Good morning, good afternoon, and good evening to everyone joining us from around the world. May is Bladder Cancer Awareness Month, an especially important time for all of us working to improve the lives of patients affected by this disease. In recognition of this month, OncoDaily is proud to host the How I Treat Bladder Cancer in 2026 virtual summit, bringing together leading experts from across the globe to share insights, experience, and the latest advances in bladder cancer care. Bladder cancer continues to be one of the most important and rapidly evolving areas in oncology. Over the past few years, we have seen exciting advances in immunotherapy, precision oncology, ADCs, and multidisciplinary care, all changing the way we approach treatment and improving outcomes for our patients. It is now my great pleasure to welcome one of the chairs of this summit, Dr. Maiti Bourlon. Doctor Bourlon is a highly respected medical oncologist, associate professor, founder, and head of the Urologic Oncology Clinic at the National Institute of Medical Sciences and Nutrition Salvador Zuberan in Mexico, and director of the Genitourinary Cancers Program for Medical Oncologists at the National Autonomous University of Mexico. Her dedication to advancing genitourinary oncology and mentoring the next generation of oncologists has had a tremendous impact both in Latin America and internationally. Dr. Bourlon, thank you so much for your leadership and for being with us today. We are truly delighted to have you open this important meeting today. The virtual stage is yours.
Good morning. It's a pleasure for me to be with you today. It's a great day for OncoDaily. Today, we are united to have the Bladder Cancer Summit, a neoplasm that has seen many advances during the last years. It is a pleasure for me to coordinate this effort for OncoDaily. We will start with a quick overview of the changes that we've seen in the landscape of treatment for muscle-invasive disease and then metastatic disease. It is also very important to mention that we have wonderful speakers for you today. We have several oncologists sharing different sessions that will provide a presentation for speakers and also will pave the brand for discussion. So at any point, be aware that you can write your questions or feedback in the chat, and we will gratefully take them into account for any discussion during the day. Thank you very much for being here, and we will start the bladder cancer discussion at this Bladder Cancer Summit of OncoDaily. So first of all, I would like to mention that still bladder cancer or urothelial carcinoma counts for many dates every year. So we know that even if many of them present in localized disease, that will inevitably recur, and still many patients would present in front line with metastatic disease. We know that many patients with localized disease will inevitably recur and will have muscle-invasive disease and metastatic disease, so it's very important to treat them wisely. Historically, we've changed the prognosis of muscle-invasive bladder cancer with the addition of neoadjuvant chemotherapy. We knew that radical cystectomy would only cure 50% of our patients with muscle-invasive disease, and inevitably, many of them will recur and develop metastatic disease. So we knew that most of us will fight enough to give these patients neoadjuvant chemotherapy because there's an overall survival advantage, and it has been tested in several meta-analyses. Nevertheless, we also know that many of these patients that undergo neoadjuvant chemotherapy will not have a complete response, and those non-responders have poor prognosis. In addition, many patients will not receive chemotherapy in the neoadjuvant setting, and many of them will still have a high burden of disease and may be amenable to adjuvant therapy. So first of all, we've seen in muscle-invasive bladder cancer the possibility of giving not only neoadjuvant chemotherapy, but also giving adjuvant immunotherapy. And more recently, we have seen many perioperative strategies, meaning that many new cancer treatments as antidrug body conjugates and immunotherapy have been implemented around this setting in the neoadjuvant and adjuvant setting, now called perioperative management. This perioperative management with new drugs has actually demonstrated overall survival advantage with the Niagara strategy with durvalumab added to chemotherapy upfront and then maintenance or adjuvant durvalumab after cystectomy. And we also know that EV-Pembro has offered a perioperative strategy for cisplatin-eligible and cisplatin-ineligible patients. So what do we know? For many years, we only see radical cystectomy. We only saw neoadjuvant chemotherapy. We also know that many of these patients could receive chemoradiation, but we know in recent years that we got approved adjuvant nivolumab, perioperative treatment with the Niagara strategy. We also saw a new biomarker ctDNA guided treatment with the tezolizumab with an overall survival advantage. And we're going to speak today a lot about the EV plus Pembro strategy in cisplatin eligible and cisplatin ineligible patients. So therefore, we're seeing new drugs. It seems that our old drugs as platinum therapy have become old, and we're reaching the overall survival boundary by incorporating new drugs in these treatment strategies. What has been happening, we knew that patients that were cisplatin eligible were traditionally treated with only cisplatin neoadjuvant therapy, but we knew that adjuvant therapy was something that could be helpful. In addition, patients that were cisplatin ineligible can also receive adjuvant immunotherapy, but most recently we also knew that durvalumab added to the conventional neoadjuvant chemotherapy with GemCis and giving durvalumab in the adjuvant scenario has an overall survival advantage. And more recently, we know that the perioperative strategy with EV plus Pembro in both the scenario, cisplatin eligible and cisplatin ineligible, confers an overall survival advantage. We also know that many of these treatment strategies are being incorporated in the radiation strategies. So stay tuned. We might be seeing a lot of news regarding these novel treatments in the chemoradiation scenario. For the metastatic urothelial carcinoma, I think we've seen a lot of changes. Many of us live with decades of only chemotherapy, just cisplatin, just gemcitabine, just vinflunine, just those Zensemivac. But after many decades, we got new drugs in the field, targeted therapies such as erdafitinib, and antibody drug conjugates such as EV and sacituzumab. We also know that immunotherapy was mandatory to be in this field as an maintenance after cisplatin or carboplatin treatment. And more recently, we know that combination therapy in the first-line treatment improves overall survival. We will review about nivolumab plus chemotherapy, which gives an overall survival advantage in cisplatin-eligible population. It's small compared to what we've seen in EV plus Pembro, but it's still worthy to mention that these strategies, both of them, have improved outcomes compared to our standard of care, which was only carboplatin or cisplatin treatment upfront. I think having new mechanisms of action, such as pembrolizumab and enfortumab, is key in order to provide the possibility of getting better responses and better treatment opportunities. And I think the EV302 study, which really stratified not only cisplatin eligible, but cisplatin ineligible patients, if they fulfill the criteria for EV, to EV plus pembrolizumab versus gemcitabine plus cisplatin, really confers a study that provided the primary objective of progression-free survival or overall survival. And we really saw key changes in this landscape. I think one of the main critiques has been that only 1/3 of patients receive avelumab maintenance after gemcitabine and cisplatin, but we really know that it wasn't Menden and it was the best possible results principal investigators could get. But I think this study is really stunning because it includes a wide variety of patients if they don't have uncontrolled diabetes or uncontrolled neuropathy. Therefore, it provides a median age about 69. Many of these patients were cisplatin eligible, but many of them were not cisplatin eligible. And we also have, heavy or high burden of disease representation, with many of them with liver disease. I think the progression-free survival curves talk by themselves, 6 versus 12 months, but it's really impressive to see an overall survival advantage of 15 versus 33 months. I think we've never seen this survival advantage before, and this is really changing the landscape treatment for patients with advanced bladder cancer. I think this is just a summary of what we were looking at. I think it's important to recall that we cannot compare across trials. But regarding a little bit of history and why we're so motivated to have this bladder cancer summit today by OncoDaily is because we can recall that 9 to 14 months was the survival that patients with hemcidamine carboplatin or hemcidamine cisplatin had as life expectancy. I really think it's important to understand that adding adult maintenance had a survival advantage, but this was only for those responders, right? Only for those that could achieve a partial response or stable disease or a complete response after platinum therapy. So we're really taking a selection of patients that are the winners, and we're not taking the whole population into account. I think the fact that we got a survival advantage with Checkmate 901, with gemcitabine, cisplatin, and nivolumab, it's really important because it speaks about incorporating immunotherapy early in the disease rather than later in the disease. But I think our primary elephant in the room today is that EV Pembro doubles the possibility of being alive. So we have an overall survival advantage of 33.8 months compared to 15 months, which has never seen before. And this is just in part because we have now targeted therapies and novel therapeutics with immunotherapy and enfortumab, which is an antibody drug conjugate directed to Nectin-4. So we have really changed, the possibility of response and survival with these combination therapies. When we've seen these combinations earlier in the disease, as I spoke for perioperative treatment, we're seeing huge responses. So I think we're really having a winner, and we're really thinking about, what's coming next. How are we going to treat patients that have progression after EV Pembro? This is a huge question. Are we going to go into a clinical trial? Are we going to expose them to chemotherapy? We'll be looking for genetic or alterations or mutations that will give targeted therapy. What are we going to do? Are we going to treat agnostic treatments? So this is really a question because we now have a good treatment option up front, where we're still thinking about what to do next. Moreover, we're using this in metastatic disease, but we're using it as perioperative treatment, and we're getting very good responses. Are we going to one day get rid of cystectomy? Is that possible? Are we going to incorporate these treatments during radiation therapy or even before having muscle invasive disease? So I think the future of bladder cancer looks brilliant. Today we have wonderful speakers talking about innovation from non-muscle invasive disease to muscle invasive disease. Then we're going to have the metastatic disease where we can talk a little bit about precision medicine, better outcomes, not only regarding, disease-free survival or overall survival, but also quality of life. And I think the most important thing is hope is increasing in our patients, and hope is increasing also in us as treating physicians. Thank you very much for this wonderful opportunity to collaborate with OncoDaily. I am sure you're going to have a wonderful day because we have wonderful speakers and coordinators that will guide you across the day for this oncology summit. Thank you very much.
Thank you very much, Dr. Mighty Boulon, for such an inspiring and an excellent opening remark. Now I suggest moving forward to our next speaker, Professor Francesco Massari. Professor Massari is an associate professor of medical oncology at the University of Bologna and consultant medical oncologist at the IRCS's Bologna University Hospital. His clinical and research work is dedicated to genitourinary oncology, with a particular focus on advancing treatment strategies for bladder cancer and other GU malignancies. Today, Professor Massari will discuss an increasingly important and evolving topic in bladder cancer care: MIBs, immunotherapy in the perioperative or adjuvant setting. Professor Massari, thank you for joining us today. The stage is yours.
Thank you very much for the invitation. Today I will discuss the evolving role of immunotherapy in muscally invasive bladder cancer, focusing on the perioperative and adjuvant settings. These are my disclosures. Over the last few years, we have witnessed a true paradigm shift in muscle-invasive bladder cancer management, moving from chemotherapy-only approaches toward the integrated IO-based strategies. In particular, we'll focus on the most practice-changing trials, including Niagara, Keynote 905, Keynote B15, Checkmate 274, and Ambassador, and finally, I will discuss the emerging role of ctDNA for patient selection. When approaching muscle-invasive bladder cancer, one of the key clinical questions is identifying the optimal radical treatment strategy. Historically, radical cystectomy has represented the cornerstone of management, but over time we have learned that local therapy alone is often insufficient because many patients already harbor occult metastatic disease at diagnosis. This is exactly why perioperative systemic treatment has progressively become an essential component of modern muscle-invasive bladder cancer management. Therefore, systemic immunotherapy has become essentially in order to improve long-term outcomes. For many years, cisplatin-based neoadjuvant chemotherapy represented the standard of care. The evidence supporting neoadjuvant cisplatin is robust, with consistent improvements in the pathological complete response and overall survival. However, despite this evidence, uptake in clinical practice remains relatively low. Several factors contribute to this: patient comorbidity, renal impairment, concerns about toxicity, and the limited magnitude of benefit perceived by clinicians and patients. This creates the perfect setting for the development of IO-based strategies. So, where are we today? Currently, we have two major IO-based approaches in muscle-invasive bladder cancer. The first is the perioperative setting with chemoimmunotherapy combination such as cisplatin, gemcitabine plus durvalumab from the Niagara study, and more recently EV-pembro from Keynote 905 and Keynote B15. The second is adjuvant setting, and in particular way with nivolumab from Checkmate 274. The field is moving extremely rapidly, and the treatment algorithms are becoming increasingly complex. Let's move now to the perioperative IO-based regimens. The Niagara study was truly practice-changing. This trial evaluated the perioperative durvalumab combined with cisplatin and gemcitabine, followed by adjuvant durvalumab after surgery. One particularly interesting aspect is the inclusion of patients with creatinine clearance between 40 and 16 milliliters per minute. In a way, this trial challenged or perhaps stretched the traditional gas criteria for cisplatin ineligibility. And this is extremely relevant in the real-world practice because many bladder cancer patients fall exactly into the borderline renal function category. Niagara met both co-primary endpoints. We observed significant improvements in event-free survival and disease-free survival, and the pathological complete response. This absolute increase in PCR was approximately 8%, which is clinical meaningful at the disease setting. Importantly, this improvement translated into better disease control overall. One common concern when combining chemotherapy and immunotherapy is toxicity. However, Niagara showed that adding durvalumab did not substantially increase treatment-related adverse events. Even more interestingly, there were no measured difference according to renal function subgroup. This is reassuring because it supports the feasibility of perioperative IO even in patients with moderately impaired renal function. These subgroup analyses are particularly interesting. Even patients with impaired renal function appeared to derive a meaningful benefit in terms of PCR and event-free survival. Again, this reinforces the idea that perhaps we have historically been too restrictive with cisplatin eligibility criteria. And now we come to what may represent the real turning point in muscally invasive bladder cancer, the combination of enfortumab vedotin plus pembrolizumab. These studies potentially redefined the entire perioperative landscape. Importantly, this strategy may work both in cisplatin eligible patients and cisplatin ineligible patients. There is also a very strong biological rationale behind this combination. Enfortumab vedotin induced immunogenic cell deaths and enhanced antigen presentation. This may synergize very effectively with the pembrolizumab by increasing immune activation within the tumor microenvironment. So the combination is not a simple additive, but it is a potentially biological synergistic. These two studies are remarkably comparable in terms of baseline characteristics. Most patients had T3 or T4 disease at diagnosis. Interestingly, around 10% of patients have variant histology in both studies, which improves the real-world applicability of the data. PD-L1 expression was also relatively balanced between populations. Keynote 905 produced a truly impressive result in cisplatin ineligible patients. The PCR rate reached approximately 57%, which is unprecedented in this setting. We also observed substantial improvements in pathological downstaging. These results strongly suggest that EV-pembro may become a new standard for patients unable to receive cisplatin. Perhaps even more provocative are the results from Keynote B15 in cisplatin eligible patients. The PCR rate approached 56%, numerically higher than what we observed with durvalumab plus chemotherapy in Niagara. This raises a major question: could EV-pembro eventually replace the cisplatin-based neoadjuvant therapy together? This is probably one of the hottest debates currently ongoing in uro-oncology. So, from a safety perspective, toxicity remains manageable and generally consistent with the known safety profiles of EV-pembro. Of course, we must pay attention to neuropathy, skin toxicity, and hyperglycemia, but overall the regimen appears feasible in the perioperative setting. These results were so impressive that they rapidly influenced the international guidelines, and honestly, it feels like we are observing a true disruption of the standard treatment paradigm for bladder cancer. This may become the future standard of care, irrespective of classical Galsky criteria. Now let's move to the adjuvant setting. The evolution of adjuvant therapy in muscular invasive bladder cancer has been quite fascinating. Initially, adjuvant chemotherapy showed inconsistent results. Then, immune checkpoint inhibitor entered the field, fundamentally changing our approach. When comparing adjuvant immunotherapy studies, several important differences emerge. The population, PD-L1 distribution, prior adjuvant chemotherapy exposure, and endpoint definition were not identically. Therefore, cross-trial comparisons should also be interpreted cautiously. Checkmate 274 established adjuvanted nivolumab as a standard option after radical surgery in high-risk patients. The disease-free survival benefit was particularly pronounced in the PD-L1 positive population. Interestingly, exploratory ctDNA analysis also suggested improved outcomes among ctDNA positive patients receiving nivolumab. The interim overall survival presented by Galsky appears increasingly encouraging, especially in PD-L1 positive patients. But perhaps the most intriguing signal comes from ctDNA positive patients. Although simple size remains relative small, the trend consistently favors nivolumab in molecularly positive disease. The Ambassador trial evaluated the adjuvant pembrolizumab. Again, we observe improvement in disease-free survival. This confirmed that adjuvant immunotherapy is an active strategy for muscular invasive bladder cancer. Interestingly, the PD-L1 subgroup findings in Ambassador appears somewhat different from Checkmate 274. Here, the relative benefits seemed more pronounced in PD-L1 negative patients. This once again highlights the limitation of PD-L1 as a biomarker in bladder cancer. And this brings us to ctDNA. Today, ctDNA probably is the most promising biomarker for patient selection in muscular invasive bladder cancer. Compared with the PD-L1, ctDNA appears far more powerful in identifying patients at high risk of recurrence and those most likely to benefit from adjuvant therapy. However, ctDNA also has important limitation. Specifically, it does not reliably detect local bladder recurrence. Therefore, ctDNA cannot replace cystoscopy or imaging. Most likely, the future will involve a two-compartment surveillance strategy: systemic monitoring with plasma ctDNA combined with bladder directly local surveillance. Urinary tumor DNA may eventually help fill this gap. So, in conclusion, current standard of care remains cisplatin-based adjuvant chemotherapy with or without perioperative durvalumab, according to Niagara. However, the future standard may very well become perioperative EV-pembro, regardless of classical Galsky criteria. Adjuvant nivolumab still represents a valuable strategy, particularly in patients PD-L1 positive, and ctDNA is emerging as a much stronger biomarker than PD-L1 for selecting patients for adjuvant immunotherapy. The optimal sequencing strategy after a revolutionary keynote and EV study is still evolving. And finally, if I had to summarize the overall direction of the field, perioperative IO appears to be outperforming pure adjuvant IO strategy. And thank you very much for your attention.
Thank you so much, Professor Francesco Massari, for such an excellent and insightful presentation indeed. It is now my pleasure to introduce our next speaker, Dr. Jordan Churo. Dr. Churo is an assistant professor of medicine and medical oncology, specializing in genitourinary malignancies at the Winship Cancer Institute of Emory University. Her clinical and research interests include personalized therapies, investigator-initiated clinical trials, healthcare disparities, and survivorship in solid tumor oncology. Today, she'll be talking about neoadjuvant strategies in muscle-invasive bladder cancer, with a focus on the latest updates involving enfortumab vedotin plus pembrolizumab. Dr. Churo, thank you for being us with today, and the stage is yours.
So, hi everyone. My name is Jordan Churro, and I'm a GU medical oncologist at the Winship Cancer Institute at Emory University. Today, I'll be discussing neoadjuvant strategies in muscle invasive bladder cancer. Where are we in 2026? All right, so here's an overview of what I'll be discussing today. I'll start with a representative case, and then I'm going to be briefly talking about why neoadjuvant therapy matters in muscle invasive bladder cancer. From there, I'll focus on Niagara trial. I'll also compare it to our historical dose-dense MVAC benchmark. And then I'll transition to EV plus pembrolizumab, including both cisplatin eligible and ineligible patient populations. I'll end with how I would approach the case today and where I think the field is heading. All right, so let's start with a common clinical scenario that we may see in our office come Monday. This is a 70-year-old male who presents with painless hematuria. He is overall quite healthy with an ECOG performance status of 1. He completes a TURBT, which does show a high-grade urothelial carcinoma with invasion into the muscularis propria, as well as 5% squamous differentiation. He completes a CT chest and urogram, which does show no lymphadenopathy or metastatic disease, and his labs are otherwise unremarkable. But however, he does have a creatinine clearance of 59. So the question is, how would you approach treatment for this patient if he walked into your office tomorrow? And more importantly, why is neoadjuvant therapy important in muscle invasive bladder cancer? So what we do know is muscle invasive bladder cancer is a high risk disease, even though it may appear somewhat localized. Despite radical cystectomy, we do have recurrence rates that are very high, often in the range of 30 to 50%. Of course, depending on the pathologic stage, nodal status, and whether neoadjuvant therapy was given. The rationale for neoadjuvant treatment is to address micrometastatic disease early in hopes to improve pathologic response, delay recurrence, and ultimately improve survival. So this is from the NCCN guidelines. These are the current guidelines-based approaches for localized muscle invasive bladder cancer. Over the last 18 months, the space has, changed dramatically, particularly when we're looking at perioperative chemoimmunotherapy as well as EV-based approaches. Looking back a few years ago, historically, we would, divide patients into cisplatin eligible or cisplatin ineligible groups. And, taking a look at this, I do think that distinction is, clinically useful today, but it does, become less central, especially with the utility of EV Pembro and when EV Pembro has been moving into earlier line management. Also, you can appreciate here that an option choice is bladder preservation and trimodality therapy. This field is also rapidly growing and evolving, but unfortunately, with my short 20 minutes today, that will not be the focus of the talk. All right, so one of the major practice-changing studies in the space is Niagara. This was a phase 3 perioperative trial evaluating durvalumab immunobased therapy with gemcitabine and cisplatin in resectable muscle-invasive bladder cancer. Patients were all cisplatin eligible. They received 4 cycles of cisplatin and gemcitabine with the addition of durvalumab, and then they were brought to radical cystectomy and then received 8 more cycles of durva. This was compared to gemcitabine cisplatin alone in the neoadjuvant setting. There were primary dual endpoints, which were event-free survival, defined as progressive disease that precluded radical cystectomy, recurrence after radical cystectomy, or death from any cause. Also, the secondary endpoints you can appreciate here were past CR, as well as overall survival. It is also important to note that they did allow split dosing of cisplatin, which we commonly do in our offices. So looking at the baseline demographics, I do want to highlight that about 15% actually had divergent histology, nearly 60% had greater than T2 disease, and actually almost 20% had creatinine clearance below 60, which appears actually to be representative of what we might see in the real world population. So I was impressed by that data. So what did we just discover? Looking at the co-primary endpoints, the addition of durvalumab did improve event-free survival. The median event-free survival was not reached in the durva arm compared to approximately 46 months in the gem cis arm. We also did see improvement in pathologic response rates, increasing from 27.5% with chemotherapy alone to 37.3% with the addition of durva. And importantly, this was not just a pathologic complete response story. Taking a look at this, overall survival also did favor the durva arm with a 24-month overall survival rate of about 82% compared with 75% in the chemotherapy alone arm. And that overall, survival signal is actually what really moved Niagara from basically an interesting study to really a practice-changing study last year. So, what are the clinical implications of Niagara currently in 2026? I think that this trial did establish perioperative chemo IO therapy as a new standard in cisplatin-eligible muscle-invasive bladder cancer. Taking a look at the patient population, it was, fairly representative in real-world practice. Also, the past CR rates did approach his historical dose-dense MVAC outcomes. And importantly, as we can appreciate, there was an overall survival benefit. And then for many of us, I do think that this was the first regimen that truly changed the long-standing cisplatin-only perioperative paradigm that we've seen for a very long time. So a very exciting time for bladder cancer. Looking at this data, that naturally, raises a question of how does Niagara compare with historical dose-dense MVAC? Of course, we don't have head-to-head trial data, so we do have to be cautious, when trying to make a statement here. But Niagara's past CR rates appear to approach historical dose-dense MVAC outcomes, and what we do know is Vesper does remain our best benchmark for dose-dense MVAC compared to GemCis. So let's take a closer look at that. So Vesper was a randomized phase 3 trial comparing dose-dense MVAC with gemcitabine and cisplatin in the perioperative setting. This trial did help establish dose-dense MVAC as a very active regimen, and historically, many of us did view it as the most effective neoadjuvant chemotherapy option, but specifically for fit patients, because as we know, dose-dense MVAC is pretty difficult to tolerate for our patients. And what we saw that in Vesper, the dose-dense MVAC actually did improve past CR rates compared with GemCis, improvement from 36 to 42%. And it also did improve a 5-year overall survival of 66% compared to 57 with a hazard ratio of 0.71. Despite this benefit, this did come with increased toxicity, particularly because these patients actually in the trial received 6 cycles of dose-dense MVAC. I also do want to highlight here that the patient population was also highly selective, with the vast majority actually being clinical T2N0, so not higher T stages or node positivity. So the question really is, does dose-dense MVAC still matter in 2026? We definitely do need to remember that Niagara did achieve similar outcomes, with a potentially more tolerable approach. But just to be clear here, we don't, of course, have a randomized head-to-head data. So I think that's just my superficial cross-trial comparisons, which I know we really shouldn't do. But with that being said, I do suspect that when the Niagara data, initially came out, that this perhaps shifted many clinicians away from using routine dose-dense MVAC. But the field has already moved beyond asking whether Niagara is enough. And the next question is, can we do better than Niagara? And that brings me to enfortumab vedotin and pembrolizumab, which I'll be referring to as EVP. So this is how I think about the emerging treatment framework. Historically, treatment selection began with asking the question, is a patient cisplatin eligible? Cisplatin eligible patients received gemcitabine, cisplatin, or dose-dense MVAC, while cisplatin ineligible patients had fewer systemic options, unfortunately. Now with EV plus Pembro moving earlier, we may be entering a period where both cisplatin eligible and cisplatin ineligible patients can receive highly active perioperative therapy. And at the same time, bladder preservation strategies are also evolving. As you can appreciate here, that is an option. But again, due to time limitations, I will not be speaking about bladder preservation or circulating tumor DNA, even though I know it's a very hot topic right now. And again, we're going to be focusing on cis ineligible and cis eligible EVP regimens. So the rationale for EV plus Pembro comes from metastatic urothelial cancer, where this combination, as we're all aware of, dramatically and change first-line treatment. EV does target Nectin-4, which is highly expressed not only in our skin, but specifically in urothelial carcinoma. And we do know that pembrolizumab does add checkpoint inhibition. This next study I want to highlight here is Keynote 905. This actually evaluated EVP in earlier neoadjuvant settings for muscle invasive bladder cancer. And again, just highlighting here that this trial evaluated the role of EVP in cisplatin ineligible patients. So what was this trial? So this was Keynote 905, also known as EV303. It was a phase 3 trial evaluating perioperative therapy in patients with muscle invasive bladder cancer who were cisplatin ineligible. Patients were randomized to either Pembro alone, followed by a radical cystectomy, and then up to 14 cycles of adjuvant Pembro, or enfortumab vedotin plus pembrolizumab for 3 cycles. And keep in mind, that's 3 cycles of neoadjuvant therapy, followed by radical cystectomy, then adjuvant enfortumab vedotin for 6 cycles and 14 cycles of pembrolizumab. This study is also particularly important because it does address a population that we know historically had very limited effective neoadjuvant treatment options. All right, so now looking at the baseline characteristics, you can appreciate that they were well balanced between both the treatment of EVP and the control. I also do want to highlight that this was a relatively high-risk patient population with about 14% of patients having an ECOG performance status of 2 and nearly 80% having T3 or T4 disease, so a little different than the previous trial we looked at. So looking at the disease-free survival, the EV and enfortumab vedotin and pembrolizumab arm did show a marked improvement with a 24-month DFS rate of 83.2% compared to 49.6% in the control arm. That equals a hazard ratio of 0.37. Looking also at the past CR rates, this was also higher in the EVP arm with a rate of 57.1 compared to 8.6 with all subgroups, obviously favoring the EVP. So these results, ultimately led to the FDA approval of perioperative EVP for cisplatin ineligible patients with muscle invasive bladder cancer in November of last year. Very importantly, even though these were impressive outcomes, the next major question was, will EVP actually provide benefit for those with muscle invasive bladder cancer who are actually cisplatin eligible? So this trial, and just highlighting here, is for cisplatin eligible patients. This is a keynote on B15 that was presented by Dr. Galsky at our recent GU ASCO 2026. So what was this trial? So this was a phase 3 trial in cisplatin eligible patients with muscle invasive bladder cancer who were candidates for cystectomy. Patients were randomized to perioperative EVP versus standard gemcitabine and cisplatin. In the enfortumab vedotin pembro arm, patients received neoadjuvant therapy followed by cystectomy and then adjuvant enfortumab vedotin plus pembrolizumab. In the control arm, patients received gem-cis followed by cystectomy and observation. And although adjuvant immunotherapy was allowed if clinically indicated. The primary endpoint was event-free survival with key secondary endpoints, including overall survival and pathologic complete response rates. And again, I just want to highlight here, when you're looking at how many cycles of EVP, you can appreciate that there was 4 cycles given here, neoadjuvantly, and then adjuvantly 5 cycles with 13 cycles of pembrolizumab. So a little bit different duration and number of cycles than what we previously saw in the earlier trial. All right, so now when we're looking at the baseline characteristics, you can appreciate here that they were, again, very, very standard in balance, again, highlighting that there was a 72% with higher T3 and T4 stages. And then also you can appreciate that the majority of these patients actually had a creatinine clearance over 60, so slightly different than our Niagara trial. So now let's look at the data. So looking at event-free survival, it was significantly improved with EVP. You can appreciate that the curves separate early around give or take the 6-month mark, and they do remain separated over time. The median EFS was not reached in EVP compared to 48.5 months in the GEM-CIS arm, leading us to a hazard ratio of 0.53. Also, let's take a look at the overall survival. So this also favored EVP with the median overall survival not being reached in either arm, but at 24 months, the overall survival rate was 86.9 in the EVP arm with a hazard ratio of 0.65. So again, very, very exciting data. Taking a closer look at the pathologic complete response rate, these results were very striking. The pass CR was 55.8% with EV plus P compared with 32.5% with GEM-CIS, leading to an absolute difference of about 23%. These were among, I have to say, the highest pass CR rates we've seen in perioperative bladder cancer, and really, I feel it was a multiple steps forward in the right direction for our field. So very, very, very exciting. From a safety standpoint, there were no major unexpected toxicities. Perioperative therapy was, feasible. It was maintained. But when you take a look at this, the toxicity profile is different than chemotherapy, so we do have to keep that in mind. With EVP, we need to pay close attention to neuropathy, rash, hyperglycemia, and of course, immune adverse events. So now, going through the Niagara and the EVP studies, as well as a historical reminder of what VESPER was and the data that came out of VESPER, I want to, come back to our case. So this is a 70-year-old male with localized muscle-invasive bladder cancer. Again, he had 5% squamous differentiation, no radiographic nodal or metastatic disease, and his creatinine clearance was borderline at 59. He is technically cisplatin eligible, but of course, I do want to highlight here that he had borderline renal function. So the question is, how would you treat this patient? Now looking at some of the neoadjuvant trials that I think are most relevant in today's practice. So, what I would recommend in 2026, for this patient, I would basically frame the options to him as perioperative gemcitabine cisplatin plus durva versus perioperative enfortumab vedotin plus pembrolizumab. I also think that, highlighting this together, that traditional cisplatin only approaches are really being challenged here, and I really think are going to become historic, such as dose-dense MVAC or just single agent or doublet cisplatin and gemcitabine. I do think that given the magnitude of past CR rates and the EFS seen with EVP, I would personally favor enfortumab vedotin plus pembrolizumab for many patients that walked into my clinic with a similar presentation. But of course, we do have to individualize and tailor our therapy at hand. Talk to the patient about his or her preference. Do they have a neuropathy risk? What is their renal function, comorbidities, surgical timing, and so on? But I really do think that EVP is a winner here. This is what I'm offering my patients, not only in frontline metastatic, but also now in the neoadjuvant setting for both cisplatin eligible and ineligible settings. And I know we are waiting for the cisplatin eligible approval, which I think hopefully is just around the corner. So what is my take-home message? I truly think that perioperative therapy is now the standard in muscle-invasive bladder cancer. Niagara, as we had spoke about previously, did establish that chemoimmunotherapy is a new benchmark in cisplatin-eligible disease. Enfortumab vedotin plus pembrolizumab, I do think is redefining perioperative management across both cisplatin eligible and cisplatin ineligible populations. But of course, we always have newer questions, unanswered questions. I've listed some of them here, which I am very excited to find out within the next couple of years. But the main questions that I have are, how long do patients need treatment for? We did appreciate that between both EVP studies, there was either 3 or 4 cycles, various adjuvant cycles, and we do know that that's a long duration of therapy. Do we necessarily need that, or can we, decrease the total duration? A follow-up question is, can we safely omit cystectomy in selected deep responders? And hopefully we have a lot of deep responders, which would be amazing for our patients. And hopefully we can avoid surgeries and, surgical complications. And then lastly, another, hot topic is how will circulating tumor DNA or other biomarkers help us really personalize therapy for our patients. So more unanswered questions, but I really think that we learned so much the past 18 months with bladder cancer. And again, it's been very exciting for not only us, but for our patients. So with that, I want to thank you again for listening to my talk today on neoadjuvant strategies. I also want to thank the sponsor for allowing me to speak at the summit. And I'm really excited to see how this field is evolving, and I look forward to the discussion. So I hope you have a great day and enjoy the rest of the talks. Thank you.
Our big and sincere thanks to Dr. Shiro for contributing to the Congress with this very informative presentation. And moving forward, I'd like to introduce our next speaker, Dr. Lola Bilmar, who is a medical oncologist and a faculty member at MD Anderson Cancer Center, whose research focuses on the genomic and molecular drivers of bladder cancer, particularly cell cycle alterations and therapeutic vulnerabilities in conventional and neuroendocrine urothelial cancer. He leads several clinical trials in early and advanced bladder cancer. His presentation today will focus on advances in research and management of small cell bladder cancer. Dr. Omar, the stage is yours.
Hello, everyone, and thank you for joining me today in the How I Treat Bladder Cancer series organized by the OncoDaily staff. First of all, I would like to introduce myself. My name is Omar Al-Halabi, and I'm a medical oncologist at MD Anderson Cancer Center in Houston, Texas. I am an assistant professor at MD Anderson, and I focus on bladder cancer. I would like to thank the co-chairs for today's event and my colleagues who are presenting in their respective talks. My focus today will be in particular on small cell bladder cancer and the advances in its management in 2026. These are my disclosures. None of them are relevant for today's talk. And these are our objectives for today's talk. First, we will try to discern and describe how is this subtype different from the conventional urothelial cancer, and what do the guidelines, specifically the NCCN guidelines, say about its management. How can we determine the risk of relapse in the localized setting, and what is our approach to the metastatic disease in the first and subsequent lines of therapy. And so to start, I would like to highlight the area of unmet need of this subtype and how it differs from conventional urothelial cancer, which you will probably hear about extensively by other speakers from today's talk. How does this subtype differentiate itself? Well, first of all, there's no doubt that the combination of enfortumab vedotin, pembrolizumab, has transformed the way we manage conventional urothelial cancer. As you can see on the left, this is the overall survival improvement in the EV-302 clinical trial comparing chemotherapy to enfortumab vedotin pembrolizumab with a hazard ratio of 0.47. On the right-hand side is data from MD Anderson showing that in this contemporary era, while patients with urothelial cancer have an OS or a median OS that's about 2 to 3 years, and that is the red curve here, the patients with metastatic small cell bladder cancer, that's the blue curve, have a median OS of less or close to 12 months. And that is reflective of the aggressive biology of this variant, and actually mirrors what's known about it in other organ sites such as small cell lung cancer, etc. If we take a step back and look at nectins, which are basically the target of enfortumab vedotin and particularly nectin-4 and their role in the urothelium, we will find that nectins are actually part of what we call the adherens junction, which is composed of both nectins and cadherins. These are strong cell-to-cell adhesion formations, and they are a function of the specialized urothelium especially the cells that face the urinary lumen. And this is particularly true for umbrella cells, and these adherence junctions, along with tight junctions, allow this barrier to face the harsh environment of the urine, and that's what we refer to as the luminal cells, thought to be the origin of what we call luminal urothelial cancer. Now, in terms of classifying urothelial cancer, there's been efforts, as you can see, on classifying it on genetic alterations and biomolecular behavior into luminal unstable subtype, luminal papillary, luminal not specified, basal squamous, neuroendocrine-like, and the stroma-rich molecular subtypes. On the other hand, there is these histological subtypes, such as the micropapillary and plasmacytoid. Those are thought to reflect a form of luminal biology. And then there are the squamous and sarcomatoid, thought to represent the basal squamous biology. And then the neuroendocrine, or the small cell histology, which is our focus of today's talk. It does carry a different RNA program, enriches for specific mutations that differentiates it from the rest of the other molecular subtypes of bladder cancer and histologies. It tends to enrich for p53 mutations, RB1 mutations co-occurring. In terms of RNA, or what we call lineage determining factors, this subtype tends to be driven by one of three transcriptional factors, namely ASCL1 or NeuroD1 or PAU2F3, and we will cover those later in the talk. But that's what these features make this subtype the unique biology that it is. Now, when we look at Nectin-4, which is the source of major advancement in the addressing or the management of conventional urothelial cancer, we will find that it correlates with the luminal subtype, tends to be low in basal squamous, and even lower or almost non-existent in the neuroendocrine-like subtype. This is a paper published by Jonathan Chu et al. From UCSF. They looked at TCGA as well as other data sets and looked at Nectin-4 expression. As you can see, the purple subgroup of this is the neuroendocrine-like, and it tends to be rare, so it's a smaller representation, but it does have a pretty low expression for Nectin-4. When we looked at the outcomes of neuroendocrine or small cell biology or histology in the era of monotherapy with enfortumab vedotin, and this was part of a collaborative study with the Unite project, which is across multiple universities and academic centers in the US, about 18 of them. We found that in a small sample, 8 patients, none of those patients responded to single agent enfortumab vedotin. And in fact, if you look at the protocols for enfortumab vedotin plus pembrolizumab, particularly the most recently published ones, the inclusion criteria for these protocols have actually excluded patients whose tumors contain any neuroendocrine component. Those were not eligible. I think with the thought that these represent probably a biology that would not be served well with this combination. So what do the guidelines say about the management of small cell bladder cancer? If you look at the NCCN, the guidelines are mostly limited to describing cisplatin etoposide chemotherapy, with few, advice on the management. So first, neurological or brain imaging is recommended for this subtype. They do describe these suggestions for pure small cell carcinoma or mixed histology with any small cell component. They even go further and say with any neuroendocrine features. They, for the localized disease setting, describe either concurrent chemoradiotherapy or neoadjuvant systemic therapy followed by local treatment, cystectomy or radiation therapy for patients with localized disease, even if it is T1 disease or non-muscle invasive disease. And we will show some data behind this. And for neoadjuvant systemic therapy, they describe the a link to refer to the small cell lung cancer, but in particular they describe an alternating doublet of doxorubicin ifosfamide and alternating with cisplatin etoposide. For metastatic disease, they also refer to small cell lung cancer or the alternating doublet as well. And so where does this data or rationale for this alternating doublet of ifosfamide adriamycin come from? This goes back to the early 2000s in a small prospective study that was run out of MD Anderson, thinking that these tumors tend to co-occur with conventional urothelial cancer. It's rare that they are pure small cell. It's only about 15 to 30% of these small cell patients that will have an isolated small cell component. Most of the time it's mixed with urothelial cancer, and the idea was that ifosfamide adriamycin are regimens that could cover the coexisting urothelial cancer, and sometimes these tumors also coexist with other subtypes such as sarcomatoid and more aggressive biologies. So ifosfamide adriamycin is an intense chemotherapy. It has its established role in sarcoma, and that would cover this non-small cell component. And then the cis etoposide has a track record in small cell lung cancer, and it would be an alternating doublet as described here with about 4-day chemotherapy for IA and 5 days for EP. This study in the phase 2 setting for 18 patients showed in the neoadjuvant cohort showed a median OS of 58 months and a 5-year overall survival of 80%, specifically for the patients that were T2. Now we expanded on this dataset and we looked at retrospective experience with patients that were getting cis etoposide by itself or the alternating doublet, about 60 patients versus 40. We also looked at some patients that received MVAC or gemcitabine cisplatin and other chemo regimens, and compared the outcomes of those patients to patients that were taken to upfront radical cystectomy and then received therapy on the back end as an adjuvant therapy. What we described in this analysis was the chances for accomplishing pathological complete response with these different chemo regimens, and also what was the residual disease component at the time of cystectomy. As you can see in the top chart, patients that did not receive neoadjuvant chemotherapy, the 62 patients, had almost 80% chance of identifying neuroendocrine carcinoma at the time of cystectomy. A very small minority of them, about 15%, was accomplishing PT0 or PTIS just from the TURBT itself. But when we, it broke down the outcomes for accomplishing PT0 versus residual neuroendocrine carcinoma or urothelial carcinoma by the different chemotherapy combinations. In general, these regimens had overlapping outcomes with the chances of accomplishing PCR that ranged anywhere from around 25% to 60%. The regimen that had the highest association with PT0 was IAEP, and with EP being the next regimen in terms of success of achieving PT0, around 40%. The advantage that IAEP seemed to have had, it was in eradicating neuroendocrine carcinoma, with only 20% patients had neuroendocrine carcinoma at the time of cystectomy left, or urothelial carcinoma, and that was less than 20% as well. When we looked at survival, we found, and this was described earlier by our group as well, that patients that received neoadjuvant chemotherapy had accomplished a significant survival advantage to the patients that were taken to upfront surgery. Unfortunately, patients that had adjuvant chemotherapy did not do as well. They do slightly better than patients that had upfront surgery with no adjuvant chemotherapy, but not as well as the patients that have neoadjuvant therapy. Even though this is retrospective data, but it is the best we have at the moment to justify neoadjuvant chemotherapy over adjuvant therapy, and this suggests that small cell bladder cancer is an early systemic, it has an early systemic spread disease pattern. Now, we had a follow-up paper focusing on the T1 patients. As in the previous analysis that I had shown, it was T2 patients up to T4A, but we also reviewed the patients that were T1. Specifically, they had lamina propria invasion, but muscle was present and not invaded. And we found that these patients do better also with neoadjuvant chemotherapy compared to not. Small sample size. It was 30 patients, but nonetheless, this is the only available retrospective analysis on T1 patients to justify systemic therapy. Now, what are the determinants for relapse and what seems to be a prognostic, poor prognostic marker for disease relapse in this histological subtype? We reviewed the patients that have had mixed tumors and compared their, throughout their journey, the presence of this mixed histology from the TURBT specimen to the time of cystectomy, and then correlated that with the risk of relapse or not. And what we found in this analysis, and this was a cumulative incidence function, as you can see on the left side, the patients that had the lowest incidence for relapse were these patients that were in the purple line, and these are the patients that achieved PCR after neoadjuvant chemotherapy, and followed by patients that achieved PCR after TURBT, so they achieved PCR but without getting neoadjuvant chemotherapy, and that's the olive color, followed by patients that had minority small cell, followed by patients with predominant small cell, and the patients that seem to have an almost 80% relapse rate within the first 24 months, where the group of patients with small cell only at the time of cystectomy. And this type of breakdown, or the performance of looking at what is the residual histology at the time of cystectomy after neoadjuvant chemotherapy, seemed to separate patients in a better way than looking at the conventional way we look at stage. Nonetheless, patients with node positive or T2 or greater, they do have an escalating rate of relapse, and this is the traditional way we stage patients for urothelial cancer, but also the actual histology that is remaining at the time of cystectomy seem to also differentiate patients that are at risk of relapse. The unfortunate reality of this disease is that majority of the time the relapse is distant. In about 84% of patients, they had a distant recurrence, either distant by itself or local plus distant, and these statistics argue against the utility of adjuvant radiation after cystectomy. Majority of patients are not really relapsing within the lymph nodes of the pelvis, but rather they are relapsing in the liver, lung, bone, or even in the brain in 10 patients. We described at ASCO GU this year the genomic profile of patients that had developed brain recurrences versus those that recurred but in sites outside of the brain, and we find this preliminary signal of association with PI3 kinase alterations and enrichment for an earlier relapse within the brain. This is an early signal, but it is among the molecular markers that we are studying further to assess its association with poor prognosis in this rare disease. Now, moving on to the approach for treatment in the metastatic disease space, we had already covered the localized disease space and the determinants of disease relapse. In terms of first-line therapy, the SWOG group has an ongoing trial that's almost finished with accrual, which is a randomized study comparing first-line platinum etoposide with or without atezolizumab for patients with extrapulmonary small neuroendocrine carcinomas, and they are studying within this trial bladder small cell cancer. This is a study trying to validate if atezolizumab can help the survival outcomes of these patients, just similarly to how it, atezolizumab or durvalumab or other checkpoint inhibitors have improved or provided an incremental benefit in survival in metastatic or extensive stage small cell lung cancer. So is this applicable to extrapulmonary small cell? This is the question that this trial is trying to address. Some people would follow that approach and hold off on recommending adjuvant or additional immunotherapy unless that trial results. However, there are also a different school of thought. There are the early adopters from what is showing benefit in small cell lung cancer. So the most recent study, which is the IMforte clinical trial, using atezolizumab plus carboplatin plus etoposide for 4 cycles, and then patients that do not achieve or do not progress during that induction phase go on to maintenance lurbinectidine plus atezolizumab versus atezolizumab. And lurbinectidine is a newer type of chemotherapy added to atezolizumab, with the thought that patients that responded to chemo likely overlap in their responsiveness with lurbinectidine, and those that would have primarily progressed on chemotherapy will likely have a primary overlap with progression on lurbinectidine. And so using lurbinectidine here to enhance the maintenance of atezolizumab. And this study was also published in Lancet last year, showing improvements in PFS as well as OS compared to maintenance atezolizumab by itself. The hazard ratio for PFS was 0.54 and for OS was 0.73. And so this combination as maintenance is FDA approved for small cell lung cancer, some would extrapolate these results and apply them to small cell bladder cancer, given that the NCCN guidelines actually refer to the small cell lung cancer for management frequently. It references it often. Now, in terms of approaching the disease in the second line setting and what to do beyond platinum and etoposide, this is a nice review of the literature by the group led by Andrea Apollo at the NCI. They looked at what's currently approved in small cell lung cancer in the second line setting. They describe tarlatamab, which is a bispecific T-cell engager targeting DLL3. This was approved based on the Delphi 301 trial, 40% response rate, OS of 14 months, and PFS of 5 months. They describe different doses, etc. And they also describe in this table here lurbinectidine, and it is a newer type of chemotherapy, focuses on RNA polymerase II degradation and DNA damage, as well as the older approach, which is topotecan. And this was from a study looking at topotecan versus CAV chemotherapy, showing comparable effects with an ORR of 25%. Now, to understand tarlatamab in a better detail, the small cell lung cancer group had divided this disease into four different molecular subtypes, including the A subtype, P subtype, N, and I subtypes, and looked at their outcomes with immunotherapy, showing that the I subtype, which is I referring to inflammatory program, it has an immune gene program enrichment. They had the best outcomes with platinum plus etoposide plus immunotherapy, but then they do describe other subtypes that the P subtype, for example, is driven by the PAU2F3 program, and this is the group that did the worst. Neuroendocrine genes were broken down into N, or the NeuroD1, which is this synapse type of subtype, and described as N, and A, which is the conventional or traditional, the most common subtype, which is a true neuroendocrine program, and that's the A subtype. And a similar effort was done in bladder cancer by the group at MSK, and to simplify this approach, they use IHC and found that in general these are mutually exclusive IHC stains, so they stained for ASCL1 to represent the A subtype, and in NeuroD1 to represent the N subtype, and PAU2F3 to represent the P subtype, and in general these tend to be mutually exclusive. They do show, similar to what the lung small cell group had shown, that the P subtype correlated with the worst outcome here, with portrayed in orange and red on the left side. Now, DLL3 seems to be expressed across A and N subtypes, but the P subtype did not seem to have high DLL3 expression. And there's a biological rationale behind that that I will not be covering in today's talk. In our practice, and there's many different ways of describing this, but there are NGS panels that are describing or can issue an addendum that describes the subtype of small cell, and we find there is a correlation between these subtypes and DLL3 staining. A subtype correlates with, and N subtypes both correlate with DLL3 positivity in IHC, but the P subtype tends to be DLL3 negative. And this is just a case example of the use of tarlatamab, which is again an extrapolation from small cell lung cancer, but it is out of the extrapolation that is mentioned in the NCCN to refer to the small cell lung cancer guidelines. This is a case of a patient that had, and this is an example of a pelvic recurrence after cystectomy, and despite receiving IAEP neoadjuvant chemotherapy. Tarlatamab, just as a reminder, is a bispecific T-cell engager that binds to DLL3 as well as CD3 on T cells and engages the T cells to attack the tumor cells. After 2 cycles, he achieved a complete imaging response, as well as complete molecular response with eradication of MRD. Similarly, we have used tarlatamab in a few cases that were subtype A and DLL3 positive on IHC, and we do see responsiveness to this approach. In summary, small cell bladder cancer is rare and often mixed subtype. Unfortunately, majority of the data is retrospective. Outside of the one prospective study with IAEP at MD Anderson, all the data that I presented is retrospective. The workup for these patients includes cystoscopy, TURBT, CT, brain imaging, and there is a growing role for PET scan. For the localized disease setting, systemic chemotherapy is the primary therapy, and then consolidation with surgery or radiation is both proposed by the guidelines. In terms of advanced disease, majority of the management is derived from small cell lung cancer. However, enfortumab vedotin or targeting Nectin-4 does not seem to be effective in this subtype. And thank you.
Thank you very much, Dr. Amar, for this insightful presentation. And we now move on. We're pleased to welcome our next speaker, Dr. Elena Kremer, who is a clinical oncologist at Oncologia Rededor and Clementino Fraga Filo University Hospital, Federal University of Rio de Janeiro. She is head of the Oncology Infirmary at Clementino Fraga Filo University Hospital and Rio de Janeiro hub leader at OncoDaily. She'll be speaking about elderly and frail patients personalizing bladder cancer treatment.
Hello, everyone. This is Elena Kremer. I'm an clinical oncologist at Oncologia and clinical oncology in the University Hospital of the Federal University of Rio de Janeiro. And I'm honored today to speak about the elderly and frail patients who are to receive bladder cancer treatment, being part of this amazing program that OncoDaily has designed for how we're treating bladder cancer as of today. Let me get this. For this presentation, my conflict of interest is that I'm a speaker for AstraZeneca and Servier. Well, why does it matter that we talk about bladder cancer in the elderly population? Well, bladder cancer incidence increases with age. Most patients we diagnose are 60 or 70 years older. And about epidemiology, 3 to 1 male predominance, a median age of diagnosis 73 years old. And they usually come with other clinical comorbidities like some sort of dementia, hypertension, diabetes, decreased renal function, and polypharmacy. So it is a multifactorial a stage for making the approach to these patients more challenging. And why frailty matters in bladder cancer, and well, it's because we're talking about bladder cancer, but I would say for cancer as a whole, it affects up to 40% of cancer patients, which is a lot, and especially because of those comorbidities and the median age of diagnosis in bladder cancer. It's a strong predictor of outcomes than chronological age alone. You can have a 75-year-old who's completely different shape and frailty level than another 75-year-old. It obviously impacts our clinical decision on how to treat. The frailer the person is, less aggressive we tend to be, and it also corresponds and correlates with survival. And frail patients often experience a reduced quality of life due to the treatments that we put on them, plus their comorbidities and their limitations before they arrive to our oncological appointment. So we have several scores. Geriatrics in general, like all over the world, have developed several scores for dimensioning and further scrutinizing the frailty risk of the patients. There is this hospital frailty risk score from Germany, which divides patients into 3 risk categories: low risk, intermediate, or high. And it is validated for predicting adverse outcomes, including prolonged hospitalization and mortality, but also side effects from treatment. And we can see in here, I have to keep moving the camera around, sorry. We can see here that we have the low risk population, which is the lowest of the proportion of all people. Second, intermediate risk, and we see the bulk of the population that we treat is of high risk. So that is not unimportant. There is this German study with patient demographics. It had a very big cohort of almost 50,000 patients with elderly people with bladder cancer in age 72 years old, which is in accordance to what we saw before, as well as the male predominance. And they use this cohort to make the baseline, to assess the baseline frailty of these patients using the score. And so in black is the age distribution, and in blue the frailty, their basal frailty. You see that, well, sometimes age isn't enough, which is basically what this graph is saying, right? So you have a basal frailty much higher in the 65, 69-year-old population than you have in most elderly people, which of course can be at expense of a number of patients in the study. There are other limitations, but just so we know that not because someone is 75, they're worse off than someone who's 65. And while they analyze frailty trends over time throughout 2016 to 2022, the low frailty proportion increased slightly, while intermediate frailty decreased, and high frailty remained stable throughout the period. This is a graphic through showing the low frailty. You can see that it's kind of stable, which maybe can translate to better care to our older population, right? And better control of other comorbidities. But we can't know that for sure. That's just an inference. So systemic therapy that we can use in some patients, well, we have increased the use of the systemic therapy between those years. And we have seen gains for low frailty patients. Intermediate frailty patients show decline rates, and while high frailty patients remain stable. So we're treating slightly less those of intermediate frailty. High frailty, I think everybody, well, not everybody, but mostly people tend to judge that you don't really go as hard with systemic therapy, right? But for low frailty, it has impacted with more people being submitted to systemic therapy path. About surgical interventions in frailty, while frailty rates declined slightly. Radical cystectomies pretty much the same. We have an increase in robotic assisted cystectomies with the popularization of robotic surgery. Well, it's kind of, well, everything remains sort of stable during this study. So this turbid is just like our go-to for localized disease because it's less, well, aggressive than going to radical cystectomy, either for video laparoscopy or robotic. We know that it is a lengthy surgery. It's many complications in the post-operative. Normally, us oncologists don't like to do that. The surgeons don't really love doing it. So we tend to be less aggressive when it comes to surgery. About clinical outcomes regarding with frailty. So I think the main phrase and line here is frailty significantly impacts perioperative outcomes. So the less frail you are, the better your comorbidities are controlled, the better you have your results. So in terms of complication, quality of life, hospital admittance, and death. And well, we have a clinical scenario. This is well, while we discuss treatment, right? I've had the patient, 70-year-old male. He had an intermediate frailty score, ECOG PS2. He was diabetic, but very well controlled, no insulin use. He had a regular kidney function and hypertension under control with medication. He had metastatic muscle-invasive bladder cancer with metastasis to the lung, lots of metastasis in the lung, but overall low burden disease. And since it's been approved, we considered, along with the family, to start EV with pembrolizumab instead of just going to supportive care and see how it went. This patient didn't really have a geriatric to accompany him, but had a cardiologist, which sort of well organized the clinical comorbidity scenarios for us, which makes, of course, the oncologist's life a little easier. And this is interesting because the EV302 trial, when you do enfortumab vedotin with pembrolizumab versus the platinum-based chemo, which was the best of care until very recently, we know that it's a great drug, it's very well tolerated, not many toxicities, and intermediate frail patients can't stand this treatment. And basically, about enfortumab vedotin, pembrolizumab comes with all the effects of immune events that we are very aware and very accustomed as of now to deal with those. There are a few effects, especially I think I would say skin lesions that can become like a Steven Johnson. So you have to be very careful about the skin. But other than that, patients are tolerated quite well. And well, a practical approach, right? We're in our private practice or hospital practice, and we have to do a frailty assessment. If we don't have a geriatric with us to help us with that, we know we have many patients and time is of the essence, so we can, of course, the best it would be to use the comprehensive geriatric assessment, but we can sort of minimize these and maybe jump to simpler questions to sort of evaluate how independent this elderly person is, and maybe we can understand how frail they are. And it is very important to emphasize that a multidisciplinary tumor board would be the best for those patients because of the need of evaluating the multiple comorbidities and social security net and everything. And I think for take-home messages, well, a frailty assessment nowadays is absolutely crucial for treatment decisions because we cannot base our oncological decisions anymore on chronological age alone, because alone it doesn't mean anything, and we need different tools to help us guide which is the best treatment we can give our patients so they can prolong OS and have a quality of life and, just live better. After all, our jobs are as doctors is to everything that we do, we must improve the patient and not make the person worse. So everything we can do to improve it, we must do it. Emerging therapies such as EV with Pembro changed the landscape for bladder cancer because it's a very well tolerated therapy with great results and much, much less toxic than platinum based chemo, doublet chemo. And of course, you have to tailor and individualize your treatment approach, always balancing the quality of life and the response that we want to have for this patient, talking with family and other people in the support net. So this is the goal and the destination of oncologists, tailoring and individualizing patient care. These are the references, and I would like very much to thank you for the opportunity to talk about it. I think it is very, 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 very important. In my day-to-day practice, I see more and more people over 65, 70, 75, 80, 85 years old who are, you would think that 85 is like, oh my God, no, we cannot treat this person. She's too frail, he's too frail. But when you assess it, it's not like that. and we can give options, especially with the newer treatment. So we do have to have this analysis thoroughly made and conducted so we can make the best decision for the patient. Thank you very much.
Our big thanks to Dr. Kromer for this informative and engaging presentation. And up next, we are very happy to welcome Dr. Jay Rao, a Vice Chair of the Department of Pathology and Laboratory Medicine and Chief of Cytopathology at UCLA School of Medicine. His work focuses on cancer biomarker development, liquid biopsy, digital pathology, and AI-driven diagnostic technologies. His talk will focus on urine biomarkers for bladder cancer diagnosis and management.
Hi, everyone. My name's Jen Rao, and today I'm going to talk about urine cytology, how to use in managing bladder cancer in today's age. I'm a cytopathologist and a director of cytopathology here at UCLA. And thank you for inviting me to join this OncoDaily webinar. So I have three objectives on my presentation today. The first is to very briefly review some of the basics of bladder cancer and specifically in relation to urine cytology. And secondly, I want to introduce to you our standardized reporting system, which is everybody using now, called Paris system, which is now with version 2. And finally, I would take a little bit time to talk about biomarker testing in urine cytology, which has been a topic for many years. So first, talk about the basic concepts. I don't have to remind everybody here that bladder cancer or urothelial cancer, we like to call, is actually a failed disease, which means that it can derive from the entire low urinary tract, which is renal pelvis, ureter, bladder, and part of the urethra. And the urine sampling actually provide an advantage to sample the entire area. Urothelial carcinoma, which is most common cancer type in the low urinary tract, and the number is close to 400,000 new cases per year, with about 150,000 deaths worldwide. As you can see, this is a very old paper from 2003. It's one of the health economic studies that I always like to cite. I'm sure the number is different now with all the new development of targeted therapy and all that, and immunotherapy. But I think that the trend still holds. So what that means is that at least in this country, the cost per cancer patient from diagnosis to death, the urothelial cancer is one of the highest. Back in the 2003 is about 10 to 20, 100,000 to 200,000. I'm sure the numbers increased by now substantially. I like to always remind my trainees about features of urothelial cancer that is very critical to keep in mind, especially when you look at the cytology. First of all, as I alluded earlier, that urothelial cancer is a failed disease. So what I mean by that is that there's a multiplicality, there's also very high recurrence rate. So it's not uncommon to have bladder cancer that was removed by TUR or by cystectomy, but then later on, there's cancer developed in the upper tract, like renal pelvis or ureter. So that's one thing that we like to categorize the disease as a field disease, and we do have quite a bit of biomolecular studies to understand the mechanisms related to that, which I don't think I will have time to get into. The second thing that is very critical to keep in mind is that low and high grade tumors are quite distinctive. The distinction can be made in the molecular pathways, in clinical presentation, in terms of management, and finally the outcomes. In other words, in many settings, a low-grade tumor I will hardly call invasive, especially muscular invasion, just not biologically make sense. So that's one thing that is very different from other cancer types that we typically see. And finally, there's another important thing to keep in mind is that carcinoma in situ is considered by many as a high-grade lesion rather than precancer lesions. So that's a very different from other cancers that we typically talk about, like cervix or breast or other disease process. And this picture came from my mentor, who is a urologist, and I still respect him quite a bit and talk to him every other week almost. And he's retired now from the chair of urology at Nebraska. His name's George Hemstreet. So when I first came to this country in '87, he gave me this picture and say, just keep that in your correction because you probably have to use it. And indeed, I'm still using it today, almost 40 years later. So what means, tell me about this picture is that on the left side, which you can see on this cystectomy specimen, there are populated tumors obviously easily seen by cystoscopy, which the problem is, even though it looks very nasty and, very multiple focus, but the matter of fact is that you can't tell by just look at the histology whether this is low grade or high grade, but it's definitely tumor involved, the bladder. On the right side, it looks very reddish, and the entire bladder looks very red. Now, the question is, can you tell is this just the just the cystitis or inflammatory process, or could this be carcinoma in situ? You can't tell. So this is the two types of clinical presentations that we typically talk about, papillary lesion and flat lesion. The flat lesions, you cannot tell by cystoscopy whether it's benign inflammatory process or malignant in situ or even invasive process. So that's one thing that I want to highlight here. And also from this picture, I highlighted the distinctions between low-grade and high-grade tumors in terms of the molecular pathways. The low-grade tumor typically don't involve p53, while the high-grade tumor typically involves. Now, the main question that I already talked about earlier is that the difference between low and high-grade, we think they are distinctive disease, but the problem that we have here is that if they are all low-grade tumor that don't have any potential to become high-grade, then you can forget about it, in terms of at least in pathological or cytological setting. But unfortunately, a small portion of the low-grade will become high-grade. Now, the question is, what percentage of them will become high-grade? Progress, in other words. We in our experience, I think it's around like 20 to 30%. I'm not sure about yours, but if you look closely the guidelines, the Paris system is typically defines that as less than 10%. I'm not sure if I agree with that. I think it's probably around like 20% in my own experience. Now, this is also a very old slide, but shows you the importance of combining cystoscopy and urine cytology together in managing bladder cancer or urothelial cancer in general. Again, from that picture that I showed you earlier, the cystoscopy can easily identify papillary lesions. The problem is that you can tell is at low or high grade by looking at just the grossly. The cytology, on the other hand, is very good on picking up the flat lesions which can be missed by cystoscopy, and that the flat lesions can be either high-grade urothelial cancers that are invasive, or what we call the carcinoma in situ. So the point here is that combining those two, it covers quite a big spectrum of urothelial carcinoma, and that's why we need to use this, complementary. And unfortunately, I have to say that in many countries, except I think US, cytology is a very common practice. But if you go to other countries, especially less developed in terms of medical care, countries that don't have cytologists in the hospitals, they don't perform urine cytology at all, and very few of them do, actually. This is unfortunate because the cytology of urine is probably one of the easiest, simple tests that one can do. And they are, like I mentioned to you, in addition to be very easy, there's nothing more convenient than correct AP, right? The important is that it has the ability to sample the entire field. Again, the field disease problem of the bladder cancer, urothelial cancer. So all the way from renal pelvis to urethra. And typically people against the cytology say that because it's not a very good test, but that has to be looked at closely, carefully. If you look at the high-grade tumors, the specificity is extremely high. In other words, I call cancer if I have enough cells and enough morphology, and this specificity is more than 98%. In other words, if I call cancer, I like to have my urologist look very carefully, and even you don't see it in the bladder, you have to go up track because the false positive rate is extremely low. It still happens. I can tell you later, what causes of that. But the problem is sensitivity is around like 70% because simply that sometimes you don't get the cells into the urine, and that makes the sensitivity a little bit low. But in general, for high-grade tumors, it's pretty good test with this kind of sensitivity and specificity. The low-grade is different story, okay? So totally different story. So the cytology can be challenging, as you all know, because of degenerative changes, because a lot of things can cause cells to look a little bit bizarre, because it just cannot detect low-grade tumor for sure, because the definition of low-grade is have very minimum cytological atypia. And on top of it, there are always therapeutic changes, viral changes that can cause, very difficult for us. So quickly about how to process the specimen, we usually recommend to immediately fix the specimen. If not possible, then at least put it in the 4-degree refrigerator. If the specimen is delayed for over 24 hours, then we recommend just adding equal volume of 50% alcohol. So it's very easy to do. That can help to stabilize the cells for about 2 weeks for not a problem. So when we get the specimen in the lab, nowadays we don't usually use the smears anymore, which is a very old technique. Now everybody uses something we call liquid preparation, liquid biopsy, or not liquid biopsy, liquid preparation, LBC. That helps to make the cells more morphology, more standardized. And the other big advantage of doing this is that, especially in today, that we can do immunostaining on top of it, and also do digital AI studies easier than the conventional smear technique. So the liquid preparation is recommended. In terms of the adequacy, which I will talk about in probably a little bit more later, the PERS system, which is standardized reporting, defined adequacy quite kind of like subjectively, but I think it's very useful in a way. Um, so for watered urines, anything that above 30 cc is what we require. It doesn't matter how many cells you see on the slide. But for the instrumented, we require about 2,600 cells, which means that so for 10 high power field, every 10 high power field, you have more than 2 cells on that, so that we adequate. 2 epithelial cells or urothelial cells. Okay. Now, even though you may not have that number, or if the volume is small on the body urine, if you have any atypical cells, then you can define that as inadequate, right? So, and also, even though you may have enough cells, but if the specimen is very bloody and a lot of lubricants, then you can still call it inadequate. So that's the kind of the broader definition of the adequacy. We like to always get your help to get in all the information we can to interpret the specimen, because they make a huge difference. Especially like, for example, whether this truly watered urine or bladder irrigations or instrumented, because the criteria for calling inadequacy is totally different, right? So that's one thing. And also, I like to see what you see on the cystoscopy, because, for example, if you actually see papillary tumor, but my morphology looks totally negative, then I will put in the category so-called negative or high grade, but cannot rule out low grade, something like that. The history is very important, especially in terms of treatment. And this is related to, especially BCG, chemo, or even like kidney transplants, those kind of things that can be very helpful for us. So the false positive can still generate by this kind of different causes, but again, in general, we do have a very high false positive rate. It's usually less than 5%. And you can still cause problem because especially like some therapeutic changes and especially the viral change that I will talk about a little bit later. So degenerative changes are number one enemy because, they can make you a little bit nervous. The trick here is that we always tell our residents or fellows that don't spend any time to look at these degenerated cells. However, if you see a lot of degenerated cells, be careful. There may be tumor hiding there, right? So kind of like a paradoxical issue. So the degenerated cells can be defined by looking at cytoplasm. There's like this kind of granules, and the chromatin looks very dark, but then fragmented. So then you can stay away from that particular cells. This is the base that sometimes cause problem, the polyoma virus. They can very much mimicking the cells, what we call the decoy cells or coy cells, the carcinoma in situ, because they're very high NC ratio, very dark chromatin. The trick here is that the chromatin pattern is very ground glass, very uniform. So then with that, you can call, polyoma virus. Problem is that we see cases that are, high grade, but also have virus on top of it. That makes things more difficult. BCG therapy is one of the most difficult areas because it causes a lot of changes that can mimicking, especially, a bigger nuclei, very smudgy nuclei, smudgy nuclei. So in general, though, the NC ratio is preserved, and there's not much irregularity of nuclear membrane. But again, this is a area of challenge that we typically face in terms of interpretation by morphology. So very quickly about the Paris system. So in order to standardize the reporting of urine cytology, and there's a group of people from around the world that led by Dr. Lawson, who again was my mentor at UCLA, but then she went to Hopkins, and she led the effort, with a group of urologists and cytologists, and to come up this system, which is very much mimicking the pap smears of the cervical cancer screening, except, this is, I think, a little bit more defined in a way. So this is the first version, which I'm not going to spend time to. So there's like 7 categories. Each has the recommended follow-up, and based on the risk of high-grade malignancy. For example, if you call it typical, you recommend either repeat use ancillary testing or use a repeat urine sample, correcting for ancillary testing. And the risk of malignancy for high grade is 8 to 35%, something like that. So this is the first version, but you notice that there's a problem here. I think even this um, the big issue is the low grade. They put in category 6, which has high, risk of 10%. It's almost like a negative, right? So that's why, they modified this into the second version. And the other thing that really I like this system is that there's a very well defined, quantitative criteria for each category. Like for a typical cells, what you need is that you have cells with NC ratio about 0.5 with one additional criteria that we see in that particular cells. And that's different, when you have NC ratio above 0.7 and hyperchromasia plus one of the other two, then you call suspicious. So there's a very well-defined criteria. Whether that criteria is really, really solid, that's a different story, but at least something that we can use to make it standardized. And if you have more than 10 suspicious cells, then you call, all right, high grade. The problem again come to the low grade, which I'm not going to talk about because this is the old version. So the new version basically take away the low grade category and the criteria remains the same and it's defined with several major improvement. One is, like I mentioned to you, you don't have low grade anymore. So what happens is that if you're really concerned about low grade, you can put that into category 2 because the risk of high grade malignancy they define as less than 10%. So what you can say is that negative for high grade but cannot rule out low grade. So that makes much easier for us to use and make much better sense as well. The other thing that really helps quite a bit is adding a typical squamous cells category because in the old days, you may just look at the urothelial cells, but a lot of times urothelial cell cancer typically have squamous metaplasia, squamous component, and you may only have a typical squamous cells on the urine specimen. So adding this is tremendously helpful. And the other thing that really helps with this new version is that there's a lot of discussion about upper tract cytology, which helps to define the criteria a little bit because obviously the upper tract has a little bit more challenging because of the cellularity and other things that are going on with the upper tract. And finally, the polyomavirus issue. In the old version, they said if you see polyomavirus, you can call always negative. But unfortunately, we miss tumors based on that because I mentioned to you some of the high-grade tumors may have polyomavirus infections on top of it. So you can still call AUC atypical even in the setting of polyomavirus. So that's an updated version that we have been using for the last couple of years, and I think this is very, very helpful. And quickly about correlations between cytology and histology in general. Anything, so this is first the slide shows the correlations in the setting of papillary tumor, which is non-infiltrative. If they have papillary tumor by histology, typically can be anywhere from papilloma all the way to high grade. For anything below low grade, it can be negative. But in the setting of dysplasia or low grade carcinoma, sometimes you do get up to the typical, even suspicious category. But in general, they can be totally low grade. But only thing that can be consistent is the high grades. That if you call high grade on cytology, in general, that you always have follow-up tissue that shows high grade or CIS. The infiltrative lesions, in general, are also very well correlated, and it depends on which divergent types. That sometimes you do have different features, but in typically we don't give a additional sort of like description about which type of tumor that you're looking at, except sometimes if adenocarcinoma, that I can make a call, I can say high grade with features of granular differentiation on cytology, because that can be stand out quite nicely. So quick summary about cytology. The first thing about cytology is that it's a very useful. I want to make sure you understand that, especially for high grade tumor, but it may not be able to distinguish invasive from non-invasive. By itself, is not a good test for low grade, and parasystem is very good for help us to standardize the reporting. So the next 5 minutes, I'm going to talk about biomarkers. Again, I told you that if you combine cystoscopy and cytology, we can manage to diagnose bladder cancer or urothelial cancer quite well, and we don't really need much help. However, as I mentioned to you, there are problems on each. Cystoscopy is not something that people like to do because the kind of invasiveness, and cytology in general, even though it's good for high grade, but still have little bit, false negativeness issue, which is about 20-30%. And also, it's just not good for low grade. So if anything helps us on that end, that would be great. So this is just a table from my recent published paper about, all the markers that we evaluated, and there are many, many. Okay, so I won't have time to go over each one of them, but in general, there are three categories. One is the dipstick based, the other is cellular based, and the other is like a molecular testing, and including proteins. This is the picture that I also like to highlight. We have been working on this earlier, ever since 80s, and I worked closely with my mentor, who again developed this technique called quantitative fluorescence image analysis. And long story short, this is the system that I came in the 80s, that really, really, it was quite sophisticated even back then. We can do multicolor fluorescence analysis on the tumor markers, but the problem back then is that marker of selection is very limited. But with that technique, we analyzed a lot of molecular changes in the tumor cells and even non-tumor areas that adjacent to tumor, and have a concept of what we call the molecular field disease process. And more importantly, we also developed a panel of markers that used to screen people with high risk, which we did in the 90s in the high risk cohort, and it generated from this study a very interesting um, um, testing marker called U-site. I don't know how many of you heard about it, but unfortunately, even though it's a very good marker for which included an antibody developed by Dr. Fadet from Quebec, um, the problem with that is that the agent is no longer available. So even though I think this is a very good test, which we have used in the clinical setting for many years, but now it's not available anymore. So I'm not going to talk about it. But the only thing that we have left is the FISH. So the FISH is targeting multiple chromosomes from 3, 7, and 17, and 9p21. So there are 4 chromosomes targets that we are analyzing. And this is what we see here, particular cells that has different colors. And if you look at the red, there's total about 7 dots here. So that means there's chromosome 3 amplifications going on. And then green is about 8, which is chromosome 7. And then aqua is the 17, which is where 53 is located. And then the only thing that it seems to be normal is the gold, which is a P16 is located. So this is not a lost or gained. So you think that would be easy, right, to look at that. But problem is, how do you define positive? So you have to look at a certain number of cells, and this is very complicated. I don't want to get into it. And the bottom line is that you need a minimum 25 abnormal cells to make it a positive. So it's not an easy test to really evaluate. And the studies showing that sensitivity compared to cytology is drastically improved in the early studies, but then later studies shows less kind of like big difference, which is typical, right? And then specificity, again, early study shows much big difference compared to cytology, but later study shows not so much difference. In our hand, I think we still use that, and especially to triage atypical urothelial cancer, atypical diagnosis categories in the urine cytology. The, with the caveat that negative FISH does not rule out the presence of cancer, and in general, it's not a good test for low-grade disease. So that's pretty much about FISH. And quickly, I would talk about the AI and machine learning. And we do work with a company called Morphogo, which developed this digital-based AI machine learning algorithms to detect urothelial cancer. I won't get into the details, but the preliminary study just published a few months ago shows that it actually worked quite well. Um, they grouped these specimens into negative, low risk, and high risk categories, and training set and testing set like that kind of things. But in general, the accuracy is about over 85% for each category. Negative, low risk, high risk category. Not low grade, high grade, but at low risk, high risk based on morphology or imaging. So it's okay, it's pretty good, but then obviously requires a lot of validations and further studies to confirm the finding. The other thing that we like to highlight here is that there's a marker called HK2 that I feel is very interesting, not only because it can highlight in the abnormal cells, especially for high-grade tumor or even low-grade, but the important thing is that there's a way to fish out those cells and to perform single cell sequencing and validation sort of thing. And for the targeted study, molecular targets for for the bladder cancer treatment, which I think is very, very interesting a concept which combines biomarker with the cell PET on cytology specimen. I think that has great potential, but obviously need more studies as well. There's a lot of dipstick based, and again, none of them really have tremendous value in the clinical application, so I won't get into that. And the other thing that I want to highlight is that even though I'm talking about mostly cell-based assay, but there's a lot of things we can do with the supernatant in terms of DAI, microRNA, methylation profile, and so forth. However, unfortunately, very few of them really become mainstream clinical applications because of the issue that typically involves in this kind of studies. And I like to, actually go beyond that and just look at the some kind of focused targets that are very, very protein based, but has some very good applications, like for example, distinguishing non-invasive from invasive cancers, and for BCG-based therapy, and for like HER2-based therapy on the urine supernatant using some novel sensitive techniques like SNAP McLumin, which is a very unique instrument. But we are planning, study on that purpose right now. So to summarize quickly, and again, urine cytology, especially liquid-based method, is a useful test, especially for high-grade lesions, and it's complementary for the cystoscopy, in the managing of urothelial cancer, you know, monitoring and diagnosis. However, cystoscopy is invasive urine cytology is not sensitive for low grade, so you do need other molecular tests or other biomarkers. Many of them have been tested, developed, but few has been showing actual clinical application utility. So, quick example of this is a case of 87-year-old female with long history of hematuria, but no bladder cancer history. But even a high school students can make a diagnosis of cancer from this morphology. However, the biopsy turned out to be initially interpreted as negative, but if you look closely, there are single cells on top of the surface of the mucosa. So this we did in 53 confirming this is actually carcinoma in situ. So what happened is that I always tell my urology colleagues that if I call cytology ECD high grade and your biopsy is negative, think about my cytology as gold standard rather than histology, because there's definitely cancer cells that I think patient has, but it just unfortunately most of them went to urine rather than stay in the tissue. So that's kind of the point I want to highlight. And thank you again for your time and attention. And unfortunately, I won't be available for questions. And I think I used 30 minutes of my time. Okay, thank you for your attention.
Many thanks to Dr. Rav for being part of the summit and for sharing his expertise with us. Moving on to our next speaker, I'd like to introduce Bridget Sein, a market research professional with a background in counseling psychology and a passionate advocate for bladder cancer awareness. As a 10-year cancer survivor diagnosed with transitional carcinoma of the urethra, she brings a patient-centered perspective on survivorship, early warning signs, timely diagnosis, and patient advocacy. He'll talk she will speaking on a bladder cancer survivor's journey from symptoms to survival.
Hi everyone, my name is Bridget, a cancer survivor, cancer of the urethra bladder, stage 3. And today I'm here to share my testimony of cancer journey. My journey started in 2015 when I developed a lot of abdominal pain, and this pain could not go away. So I went to different gynas, and I was treated for several times. I was treated for UTIs. So at first we thought it was a gyna issue. So after the pain persisted, I sought opinion from another doctor who recommended an ultrasound, and from that ultrasound, it showed that I had ovarian cyst. So the doctor said we had to remove the cyst. So the cyst was removed, but after some times the pain persisted. So I went back now to another opinion, or to seek another opinion. And before even I sought another opinion, I went to 5 different gynecologists here in Nairobi, and they were not able to pinpoint exactly what was the main issue I was ailing from. So from there, I went, a colleague of mine recommended another gyna, where I went to see that gyna, and I was so devastated because I had a lot of pain. It's one thing to have a pain, and it's another thing that you don't know what is ailing you. So when I went to this doctor, I told the doctor, I'm so devastated, I don't know. I don't know. I'm so hopeless and helpless. I just need help. So this doctor listened to my case, and he went through some medical report that I had, and recommended that I should do an MRI. So from that MRI, when I did the MRI, after 2 days, I went back with the results to the doctor, and the doctor wrote a note, and he told me to go and see. He told me, Bridget, you need to go and see a urologist. So I went to see the urologist because he only recommended, and he did a note, and he put in an envelope and sealed it. So I went to see this urologist. So after the urologist went through the medical report, he also recommended that he needed to do another MRI. We did an MRI, and we did also a histology. And from that histology, yes, he saw there was something, but he wanted to go further. He wanted to investigate further. So he said he need to do a cystoscopy, where they will put a camera inside and see what is happening because of the magnitude of pain that I was going through. So after now, after they did the cystoscopy, that is when we were going to because now it was done in the theater. When we are going to the theater, they told me, both of them, it was both the gyna and the uro, both of them, they was performing that surgery, and they told me to give them a consent, to give them an okay, or when they go inside and from the cystoscopy, if they see anything that is abnormal, they can remove it. So I give them a go ahead that once they discover anything that is abnormal, they can remove it. But for them, from the report, they had already seen the mass, but they didn't want to break the news to me at that particular time. So after now the surgery, I stayed in the hospital for 7 days, and after the 7 days, I was discharged. I went home. After 2 weeks, I went back to see the doctor. And the doctor told me that they need consent for me to send my biopsy to South Africa. So I wondered. It's barely 3 months. I did my second opinion because I feel it's like there was a misdiagnosis somewhere. And they say, yes, it's true. He wrote for me a note and he sent me back to the lab. And I went to the lab, I paid some fee, and I took my biopsy. They preserved for me in nicely in a glass slide, and they gave me. So I went with this biopsy and I went to another lab that was Lancet. And I told them I need a second opinion for this biopsy. And they told me they're sending their biopsy again to South Africa. So they sent to South Africa. After 2 weeks, I went and collected my biopsy, and the results were still the same. That it was transitional cell carcinoma of the urethra, high grade. So my situation and my story was still that I have cancer. So from there I said, okay, now it is confirmed that I have cancer. So what next? The next thing now is to get treatment ASAP, because the high grade mean that it's very aggressive and it has a chances of recurrence and a chances of multiplying very fast in your body. So I really needed to seek a very urgent medical treatment. So I asked myself, what do I do? So I remember when I went back to the lab, this lab technician, he told me, if you can afford to go to India or you can afford to go to South Africa, please go, because this type of cancer, especially the location and the type of cancer that you are going through, it's one of the rare cancer in women. So please just go to India. So I asked myself, it's a good idea. I need to go to India, but where am I starting? Because at that point, I had already exhausted my medical cover. I didn't have my medical cover. I didn't have money. I didn't know where to start. Yes, it's in India. I didn't know. And this is the goodness and is the importance of sharing our story. Because I remember the story of Janet Kanini and how she came to the late Janet Kanini, how she came to the public, and she talked about her cancer journey. And I remember she mentioned something about India. So I decided, let me go to her email. I emailed her about my case and whether she can refer me to her doctor. So when I texted her, I emailed her that day. The same day she replied and she gave me contacts to several doctors in India, and she gave me contacts for Doctors Beyond Borders. So I took all my doctor's medical report, MRI, ultrasound, any medical report, and I shared widely. I didn't care who was receiving from the other end, whatever they will do with the information. I didn't care what I was carrying at that moment. I really needed treatment as soon as possible, very urgent treatment. And after a few days, I got response from nearly 70% of the email I sent. I got 70% from various doctors, from various hospitals, and the treatment plan and the options they had for me. And then now I just wanted to settle for one. So I prayed and asked God for direction. And so I went back. And now all these hospitals in India, they're all equipped. They're big hospitals. They have doctors. So I decided, let me narrow down. Let me now go to doctor's profile. So I went to each and every doctor's profile. And one that attracted me the most was BLK Kapoor, one doctor called Dr. Amil Agarawal. And this doctor, he had 25 years experience in onco services. So I decided, let me try this, doctor. So I sent now my medical report to him directly. I look for his contact and everything. I sent my medical report, and from there I got a response, and then I decided now I'm going to settle for this one. And remember, I didn't have money. I only had faith. So I confided with one of my colleagues of what I was going through, and I told them not to share my story with anybody. That was just for their info. And then 2 days later, I got a call from my HR, and I thought, okay, maybe she wanted to find out how I'm faring on after now doing the second surgery. But she told me, I know what you're going through. And I said, how? And she told me, I was told by so-and-so. So one of the ladies that I shared my story with, she went and leaked the information to the HR. And I was so mad with her, but it was a blessing in disguise, because after that, everything moved so fast, and I was able, they were able to fast track my treatment to India. And then now we broke the news now to my family members, to my sister, to my brothers, and even to my mom. And finally, after much consultation and blessing from my family members, we went to India with my sister as a caregiver. And I want to bless God for my sister, because she resigned from her job, a well-paying job, just to go and take care of me. So we went to India, and when we arrived in India, the story was still the same. We met a panel of doctors, that was medical oncologists, surgical oncologists, radio oncologists, gyne oncologists, and uro-oncologists. So we had a discussion. I shared my medical report with them, and they went through my medical report, but they recommended that they need to do their own test. So we started a series of tests. It took 2 weeks to complete all the tests. After the test, we went back now to the doctor, and we sat down, and they confirmed, yes, it is cancer. And they even did the staging, and the staging showed that it was cancer stage 3 that had spread from urethra, bladder, and part of my reproductive organ. That is invasive transitional carcinoma of the urethra. So, and they said the standard way of treating this disease is only to remove the organs. So I told the doctors, no, that was the same treatment plan in Kenya. And that's why I came to India, because I think India, you are more advanced in technology than Kenya. So I'm not ready for my organs to be removed. Patients, you need to be your own advocate. You need to stand, there's a right of a patient, and you need to choose your own treatment options. So they were not happy with my decision. So after that, I went to 4 different opinions in New Delhi. I went to Artemis, I went to Max Hospital. By then it wasn't BLK Max. I also went to Fortis, and I went to Medanta, but the story was still the same. So when I went back to the hotel, I met this Pakistani. He had prostate cancer. And the treatment plan for his case was the same as mine. So we had something in common. So he told me that they wanted to remove his organs, but he refused. So he told me, since him is older and he refused his organs to be removed, what about me? So he recommended me to go to and see another doctor. So I went to see this doctor, and this doctor now from Fortis Scottish told me that I can only do chemo and radio, but it's not going to be effective, 100% effective. It's only going to be maybe between 50 and 70. So I said, yes, sounds good. I will settle for this. The remaining part, my God will complete it for me. So I went back now to my original doctor. Information is power. With this information, and I told my original doctor that I will settle for chemotherapy and radiotherapy, and no removing of my organs. He wasn't happy, but at the end of it all, he agreed with my decision, and I started my chemo. So after starting my chemo, I did 6 sessions of chemotherapy, and I got all type manner of side effect from vomiting, diarrhea, loss of appetite, nerve issues, back issues, bone issues. I had a lot of everyday headache, nausea, every day. There were new side effects, and on top of all, to wrap it all, I lost my hair. I remember I used to love my hair so much. It was very devastating for me to lose my hair, but nevertheless, I accepted it. It wasn't easy for me and even for my caregiver. We really cried that day, but we accepted and we moved on. After 3 months, we started now the second line of treatment, that was radiotherapy. And radiotherapy for me, because now the cancer was between the urethra, bladder, and reproductive organ, it meant putting a catheter in between. I stayed with catheter for 3 months. I got all manner of infection from that catheter. It wasn't easy at all. I used to pass blood. Every hour we used to empty my urine bag. It was full of blood, full of urine, and on top of that, I got burn at my along my private part. From the rays, radiation rays. So I got a lot of burn, and backside I had a lot of bed sores. So it was the most devastating, difficult, and the darkest time of my life. I used to cry. I could not walk because of the burns that I had, burns all over. I cannot even wash myself well. So my sister used to put water in a basin, put Dettol and salt. I could sit on that water so that it can clean itself, that area. We used to use yogurt and ice cream. I could apply ice cream along my private parts because it was so painful. All antibiotics were not working, painkillers were not working, until the doctors even recommended I should be injected with morphine because of the pain that I was going through. It was so much, a lot of pain, excruciating pain that I cannot even explain, that I was going through a lot of pain. But in all that I was going through, God is so faithful. And that's why a cancer patient, I just want to encourage you. Put your hope in God. Put your trust in God. I used to pray. I used to talk to God. Sometimes I could not even have strength to pray. But I used to talk to God and remind God of His promises, that His word says that He will never leave us. He will never forsake us. He will always be with us. He's fighting our battles. I used to tell God, I am with you in this, God. You promised me when I'm going through fire, you are with me. When I'm going through waters, through sea, it will not sweep over me because you're always with me. I used to remind Him that weeping may only endure for a night, but joy come in the morning. I used to speak to myself, to speak to my inner man, to my spirit, that I am going back to Kenya fully healed, not as a cargo, but as a passenger. I used to tell myself that I'm going to testify the goodness of the Lord in the land of the living. And true to what I had believing in God. By the time I was coming back to Kenya, when we did the last CT scan, it showed no traces of cancer, until one of the nurses told me, it is your Jesus who have done it for you, because the situation was so dire. The situation was so it was an impossible mission, but God came through for me, and that's why I believe there's nothing impossible with God. So I want to encourage you who is going through very active treatment right now. Put your trust in God. Keep fighting. Keep believing, keep hoping, do not lose hope. One thing about this cancer journey is so difficult. There are highs and there are lows. But one thing, healing is in your mind. Whatever you believe here, whatever you will speak to your inner man and to your mind, it will come to pass. So believe that you will come out of that situation. Believe that, know that this cancer, So we have warriors. We have people who have conquered this cancer. Look at me right now. I'm not on any medication. Apart from the vitamins, multivitamins only, I am not on any medication. This is my 10th year celebrating my survivorship, and I thank God because I've seen the hand of God in this, and I know even you will come with that testimony. Do not allow cancer to define who you are. Do not allow cancer to cut short your life. Have hope that even if your body cancer has caused harm to your body, it cannot crush your spirit. So be encouraged. Fight it with all your being. Be your own advocate. When you go to the doctor, ask as many questions as possible. Document everything. Go with a notebook. Whatever the doctor says, document it down. Follow your medication on your treatment plan religiously. Do not whatever the protocol you are given, follow it to the ladder. And then drink a lot of water. Take care of yourself. Love yourself. Love yourself. You are the only one who can do it for yourself. Be your own advocate. Advocate for yourself. Even when you are in your lowest, just wake up, brush your teeth, freshen up, change your everything about yourself. Just have hope in the Lord, because one thing, cancer is not a death sentence, and cancer one day it will also die. So do not allow this monster to take toll on you. Do not allow this monster to crush your spirit. You have something to guard. You have something to celebrate life for. Life is so beautiful. Just have faith in God that this cancer, I will conquer this cancer. Be part of statistics of those cancer patients who are going to be warrior and to tell their stories. Do not be part of the statistics of those who have gone to the grave, of those who are going to the grave. No, refuse it with every part of your body. Just take a balanced diet, eat a balanced diet, drink a lot of water. Even if you don't love water, force yourself to drink water. Drink a lot of water. Take care of yourself, and you will come back with that testimony. We are waiting for your testimony. We are waiting for your testimony. You are not going anywhere anytime soon. So the symptoms that I had, at first, I assumed them. I ignored them. And that's why it's very important to listen to your body, because at first there was a time I spotted urine in my blood, blood in my urine, but I didn't take any action. I had a lot of abdominal pain, heavy menses, bleeding, and one about when it comes to bladder cancer, especially in women, it mimics gyna issues. So sometimes you can assume it's only maybe it's hormonal changes in women, maybe it's only gyna issues, or maybe my menses are coming. That's why maybe sometimes we tend to ignore, and I'm yet to come across women who have undergone through this. I don't know whether it's because of stigma. We don't want to talk about our story, because you cannot talk about urethra, bladder without talking about our womanhood or reproductive organ, especially the vagina, because the urethra, vagina, and bladder, they are in the same path. So that's why I think most women, we don't talk about it because of the stigma of talking about our private parts. But because I am here to encourage someone, that's why I've decided to tell my story, so that I can encourage someone there because of stigma. Go and be tested. Take advantage of all this free screening. Go and see medical doctors. Whenever you feel there's something amiss in your body, listen to your body. Our bodies normally speaks. It normally sends signals to us. So listen to your body, and if symptom persist, seek medical advice. So be encouraged. I love you so much. We are waiting for your testimony. Bye-bye. Thank you.
Thank you very much for this powerful and inspiring talk, for openly sharing your story and this very important patient perspective with us. Thank you very much. Moving forward, we're pleased to welcome Dr. Imene Haji, who's a medical oncologist with a particular interest in genitourinary cancers, thoracic oncology, GI cancers, and precision medicine. She's involved in academic and educational initiatives in oncology and international collaboration focused on improving cancer care and access to modern therapies in low and middle resource settings. Her talk will focus on national bladder cancer guidelines in Algeria, adapting global evidence to regional practice. Dr. Haji, the floor is yours.
Hi, good morning. Good morning, everyone. Thank you very much for the invitation. It's
Thank
a pleasure. It's a pleasure to participate in this virtual summit. Thank you.
Thanks for taking the time to join us. Thank you.
Thank you. So today I will discuss evolution of my screen. Yeah, is it? I'm sorry.
Yes, everything's okay. Thank you.
All right, good. Sorry. Okay. So today we'll discuss the evolution of bladder cancer management, a particular focus on how rapidly evolving international evidence progressively integrated into national clinical practice and therapeutic guidelines. I will mainly focus on the medical oncology perspective, especially perioperative treatment strategies, immunotherapy, ADCs, and future precision approaches. Major global represents the wide. In Algeria, it is the fifth most common cancer overall, and the second GU malignancy in men after prostate cancer. More than 70% of patients are diagnosed after the age of 65 years, and the disease predominantly affects men with a male to female ratio of approximately 3:1. Smoking remains the leading risk factor and continues to represent a major public health challenge. Risk factors contribute to bladder carcinogenesis. Tobacco exposure are the most important risk factor. Other contributors include occupational exposure to aromatic amines and hydrocarbons, cyclophosphamide exposure, chronic inflammation, and schistosoma hematobium infection in endemic regions. Advanced age and male sex are also strongly associated with increased incidence. Bladder cancer is a highly heterogeneous disease. Non-muscle invasive bladder cancer includes TA and T1 and carcinoma in situ lesions and represents approximately 70 to 80% of newly diagnosed cases. Muscle invasive bladder cancer, on the other hand, is associated with significantly higher metastatic potential and poorer outcomes. The major clinical challenges remain recurrence, progression. Slide illustrates the biological evolution of bladder cancer. We can observe the progression from superficial toward muscle invasive, eventually metastatic disease. This natural history explains why early risk stratification and multidisciplinary management are essential. It also supports the growing role of perioperative systemic treatment in high-risk disease. So, sorry. Okay. Modern staging increasingly relies on multi-parametric MRI techniques. The development of the VIRADS system has improved assessment of muscle invasion and may facilitate patient selection for bladder preservation approaches. Although pathology remains the gold standard, imaging is becoming increasingly important in treatment planning. Perioperative systemic treatment has become a cornerstone of muscle-invasive bladder cancer management. Cis-based neoadjuvant chemotherapy remains the standard of care for and pathological response rates. The most commonly used regimens are Dose-dense MVAC and GemCis. Patient selection remains essential, particularly regarding renal function and performance status. So this slide summarizes the main criteria used to identify candidates for neoadjuvant cisplatin-based chemotherapy. Eligible patients generally have T2 to T4A disease, good performance status, preserved renal function, and no major contraindication to cisplatin. These criteria have become increasingly refined in modern guidelines. So evidence for neoadjuvant chemotherapy. Level 1 evidence supports the use of neoadjuvant chemotherapy in muscle-invasive bladder cancer. Analyses demonstrated significant overall benefit associated with cisplatin-based combinations. In daily practice, neoadjuvant treatment improves pathological response rates and may increase cure probability in selected patients. The VESPER trial compared dose-dense MVAC with GemCis in the perioperative setting. The study suggested improved progression-free survival and pathological response rates with dose-dense MVAC. These findings reinforce the role of intensified cisplatin-based treatment in fit patients. In Algeria, both regimens remain widely used depending on patient characteristics and treatment accessibility. These results further support dose-dense active perioperative regimen. However, treatment decisions must still balance efficacy, toxicity, patient fitness, and local resource availability. The of adapting evidence to real-world practice. So bladder preservation strategies represent an important alternative for selected patients. Trimodality therapy combines maximal TURBT, radiotherapy, and concurrent radiosensitizing chemotherapy. The best candidates are patients with unifocal T2 tumors, no extensive carcinoma in situ, no hydronephrosis, and preserved bladder function. This strategy is especially relevant for patients refusing cystectomy or considered poor surgical candidates. Overall, the past decade, bladder cancer management has undergone a major transformation. So it progressively moved from chemotherapy-only approaches towards immune checkpoint inhibitors, ADCs, and precision oncology strategies. This therapeutic revolution has dramatically changed both perioperative and metastatic disease management. Keynote 045 established PEM as a standard second-line treatment after platinum-based chemotherapy. The study demonstrated improved OS compared with chemotherapy and represented one of the first major successes of immunotherapy in urothelial carcinoma. This trial significantly changed advanced disease management worldwide. The Javelin Bladder 100 trial introduced maintenance immunotherapy as a new treatment paradigm. So avelumab maintenance after first-line platinum chemotherapy significantly improved overall survival compared with best supportive care alone. This study rapidly became practice-changing and was integrated into international and Algerian recommendations. Checkmate 274 established adjuvant Nivo as a new standard of care for high-risk muscle-invasive urothelial carcinoma after surgery. The trial demonstrated significant improvement in disease-free survival. As a result, adjuvant immunotherapy progressively entered modern perioperative treatment algorithms. So this study reinforced the role of Nivo in high-risk postoperative disease. It also marked an important transition toward integrating immunotherapy earlier in disease course rather than limiting its use to metastatic settings only. Circulating tumor DNA, ctDNA, one of the most promising tools in modern urothelial cancer management. Detection of molecular residual disease may identify patients at particular high risk of relapse after surgery. So in the future, ctDNA-guided strategies may help personalize perioperative treatment and avoid overtreatment. This field represents an important step towards precision oncology. Okay. So the Niagara trial represents another major step in perioperative immunotherapy. This study evaluated the addition of durvalumab to neoadjuvant chemotherapy, followed by adjuvant durvalumab. So the objective was to improve long-term disease control through earlier integration of immunotherapy. So the Niagara trial demonstrated improved pathological complete response and event-free survival compared with chemotherapy alone. These findings reinforce the growing importance of perioperative immunotherapy and are likely to further influence future treatment standards. Management of metastatic urothelial carcinoma has changed profoundly in recent years. Historically, treatment relied mainly on platinum-based chemotherapy. Subsequently, immunotherapy emerged as a new standard. Today, ADCs and combination strategies are reshaping first-line treatment paradigms. The therapeutical landscape changed more during the last few years than during the previous 2 decades. Okay, so the EV-302 trial is considered one of the most practice-changing studies in advanced urothelial carcinoma. The combination of enfortumab vedotin and pembrolizumab demonstrated remarkable improvements in progression-free and overall survival compared with platinum chemotherapy. This combination is progressively redefining first-line treatment towards standards worldwide. So EV, this slide illustrates the growing importance of antibody drug conjugates in bladder cancer management. ADC-based combination are rapidly moving from late-line treatment toward first-line and perioperative settings. These therapies represent one of the most important therapeutic advances in urothelial cancer. FGFR alterations represent an important therapeutic target in urothelial carcinoma. Erdafitinib demonstrated meaningful activity in patients harboring FGFR2 or FGFR3 alterations. It illustrates the progressive transition toward biomarker-driven treatment strategies and precision oncology. So, future therapeutic strategies are increasingly focusing on novel antibody drug conjugates, HER2 targeting, molecular profiling, and combination approaches. The therapeutic landscape continues to evolve rapidly, with multiple ongoing trials exploring increasingly personalized treatment strategies. One of the most important developments in Algeria has been the progressive alignment of national recommendations with international standards. So compared with the 2024 version, the 2026 update integrates perioperative immunotherapy, ADC-based defined cisplatin eligibility criteria, and more personalized treatment strategies. So this reflects a significant effort to rapidly adapt a global evidence to regional practice realities. Appropriate patient selection remains essential when considering cisplatin-based chemotherapy. Eligibility depends on performance status, renal function neuropathy, hearing function, and cardiovascular status. This refinement is clinically important because cisplatin eligibility directly influences treatment sequencing and access to modern perioperative approaches. Despite major scientific advances, important real-world challenges remain. These include unequal access to novel therapies, limited molecular testing infrastructure, financial constraints, and geographic disparities in care delivery. Multidisciplinary collaboration remains fundamental to improving outcomes in routine clinical practice. So to conclude, Algerian bladder cancer guidelines are progressively aligning with international standards. Immunotherapy and antibody drug conjugates are reshaping disease management across multiple settings. Precision oncology is becoming increasingly relevant. However, implementation challenges and treatment accessibility remain major issues in many regions. Thank you very much for your attention.
Thank you very much for walking us through the practical aspects of bladder cancer management in your regional practice. Thank you. And
Thank you.
with your permission, I'd like to bring in a question from our audience, from our live chat.
Yes.
So, okay, with ctDNA and molecular residual disease becoming increasingly relevant to your 4C biomarker-driven decision-making becoming feasible in routine practice across North Africa in near future.
Sorry, what is the question? So are we implementing ctDNA and is it the question?
Is it feasible to make biomarker-driven decisions in near future in your region?
Well, I think in the near future it would be. It is going to there. Discussions are being made. So yeah, I think it would be very feasible. Very feasible. Yes.
And another question I'd like to ask you about, if you don't mind.
Yes, of course.
How can regions with limited access better implement modern bladder cancer guidelines?
How can regions
with limited access better implement
how they
modern bladder
implement?
cancer
So
guidelines?
yes, so I can speak from the Algerian point of view. You know, as I showed in the slide, 2024 and 2026, so much has been done. And I think our patients, especially in Algeria, are very lucky because they don't have to deal with reimbursement of treatment. So they get the treatment freely. And as you see, immunotherapy is available, ADCs are available, and it's going towards a very global approach. So we are very hopeful for our patients. Yes.
Thank you, Dr. Haji. Thank you for this important discussions and for joining us today.
Thank you. Thank you. Thank you. Bye-bye.
Bye. Well, we'll take a short break, I think, and be right back. Hello, everyone, and welcome back to the How I Treat Bladder Cancer in 2026 Virtual Summit. Moving forward, we're pleased to welcome our next speaker, James Cato, who is a professor of surgery at the University of Sheffield and honorary consultant urological surgeon at Sheffield Teaching Hospitals NHC Foundation Trust. His work focuses on bladder cancer research, urologic oncology, and clinical trials, and he has published more than 400 primary research manuscripts. He'll be speaking on muscle-invasive bladder cancer in 2026.
Thank you very much for this kind invitation to come and talk to you today. Can you hear me okay?
Yes.
Great, thank you. I'll do my talk. So it's obviously a great honor to be here today, and thank you for inviting me. These are my disclosures, so they're mostly to do with funding and support I've done in the field for guidelines, journals, and etc. So I'm going to talk mostly about radical cystectomy today as a surgeon, and I think this is the thing that is most pertinent from my perspective, given you've got a panel with lots of oncologists and radiation oncologists going forward. I see treatment of bladder cancer, invasive bladder cancer, as two sides of the same coin, and cystectomy and how that impacts those coins. So on one side, we've got treatment of the cancer and survival. So can we optimize survival where possible in patients with invasive cancer? And on the other side, we've got the morbidity, mortality of the treatment, which in this case is surgery, and then the subsequent quality of life down the line. And obviously, what we all want as doctors is to have the perfect balance of these two sides of the coin, so that we have the most effective treatment that has the least morbidity and the best quality of life going forward. If we think about all bladder cancers, all invasive bladder cancers, so in the rule chart here, if we think about 100% of them, what we see is a fair number of them are not eligible for non-surgical treatments. So if you think about chemotherapy or immunotherapy, we've got patients who are cisplatin ineligible, which may be less relevant in the EV Pembro era, but certainly is a good marker of frailty and morbidity. We've got people who have contraindications to immune therapy, so either autoimmune diseases, immune-related diseases, or previous reactions. And then we've got people who've got reactions to antibody-drug conjugates, so are not suitable for EV Pembro, or got a neuropathy already, or liver failure, or current infection. We've got people who are unsuitable for radiotherapy, so they may have a hostile bladder, so you may have a small volume, low compliance bladder with widespread carcinoma in situ. May have got a tumor that's in a diverticulum, so no muscle there. We may have obstruction of the upper tract, so hydronephrosis. And you may have bad bladder symptoms as a consequence. And then you've got people whose body is unsuitable to receive radiotherapy. So maybe they've got ulcerative colitis, they've had previous pelvic radiotherapy, especially for prostate cancer, we see a lot of. Maybe got hip replacement, so the imaging is not ideal. They've got small bowel pathology. And then we've got between 5 and 10% of patients who don't have urothelial bladder cancer. So they've got a pure adeno, squame, or sarcoma. So already those 100% has dropped down to about 80% that are suitable for bladder sparing approaches. If we then look at radiotherapy as a treatment, which is definitely effective in the right population, we recognize that there are radio-resistant cancers, and that range is probably around 30%, between 10 and 30%. Here you can see on the left a systematic review that has a rate of salvage cystectomy of between 10 and 30%. And that's people who get to cystectomy. A lot of the patients who develop advanced disease after radiotherapy aren't fit for surgery, so they probably have a higher failure rate. If you look at cohorts going forward, it's certainly in the kind of 30% range for people who start bladder sparing to end up failing that treatment. And if we go to drug treatment, then we've got either, we look at the state of the art at the moment, so in EV Pembro, so EV303, we saw great path-CR rates, but the non-path-CR rate is about 40%, 43%. And the non-path partial response rate is about 34%. So again, approximately 30 to 40% of patients don't respond to EV Pembro in this context. And if we think about Niagara with durvalumab on top of Gemcis, we see the non-path CR rate about 63%. So again, a not insignificant majority/minority of people don't respond to that treatment, despite it being state-of-the-art gold standard. If we go forwards about survival, I think the data are really conflicting. I think the best we can conclude is that there is no proven difference between the two treatments for surgery or radiotherapy. I'll come to drug treatment in a minute. But on balance, given that a proportion of patients biologically are going to be radioresistant, then surgery probably has a slightly marginal higher cure rate just because effectively you're treating all the patients as opposed to treating only those that are radiosensitive. So I can show you data that show no difference in the outcomes, or data from larger multi-prospective trials that show significant differences in the outcome. But these are going to be heavily pre-selected. We know in the real world that people having radiotherapy have a lower performance status, so less fit, which is a strong marker for overall survival, more likely to have significant comorbidities, and therefore may end up having slightly less effective treatment. So I'm not sure if I'm convinced by these data, but in the UK, we did try and run a randomized trial. So it was before my time as a consultant, but SPARE ran across the UK with randomized patients to surgery or cystectomy. The main outcomes were to do with toxicity. So we saw more toxicity with the cystectomy cohort, but in reality, that was fatigue and erectile dysfunction rather than anything that was life-threatening. And if you look at the grade 3, grade 4, there weren't any significant differences. But if we look at the long-term outcomes, and this is a trial in which only about 40 patients were randomized, we saw significant differences in time to local regional recurrence, with cystectomy being far superior. We saw trends towards differences in metastatic survival. And with 40 patients, we almost had significance in overall survival. P equals 0.06, with hazard ratio nearly getting to 1. And perhaps if we'd had a couple more patients in there, we would have shown superiority of cystectomy at radiotherapy in a prospective trial. If we then think about safety and mortality, we know that cystectomy historically has had a very high mortality rate, but there's been a lot of work that's been done to reduce that mortality rate. If we now think about the 3 arms that I think are important in this, the first one is centralisation. So in the UK, we moved towards centralisation in 2000. And what you can see on that graph on the left is the number of cystectomies that are done, which has gone up to 4,500 in 2008. And the mortality rate has dropped significantly from around 5% at 30 days to less than about 3%, and from 10% down to about 6% at 90 days. And that's to do with massive centralisation. So in the UK, we've gone from 200 centres doing cystectomy to about 40. So that's centralisation. Then we've got enhanced recovery. So on the data on the right, we've got the Sheffield series of 450 patients, where we've shown that with relatively simple steps of enhanced recovery, we can reduce the length of stay from 20 days down to 6. We can reduce the readmission rates from 50% down to 15, and we can reduce the mortality accordingly down to about 1% within 90 days in Sheffield. In fact, less than 1%, about 0.7%. But we know that with centralisation, you get increased volume, better case selection, better performing teams. With enhanced recovery, you get further improvements, and the icing on the cake for that is robotic surgery. So again, we know that you get shorter length of stay, fewer readmissions, and fewer complications. If we look at all-cause mortality, so overall mortality, so here we've got the IROC trial on the left, and on the right, we've got the radiotherapy trial, BC 2001. So all-cause mortality in the IROC robotic trial, so it's open versus robotic cystectomy. At 3 months, it was 1 or 3%, depending on which arm you're in. At 6 months, it was 4 or 5% all-cause mortality. And that is very similar. It's marginally better, but very similar to what we saw in the all-cause mortality in BC 2001, which was radiotherapy versus radiotherapy with 5-FU and mitomycin prior as radiosensitizers. And again, there you see the 6-month all-cause mortality is 8%, which is certainly higher, but certainly not dramatically better than with radical surgery. So I would argue that the surgical outcomes are very similar to the non-surgical outcomes in terms of mortality. And if you look on the bottom right of those graphs, you see in green the mean age with surgery is slightly younger, 3 years younger, but the number of patients with performance status 2 and 3 is the same, 3% to 3.1%. But I don't think these populations are dramatically different. There are no randomized trials without cystectomy for drug-sparing approaches. But if we look at EV303 and Niagara, what we see is that 88% of patients in the control arm get cystectomy, so 12% don't get to that point, and a fair number of them don't complete the neoadjuvant treatment. We're anxiously awaiting these trials now to see if there's any value in bladder sparing in those who completely respond. And obviously that's what a lot of the panel are going to talk about today and into the future of travel. But I would caution that, given that the data don't support that approach at the moment. My next discussion is about quality of life. So the majority of people perceive that having their bladder removed is the end stage of their quality of life, and therefore everything should be done to avoid that and to go down a bladder sparing route. But the evidence doesn't really support that. And I'm going to show about 4 studies that have looked at this. The first one is an NHS England survey that was run not by urologists, not by oncologists, but run by the NHS as part of a pilot study where they looked at all different cancers. It was an NHS cancer patient survey. We were able to get hold of the 673 patients who'd responded with bladder cancer. What you can see here is the scores of well-being, quality of life. So that's physical, social, emotional, functional, and other items. Green is good, red is bad. And what you can see in this population is that in nearly all of these domains, the cystectomy had the best quality of life, had the least impact on their overall quality of life. The exception being body image and sexual function, which you can see there in red. The radiochemotherapy was better for those, and radiotherapy across the board was the worst. Now, again, that could be a function of treatment, or it could be a function that the older, less fit patients are having radiotherapy, and therefore they have a lower performance status, which we know strongly associated with quality of life. If we take a second survey, so this was one we ran in Sheffield across Yorkshire, so we invited 3,000 patients and 1,700 responded. It was conducted in the first 1 to 10 years after diagnosis. It was all patients with bladder cancer. So many of them had non-muscle invasive disease treated by TURBT alone. Some had radical cystectomy, some had radical cystectomy chemotherapy, and likewise with radiotherapy. What you see here is the EQ5D domains, and you can see that fundamentally, regardless of the treatment, the quality of life doesn't vary much. In other words, your quality of life is not affected by the treatment you've had. What directs your quality of life actually is your age and your performance status. On the left here, we've got comorbidity, and you can see here that as you get older and you get more comorbid, your quality of life drops across the board, far more than what treatment you've had. It's to do with age and performance status that affects quality of life. So you've got cystectomy population on the left here and radiotherapy population on the right, both showing the same things. And again here, if we look at the EORTC QLQ-C30 modules, again, you see, broadly speaking, the only domains that are different after surgery are sexual function and body image, which again, we've known from that first cohort. Then we've got a longitudinal survey. So this is patients who conducted a prospective longitudinal quality of life survey before their radical treatment or TURBT, afterwards, and up to a year following that. What you can see here is that across the board for these domains here, so this is the EORTC QLQ C30 domains, you can see that fundamentally TURBT is in blue, radical pathways in red. You can see that whilst there's an initial drop in radical cystectomy in social functioning, in role functioning, etc., by recovery, so that's 6 months or so after their treatment, they're back to normal. So although there's an initial drop in their quality of life at the time of the surgery, they recover it such that 6 months down the line, there's no difference. The Dutch found very similar. So they did a study called Bladder, where they looked at patients going long term and compared neoadjuvant chemotherapy with cystectomy with chemoradiation and radiotherapy, 500 patients, and fundamentally showed exactly the same things. In fact, what they found is the highest quality of life overall was with radical cystectomy and chemotherapy. And depending on the domains, in some domains, chemoradiation did better or around the similar, but radiotherapy and bladder sparing alone was actually the worst in terms of long-term quality of life. The data don't really add up to say that having a cystectomy is a really bad quality of life. And then the final thing to consider is the cost of the agents and the drugs. So on the left, you can see here a bunch of drugs that have come into the bladder cancer space. And on the right, we've got cystectomy. And what you can clearly see is that these drugs are phenomenally expensive. And so for the healthcare providers going forward, it's going to be a real challenge for who pays for these drugs and what is the benefit we get from them in terms of cost effectiveness. In the UK, the NHS pays around £22,000 for a cystectomy. And in the US, I understand the prices are roughly similar depending upon whether you have a complication or not. So $28,000 if you have no complications, and anywhere between $45,000 and $97,000 if you have a major complication after the treatment. So those are far cheaper than the medical drugs that are coming forwards. And if you think about financial toxicity, this is becoming an increasing problem. So we see in the US, we've got a paper from New England Journal, a paper from JCO talking about the toxicity of it. And on the right, if we look on Scopus, this is a search for the words financial toxicity and cancer. And what you can see is a dramatic rise in the number of publications that are now focusing on this topic, such that it's going to become an increasingly problematic issue going forward. And in bladder cancer, we know this is relevant. So in the US, there was a study called CYSTO, which was an observational cohort study looking at people who had cystectomy or BCG for high-grade non-muscle invasive bladder cancer. And what we saw one of the greatest things that came out of this was financial difficulties. So you can see the EORTC financial difficulty score favored cystectomy. And then the cost financial toxicity score also favors cystectomy, as opposed to bladder sparing treatments. And that's probably because it's a one-off definitive treatment, as opposed to going to and from hospital, being off work lots of times, traveling to hospital, paying for travel, paying for parking. And in the UK, in our life and bladder cancer survey, so the 1,700 patient survey, we saw that financial worries were a significant issue for people who are still working. So in the population that are under 65, we saw that 25 to 30% of them ranked as highly their financial worries because of managing their bladder cancer going forward. So as we sort of come full circle, I think financial toxicity is going to be a bigger issue, and that's going to be relevant for healthcare providers as a whole. So in summary, I think there's two sides to a coin. There is treatment of the cancer and survival. Survival is best probably for surgery, but I do recognise it could be over-treatment for some people, and it does allow the integration of multimodal care, and it allows us to think about dynamic treatment responses according to drug treatments they've had prior to surgery. I think it's safe in optimized programs. The outcomes are improved with centralization, enhanced recovery, prehab, and robotic surgery. And probably it's going to be the lowest cost for muscle invasive bladder cancer care going forward, and has limited impact on quality of life. Thank you very much.
Thank you very much, Professor Kettle. We sincerely appreciate your time, expertise, and the valuable insights you've shared with us. Thank you for accepting our invitation and being part of the summit.
Thank you. My pleasure.
Well, okay, we'll now transition to our next talk presented by Joan Svakianos, a professor of urology at the Icahn School of Medicine at Mount Sinai. His clinical and research work focuses on urothelial carcinoma, robotic radical cystectomy, translational research, and the development of novel biomarkers for BCG and responsible bladder cancers. His talk will focus on the use of the ctDNA in bladder cancer. Please, could you share your screen with us?
Good morning, yes. Just give me 1 second.
Sure.
Is that shared?
Not yet. Okay, we're gonna say it now.
Sorry. There you go. Okay, is that shared? All good?
Yes, please, the floor is yours.
Good morning, and thank you very much for the invitation to present here. And I'll be speaking about what I think is a very exciting, fairly novel, but not extremely novel biomarker in bladder cancer, which is ctDNA. And the question is really, what is ctDNA? And, ctDNA is not a new concept. It is not something that we don't know about, because it goes all the way back to single cell biology, and it's a normal biological function for dying cells to fragment their DNA. And our body has mechanisms, and our immune system has mechanisms to do this with things like apoptosis, necrosis, active release through exosomes or microvesicles. And these are things that have been tried to be biomarkers in the past. And of course, you have inflammatory responses like netosis and others that fragment the DNA. And so this concept of DNA fragmentation and DNA being in our circulation is one that we know goes back many years and is something that's been studied quite a bit. We do know that it happens both to normal cells, so normal functioning, aging, dying cells, as well as obviously cancer cells. And when these fragments of DNA are placed into the plasma, they are somewhat considered toxic to the body, and there is a normal immune response that has been developed using macrophages from the liver and our complement immune system to actually clear the DNA.
I'm so sorry for the interruption. It seems we have an issue and the screen is frozen. Could you check it again and make sure you share your slides?
Sure. So I'll stop sharing and reshare. Is that what you're trying
Yes,
to?
please.
Okay. Let's see. Stop sharing. Screen share. Share. How about now? Are you able to see them now?
We can't see your slides, no.
You cannot. About now?
Yes.
Okay.
Yeah.
Okay. So was basically getting to the point of saying that this is this ctDNA in the circulation is a normal function, goes back to almost single cell biology, and our body has an immune system to actually clear this. As you can see here, the macrophages will take up this fragments of DNA and then break them up to nucleic acids and discard them. And because of this, ctDNA or cell-free DNA actually has a half-life in our circulation of about 1.5 to 2 hours. And so the biology has always been there. The main issue has been the mechanics and the tools that were necessary to be able to bring this to clinic both at scale and in a timely fashion that will allow us to make treatment decisions. So while we've thought about precision medicine in the past, and we've had many sort of versions of it, including the idea of sequencing a tumor, finding a mutation, and having a drug for that mutation. While some of those have panned out, really it's not necessarily been we haven't been able to really use it through pan cancers and for all tumor types. And so I think ctDNA is really now the promise of precision medicine, but not necessarily specific about here's your mutation, here's your drug, but really about more when we should escalate care or when we can de-escalate care, what we can do in terms of possibly monitoring patients on different therapies and then making decisions rather than just sticking with the traditional algorithms that we have in our guidelines. And I think bladder cancer is the ideal tumor for something like ctDNA. And that's because you can see that the tumors need to be resected. We need to have a full resection of the tumor. And that full resection of the tumor allows us plenty of tissue to either perform whole exome or whole genome sequencing. And this is from a review that one of my fellows and I wrote a couple of years ago. And the beauty about the use of specifically the Signatera assay from Natera, and that's where the majority of the bladder cancer data exists, is that these are clonal algorithms in the bioinformatics. So the panels that are made from sequencing this tumor are actually clonal to the point that all you really need is this TURBT specimen to give you prognosis with ctDNA, but as well as to continue monitoring with blood samples throughout the patient's care. So we don't need to rebiopsy a metastatic site. And then you'll have these results here. The excitement of ctDNA really started back in 2019 from this publication from Christensen et al. From the group from Aarhus, who had a prospective study called Trombola, 68 patients with locally advanced muscle-invasive bladder cancer, and they had 656 plasma samples that were collected longitudinally. As you can see here, all analyses were, and the initial panel signature was performed from the TURBT specimen, and then blood was taken throughout the patient's journey out to 2 years. And what they found was really that ctDNA is a prognostic biomarker after TURBT and before neoadjuvant chemo. The lack of clearance was a better predictor of recurrence than the actual pathological response at the time of cystectomy. The lead time, so from the time the test turns positive to finding radiographic concerns for metastatic disease, was 96 days. And the most important, in my opinion, I think, is that if you consistently stayed undetectable or negative, there was 100% overall survival. You can see here the Kaplan-Meier curves from the single time points. So like I mentioned before, so single time point before neoadjuvant chemo or after neoadjuvant chemo, from the TURBT specimen, the signature, that the recurrence-free survival was 3% if you were undetectable here and 11% here. But if you were detectable, it was 46% and 75%, with a hazard ratio of 29 and 12, really showing you that a single time point from the TURBT specimen has a significant prognostic impact and allows you to actually be able to counsel patients better and maybe change the decisions that you make for some patients. And most importantly, like I said, the recurrence-free survival was 0% if the patients longitudinally remained undetectable, and 100% if they remained positive, with a hazard ratio of 129.6, which is pretty extraordinary, and a sensitivity of 100% and a specificity of 98%. And it was a more reliable predictor than lymph node status and pathological staging. And we all knew this was the case, right? Because not every T2 behaves the same. Not every T4 behaves the same. And so now we're actually bringing in a biomarker that maybe allows us to understand the biology of these tumors a lot better than the pathological staging alone. And so the group thought similar to what we thought at my institution at Mount Sinai was, well, can we use this to maybe consider neoadjuvant treatment? Every patient in that trial got neoadjuvant chemo. And here what they did is they took those 68 patients from that data and they looked at 102 patients that were neoadjuvant chemo naive that were treated with surgery alone. And while this is definitely not an apples to apples comparison, this is, very biased, 2 different cohorts. What you can see is that the Kaplan-Meier curves here on the left are the neoadjuvant chemo treated. The Kaplan-Meier curves on the right are actually the cystectomy only treated. And you can see the undetectable, which is the turquoise line, compared to detectable, which is the red line. There is the same separation in the curves in the neoadjuvant cohort as there is in the cystectomy only cohort. And so maybe the undetectable patients can get away and could be the ones that we treat with surgery only and no need for neoadjuvant chemo. And this is a biomarker that we've been looking for many, many years. And while they tried to compare, the positives and the negatives, both were not statistically significant. And this has to do probably with numbers, but really going to show you that the undetectable patients maybe we can de-escalate, while the positive patients we need to escalate. And of course, this is all hypothesis driving data, nothing that may necessarily change the clinical practice today, but it is very encouraging. And similarly, what we did is we took our cohort of patients and decided that prospectively we would collect ctDNA on every patient going on to cystectomy. And what we saw was a similar Kaplan-Meier curve. The undetectable patients do really well. The detectable patients do really poorly. And when we tried to break it down a little bit further, we actually saw very similar findings to the Aarhus group, in which the neoadjuvant chemo patients, as you can see in the red line, compared to the cystectomy-only patients, actually had overlapping curves, and there was no difference in outcomes for those patients. And so really driving the hypothesis that maybe we now have a biomarker that can help us identify which patients we may be able to de-escalate care in. But of course, this needs to be found prospectively. And that, I think, is encouraging the idea of doing a neoadjuvant biomarker-driven ctDNA study from what we see in our adjuvant cohorts. And very interestingly, we had 3 adjuvant studies We had Ambassador, which was pembrolizumab versus observation, Checkmate, which was nivolumab versus placebo, and IMvigor010, which is atezolizumab versus observation. These were all very much the same inclusion criteria, pretty much powered the same type of therapy, PD-1 or PD-L1 inhibitor, with somewhat same or similar outcomes. DFS and OS as co-primaries, DFS alone, and DFS alone. And you have 3 studies with pretty much the same cohort of patients with 3 different outcomes. The DFS was positive, but OS negative for Ambassador. DFS was positive for Checkmate, and DFS was negative for IMvigor. And of all these, actually, Checkmate got approved based on the New England Journal of Medicine manuscript showing a hazard ratio of 0.55. But when we look at this, we say, well, how is this different? What are we missing here? And most of us will look at these curves and say there's a separation. But the truth is, when we look underneath the placebo curve, that is the largest area under the curve. And these are all the patients that did not need any adjuvant therapy. They did really well without anything. These patients, which is the smallest area of the curve, are the ones that benefited from the adjuvant therapy. And these patients on top of the curve actually didn't respond to therapy. And unfortunately, they progressed regardless of what we did. And when you think about the numbers, it's 54 to 78. And if you shift this curve up or down just a few patients, this can completely change the outcome, which is likely what we saw because of the 3 different endpoints or three different results from these trials. And so clearly what we use in terms of inclusion, pathological, clinical data, does not have reliability. But when IMvigor, which was a negative study, IMvigor010, actually went back and ad hoc looked at their patient outcomes based on ctDNA status, they actually saw that the ctDNA positive patients actually had a hazard ratio of 0.5 and benefited from atezolizumab. And this is for overall survival. And they found similar results when they carried out their data to 5 years, 60 months. And so clearly, we do see that there is a benefit here for some patients getting adjuvant therapy. And that led to IMvigor011, which was recently published and now in the US has indication with a biomarker-driven ctDNA, the Signatera assay. And this was a 2-to-1 randomized trial of atezolizumab versus placebo in patients who were ctDNA positive, and pretty much exactly the same inclusion criteria as we saw previously in all the other trials. And the ctDNA negative patients were on to standard of care. And the most important part of this trial, in my opinion, was that you can actually convert to ctDNA positive within 21 months. So you had the patients that immediately after surgery were positive, or the patients that you followed that have then converted and then started adjuvant therapy. And of course, this was a positive study, again, published in the New England Journal of Medicine, with an overall survival hazard ratio of 0.59 and a disease-free survival of 0.64. And when you broke it down to the different cohorts, you saw that the immediate, and while this wasn't powered, so some of these are not statistically significant, you can see the separations in the curves for the patients who were immediately continued to be positive versus those that converted to positive. Both groups seem like they do benefit from atezolizumab. But more importantly, what you see is that, again, the undetectable patients do really well. You can see out to 2 years, a roughly 90% DFS if you were negative, with a greater than 90% overall survival. So the theme seems to be the same. The undetectable patients do well. The detectable patients do need therapy, and it seems that the atezolizumab, which is now approved, does benefit in those patients. But as you can see, these curves are not ideal. And while they are shifted to the right, we can probably do a lot better. When you went back and you looked at, this was recently presented at ASCO and published, but the Checkmate 274 group went back and basically looked at ctDNA status in their cohort of patients and then saw exactly the same thing. The undetectable patients do really well. The detectable patients do really poorly, with a median disease-free survival of 5 months compared to 52.1 months. And when they broke it down to the undetectables and detectables, the undetectable patients actually had no statistical significant difference, which you can see here are the top two curves. But the positive patients, you actually had a significant difference with nivolumab of a median disease-free survival of 2.8 versus 74 months. 7.4 months, I'm sorry. And similarly, the Trombola trial did have a longer study showing that, again, the negative patients actually do really well if you just surveil them. And the positive patients, unfortunately, do need adjuvant therapy. But even with adjuvant therapy, we can probably do better. And that's where the modern trial comes in. The modern trial was a trial that was designed ahead of its time and very thoughtfully and smartly so, headed up by Matt Galsky. And this is a 4-arm study that now looks at nivolumab alone versus escalation of care of nivolumab with a LAG-3 inhibitor. And from my understanding, this will now be amended to include EV Pembro here as well. And the negative arm will be nivolumab versus surveillance, and we will be able to convert or shift the patients who are detectable within during the surveillance period to nivolumab, being able to salvage these patients. So really here, it's about minimizing the risk of adverse events for as long as we can, but benefit the patients when we need to. And here it's really about continuing to shift the curve to the right about escalating care. This is a fantastic study that I think will give us a lot of important data, but also give us new data that will allow us to design even better studies. And why is this important? I think this is important for patients like this. This is one of the first patients I ever got ctDNA status on. This is a 45-year-old male that came to me with clinically T3 bladder cancer. He had a right nephrostomy tube in. He did not want neoadjuvant chemo. He just wanted it all out and wanted the tube out of his back. So he went straight to radical cystectomy. He was T3O and 0. This was 2021. And of course, the question is, do we give adjuvant therapy at this point? And, the answer is at 2021 was obviously yes. But if we knew what we know now about ctDNA status, InVigor, Checkmate, so forth, maybe this is a patient, even though he's young and has high-risk disease, that we can actually watch. And again, why is that important? Well, because he initiated GemCis, and after 2 cycles, he actually developed a stroke and now has some right upper extremity weakness. He was a young guy with rehab. It actually isn't so bad, but it is somewhat still affecting his care. After he recovered from that, the question was, should we continue with adjuvant therapy? And this was when Checkmate was published. And so the question was still, should we give him adjuvant nivolumab? Well, if we knew what we know now and his ctDNA is still negative and he had an adverse event already from systemic therapy, well, maybe we can continue to watch him. But at that time, of course, we did not have the ctDNA status. He initiated nivolumab, and he actually developed severe colitis after 3 treatments requiring high-dose steroids and admission. And this is his report. From the beginning to just about 6 or 7 months ago, he's remained undetectable throughout. Now, you can argue that maybe the lower, the suboptimal dosing, chemo plus a couple of cycles of immunotherapy may have been enough. But I think even before starting therapy, he was negative. And given the data that we know, he had a very good prognostic outcome with the undetectable ctDNA. So I probably would argue that this is a patient that, even though the pathology said high risk, the ctDNA said differently, and would have probably been okay if we surveilled him and, if converted to positive, had started therapies. And so for me, the way I look at this is really about the minimizing the adverse events from therapies, including surgery, because I do think that there are some patients that may not benefit from a cystectomy if they have high levels of positive ctDNA. And there are, I think, there are 2 other really good indications for ctDNA. This was a study that we published in 2025. We looked at the ctDNA status within 1 month of imaging for surveillance patients. And what we saw was 100% concordance, that if you were undetectable, imaging was not concerning for metastatic disease. compared to if you were detectable, that 100% of patients eventually did identify some type of metastases. And again, this is important because we use staging and clinical parameters now for surveillance. So a T1 patient, a post-chemo T1 patient, may not get imaging for 6 months, while a T3A patient may get imaging every 3 months. But what if that T1 patient is ctDNA positive and that T3 patient is ctDNA negative? Well, maybe we need to flip that around where the T3A ctDNA negative patient can get imaging every 6 months. And the T1 patient, we probably need to escalate their surveillance and capture their metastatic disease earlier to allow us to get better treatment. Now, I'm not sure if that is a true statement or not, but what I'm basically getting at is that our current surveillance programs based on guidelines and using staging alone could likely be refined with a biomarker like ctDNA to allow us to escalate surveillance on some patients and de-escalate in others. And to me, the most interesting as a urologist is really in the world of non-muscle invasive bladder cancer. And this was first reported by Laura Bukovina and the group from Cleveland Clinic in this brief report in European Urology, where they actually looked at 23 non-muscle invasive bladder cancer patients. And what they found was actually 1/3 of their patients were ctDNA positive, even though they did TRBT, restaging TRBT, and imaging, all suggesting clinically T1 or lower disease. And you can see that 60% of these patients were actually BCG naive. So these weren't the patients that had 5 or 6 intravesical therapies trying to save their bladder. And again, as a urologist, I see these patients where I say, my gut is telling me that you have higher risk disease than what we're looking or seeing based on pathology and imaging. But even though I recommend an upfront cystectomy, a lot of patients will say, no, we should try intravesical therapy because of obviously the burden of a cystectomy. And so I think that this is now an important biomarker to help us actually better risk stratify these patients, because we know some of these high-risk patients will progress, 20 to 30% will progress, and some even will metastasize. And so this is a paper that is in the Journal of Urology that is currently suited for publication. And this is our group with the group from USASF and Seema Porton, where we actually had 45 patients that were that we had ctDNA status on, that were going on to radical cystectomy. And so we looked at our ctDNA status and we saw exactly the same thing. 15 out of the 45 patients, so 1/3 of the patients, were actually ctDNA positive, similar to what Laura found. And very importantly, it was the same group of patients. Some were, the majority were BCG naive. Some had induction BCG. Some were only 20% were BCG unresponsive that were actually detectable. So again, this is not this large cohort of patients that we have been trying to save their bladder for long periods of time. And the majority were T1, and some were T1 and CIS. And interestingly, what we saw were that 2/3, so 67% of the patients who were positive, who went on to cystectomy, were actually muscle invasive. So really showing that if you're ctDNA positive, you have a very high chance of upstaging. At cystectomy, if you were undetectable, only 4 or 13 patients actually were muscle invasive. So the overwhelming majority, 87%, were still non-muscle invasive and were likely cured of their cancer. More importantly, it was that 1/3 of the patients that were detectable ended up having positive lymph nodes at the time of cystectomy. So really now we have a biomarker that can show us that we can add to our clinical staging and identify the really bad players in the non-muscle invasive state. And as you can see, the Kaplan-Meier curves are very similar to every other Kaplan-Meier curve, where the undetectable patients do really well and the detectable patients do really poorly. So in conclusion, I do think ctDNA is a prognostic biomarker. I have included it in my practice in terms of being able to counsel patients appropriately and setting expectations for those who will likely need significant escalation of their care. There's ability to do the assay from a TRBT specimen, the Signatera assay, with high sensitivity and specificity, allowing for prognosis from a single time point. But of course, the longitudinal is way more important. I think for adjuvant therapy, decision making is now standard of care. I had a question mark there, but now it is, because we have approval with the ctDNA Signatera biomarker for atezolizumab. So I think we can consider this being standard of care at this point in time. And you can, I think, use it in the neoadjuvant setting for de-escalation, but obviously we need to do the clinical trials in the neoadjuvant setting as well. And of course, there are, I think, a lot of other important ways that we can use ctDNA to better surveil and stage our patients. And that's it. I think I'm happy to take any questions.
Thank you very much, Professor Svakianos. We truly appreciate you sharing this valuable information with us. And yes, by the way, we have an interesting question from the audience that I'd like to bring in. And here it is. If ctDNA becomes part of the routine bladder cancer care, how do we avoid overreacting to molecular relapse before there is clear radiologic or clinical disease?
So, but I think what IMvigor011 actually showed us is that we shouldn't be overreacting to MRD positive patients, meaning that they treated the patients based purely on the ctDNA status. So in the adjuvant setting, the undetectables became detectables without radiographic findings of metastases, and the therapy was started, and it actually showed a clinical benefit in those patients. So I don't think overreacting. I think we're reacting appropriately and likely before a large burden of disease.
Well, thank you for your expertise. It was a pleasure having you with us. Thank you for joining.
Thank you so much. You guys have a lovely day.
Thank you. Moving on to our next speaker, I'd like to introduce Dr. Udipya Goswami, who is a consultant medical and hematologic oncologist at SP Medaford Hospital, Kerala, India, a gold medalist with MBBS, MD, DMB, and ASCO qualifications. His clinical interests focus on comprehensive cancer care and hematologic malignancies. He also serves as the OncoDaily hub leader of Thiruvananthapuram, current treatment strategies for metastatic bladder cancer in the area of precision oncology. That's going to be her topic today. If any hurdles there, we can take a short break so we can manage this. gold medalist with MBBS, MD, DMB, DRMB, and ECMO qualifications. His clinical interests focus on comprehensive cancer care and hematologic malignancies. He also serves as the OncoDaily hub leader for Thiruvananthapuram Puram. He'll be speaking on current treatment strategies for metastatic blood cancer in the area of precision oncology. Thanks for joining. Please share your slides with us. Sorry, we can't hear you properly.
Yeah, I think I had some technical issues. Are you able to hear me now?
Yes, it is resolved
Yes.
now.
Yes. Thank you so much for inviting me. Thank you, OncoDaily, and thank you, Susanna, and the entire support team in
Thanks for
OncoDaily.
accepting the invitation.
Yes. Is everything okay? Shall I share the screen now?
Yes, please.
Yeah. And is my screen visible as well? Like, are my slides visible?
Yeah, I guess it's okay.
Yeah. Thank you. Then I'll go ahead, right?
Please.
Yes. So thank you all. Good evening, good afternoon, and good morning to different parts of the world. And I am Dr. Udiptya. Thank you for the kind introduction. And I'm going to present the current treatment strategies for metastatic bladder cancers in the era of precision oncology, but with a perspective of LMICs. We have come away from where we began. We had the era of 1980s with cisplatin, and then followed by the MVAC. And after the MVAC, we had in 2015-16 there was this revelation of all the immunotherapies that came into the picture. We had nivolumab, we had pembrolizumab, as well as the avelumab, and then slowly the enfortumab vedotin and other drugs came into the picture. So we have truly come a long way from where we started. Now we have to also understand that now we are in the era of biomarkers, and when we talk about biomarkers, we have to understand that almost 20 to 25% of the patients of urothelial carcinomas have some form of germline mutations. In there are some studies which say that around 25% patients can have some germline mutations. Other than that, we are in the era of FGFR mutation testing. So FGFR mutations are also present in 10 to 15% of the patients, as well as the HER2 positive tumors are as well as there. But you have to understand that not all tumors, not all mutations are created equal. So that has to be kept in our mind. And there are some variations. HER2, as we all know, is different in breast cancer, in gastric cancer, as well as in bladder cancers. So what trouble do we face in metastatic bladder cancers are that when we start treating in the initial non-metastatic phase, for example, in the first line therapy, we have a good attrition. We have a good amount of patients who are taking treatment, but the difficulty starts when we go to the second line, or if we say that in the metastatic setting, is that the patients who end up receiving the second line therapy is actually only 37%. So that is a significant drop. Now, why does this happen? Is because bladder cancers are generally at an older age, so 60 to 65 years, and then after the first line of management, it may be surgery, or it may be what we call the pembrolizumab or the platinum. We tend to see that we lose these patients because of age as well as because of other comorbidities. So only 37% of the patients end up receiving second line therapy, and if we go for third line, it's even lower, it's 11.8%. So the attrition rate challenge is very much there in bladder cancers, and we know that we did not have much beyond platinum or beyond gemcitabine cisplatin or gemcitabine carboplatin for a long time. For the last 2 decades, before 2020, we did not have much. So putting these patients on taxanes and other chemotherapy regimens were difficult at that age. Now, besides first line, we should understand that sequencing and the optimization is very important. And now, as per the NCCN guidelines, when we see that, I'll soon come there, is that when we come to the NCCN guidelines, we see that in the first line, be it cisplatin eligible or ineligible, we have pembrolizumab and enfortumab as the first choice, be it cisplatin eligible or not eligible. Now, other than that, when I'm talking about from the LMIC perspective, you have to also understand that enfortumab vedotin EV is not readily available in our country, and I think as that must be the case with most of the countries, be it low middle income or even upper middle income countries. The access to EV is difficult. Now, at that setting, we have to understand that we have to base our treatment on obviously platinum with gemcitabine, but then with the other generic options of nivolumab which we have. So generally, if a patient walks into our OPD on a particular morning, we would be really tempted to give that patient of metastatic bladder cancer with gemcitabine, carbo, or cisplatin with nivolumab. So that is where we come into the first line. Now, the second line, we obviously have other options. We have biomarker driven therapy, we have the DDM-BAC, but to be fair, we rarely use DDM-BAC in our practice because of various issues with febrile neutropenia with infections. Now, coming to the beyond the second line, obviously there are some sequencing, and I'm going to talk about that in the further slides, of whether we have given immunotherapy at the first line, then what happens in second line, and vice versa. Now let us come to the ASCO 2021, is where we get some good data of the Keynote 052, the first line pembrolizumab data, where in cisplatin ineligible advanced urothelial cancer. And I think the investigators were really right here, and they were trying to find out alternatives to a cisplatin ineligible advanced urothelial cancer. And then they found out that after 24 months of treatment that they continued pembrolizumab, they got decent amount of ORR, they got decent amount of PFS and OS, and the safety signals were also good. And then once they followed up, they found out that the tailing of the curve was also significant. And then after the Keynote 502, there was also in the second line data of Keynote 045, where there was a hazard ratio of 0.71. And if we see that here also, even though the number of events increased as the tail of the curve improved, but then we had good signals that the IO space is opening up in bladder cancer. Then came the revelation about the ADC era of metastatic urothelial cancers, and what we are talking about today is the bladder cancers. Targeting Nectin-4 is what the enfortumab vedotin is concerned, and we understand that, be it for any of the ADCs, obviously the antibodies, they will be attached to the Nectin-4, and then there will be internalization and release of the cytotoxic molecules. The ASCO 22 came, and then we had for the first time a 24-month data of EV301, and this was very nicely done. It was a single arm study of not a single arm comparator. We saw that enfortumab chemotherapy, and there was a hazard ratio of 0.7. Even when we looked at the safety signals, we found out that obviously skin reactions were the most important thing, with 47% of all grade. But peripheral neuropathy was also significant, and I would really come to that part very soon of how do we handle with those side effects. Hyperglycemia was also there, but only 6%. So the majority of this treatment-related adverse effects were mild to moderate in severity. And if we compare to chemotherapy as well, we see that it is the peripheral neuropathy part was very significant. Now coming to the EV302 keynote A39, the long-term follow-up, which continued to show that prolonged OS and PFS benefit with versus obviously the standard of care. And then this is where we started first getting signals that EV plus Pembro, that is having an ADC with IO, makes a lot of difference for our setting. And when we see the PFS survival curve, we see that there is a very significant data and a hazard ratio of 0.48, and there is a nice curve, and there's a nice space that is developing between them over 24 months, and I think now we have gone beyond 36 months as well. And if we look at the OS, we see that the hazard ratio is 0.51. Now coming to the main important part, which is the mechanism of toxicity and how does it happen, and which is very, very important for us oncologists, because we understand that trial data would be there. There will be some statistical things here and there, but we would be managing the patients firsthand, and the problems are very real world. And I was very much lucky to actually have seen 3 patients of EV who had received during my training previously during the 2021-22 because of a trial setting. So what we have to understand is that there is a very nice term that I was taught, that enfortumab vedotin, there are 2 parts of the drug. So the enfortumab hits the skin and the eye, and the vedotin hits the nerve and the marrow, is how we remember it. So the skin rash and the ocular toxicity is actually antibody related. So the skin rash is on target but off tumor effect. So where the nectin-4 expression is seen in the keratinocytes, and the enfortumab binding happens, and there is keratinocyte injury. On the other hand, for the ocular toxicity part, nectin-4 expression is more in the corneal epithelium, so antibody binding happens, and then there is epithelial damage. But when we talk about peripheral neuropathy, it is because of the payload, as I told you, is vedotin. So there the MMAE complex inhibits the neuronal microtubules, and there is impaired axonal transport and neuropathy. And even in case of the hyperglycemia, if you see, there is MMA related metabolic stress, which leads to insulin resistance. And as always, we understand that why does cytopenia happen for any cytotoxic chemotherapy agent, which is overall the bone marrow progenitor suppression. When we come to the second line strategies in metastatic bladder cancer, we have to understand that there are some challenges. Now, in the first line, now we are having nice data in metastatic setting of having enfortumab vedotin with pembrolizumab. Now we have exposed our 2 main uh, weapons in our armamentarium. Now what happens after that? Now let us see what happens if we have a platinum. If we bring a platinum into the picture as a second line, we see that the observed response rate is only 50%. Out of that, complete response is seen in only 3%, and partial response is in 47%. So not a great data that we have for reintroducing platinum in the second line strategy. And that is the that was is where we have edafitinib. Now edafitinib is obviously a first line CLIFR inhibitor, and we are very well aware of the mechanism of action, so I won't go into detail of that. But then there are some challenges, and that we face routinely as community oncologists, is that how is the FGR testing, and not all labs are capable enough to do that. So the eligibility for FGFR inhibition requires patients to undergo testing, and that testing is ideally occurs at the time of diagnosis of the metastatic disease. So though you have to understand that we should be able to offer these tests to the patients at the second line setting, and that we have good enough data now to support FGFR3 inhibitors. And coming to the data, if we see that the Thor data, the Thor 1 data, there were 2 cohorts in that data is one was obviously edafitinib comparing with chemotherapy. We found that the median OS was 12.1 months versus 7.8 months. In a median follow-up of 15.9 months, there were a lot of analysis done, and we see that edafitinib did show a good significant data in OS, and the hazard ratio was 0.64. There were discussion on the presence of mets and the PDL1 being low or high category. I think irrespective of all the data that we have, if there is a FGFR3 mutated tumor, we would be really tempted to give it in the second line. Now, coming to the safety profile of edafitinib, we understand that there are obviously possible serious TRAEs with edafitinib that is possible, and if you look closely, that there were discontinuations in this arm, and around 11 patients had discontinued. Most of them they were having the eye disorders, skin and subcutaneous disorders. So that was very important. But another side effect that we handle routinely in our practice is hyperphosphatemia and diarrhea. So these are the two areas that we have to be very careful, and understanding the right way to taper these drugs and monitoring phosphate levels is very important. And I thought that that is also important for us as a community oncologist to know that, and that's why I put them in one of few slides coming in the later half of the presentation. When we are about FGFR, when we are talking about inhibitors, edafitinib, we often think that what better can we do, because you have to understand that with the new drugs, with the new FDA approvals, there is going to be resistance, and once the patients acquire this resistance, we should be able to give them another option. So if we see what are the mechanisms of FGFR resistance, we have to understand that there are alternative receptor pathway signaling, there are some bypass signaling options, there are some resistance mutations as well as some gatekeeper mutations that can actually lead to this resistance. Now coming to is that we often tell to most of our patients that these are all chemo-free regimens, be it EV plus pembro or be it edafitinib. But is it truly chemo? Is it truly toxicity safe? That we have to understand. So there are a lot of disorders related to the eye. There are peripheral neuropathies. There are multiple issues that we have to really address with these drugs. As I mentioned that the phosphate levels, the phosphorus levels are very important, and this is the graph where we see that we generally measure the phosphate levels at mg per dl. So if we initiate, for example, at 8 mg per day and we check the phosphate levels after 2 weeks, so we see that if the phosphate levels are above 7 mg per dl, then ideally we should hold edafitinib and then wait for the phosphate levels to come. We would be checking it again almost every 5 days, so at the 25th, 30th, and then the 40th day, and then when the levels have come to a normal range of 2.4 to 4.4, then we would be starting at a dose of 6 mg per day. I'll also give you the dose wise schedule of what we generally follow and what is the ideal scenario. Before that, as I was talking about, that it is not chemotherapy who are always the villains in our practice. These are new drugs and we are learning with them. We have to also understand what are the types of cutaneous toxicities that are there with edafitinib. So the nail toxicities and the hand-foot syndrome. So how do we prevent this nail toxicities is by avoiding prolonged contact with water, repeat trauma, the friction, pressure on the nails and nail beds, and obviously using the topical emollients, loose fitting socks, footwear, maybe avoiding the use of nail polish and removers. We can avoid cutting, ask them to avoid cutting nails, and using some Epsom salt soaks or vinegar soaks. And these are prevention strategies. Now, how to manage if there is a nail toxicity? I think topical and oral antibiotics to prevent secondary infection and to give a treatment break. So as we can see that ankylosis and paronychia is very, very common. In case of hand-foot syndrome, I think it comes in a similar way of how we have been handling the various other TKI related hand-foot syndromes, where we use a prophylactic removal of the hyperkeratotic areas, using of moisturizing creams, avoiding lotions with alcohol. And on the other hand, how do we manage is a topical or oral antibiotics for similarly for the infection and giving a treatment break. So I was just talking about the dose modifications, and so how do we start? So we start at an 8 mg once daily dose. We check for these serum potassium levels 14 to 21 days after the initiation of the treatment. Now, if the serum phosphate levels are less than 9 mg per dl, then we can actually increase and go to 9 mg once daily. And if there are no ocular disorders or any grade 2 or more than that adverse reactions. Now, if the serum phosphate levels are more than 9, then we should actually check for the next part, which is we should start tapering the dose. So, for example, if we have started at a dose of 9 mg once daily, then we should actually come down to 8 mg. Then the second will be 6, 5, 4, and onwards. And then similarly, if you have started at 8 mg, then it will be 6, 5, 4, and onwards. Now coming to the other targets, and I think I was going to there has been a lot of discussion happening on the role of HER2 in metastatic uh, urothelial cancers. So now we have to understand that HER2 assessment has been always inconsistent, and we have not been able to really hit the bullet on what is the ideal way to do it. HER2 positivity can vary across the anatomical location, stage, histology, or the primary and the metastatic sites. And the prognostic role of these are uncertain. So there is a lot of data, a lot of promising data coming, and I think HER2 is there everywhere, to be fair. So now coming to obviously I think previous speakers have also discussed about the Destiny Pan Tumor 02 trial, which was the TDHD used in the HER2 expressing bladder cancer. They found out that in the patients who had, so they were divided into the bladder cohort, were actually divided into three parts, either the IHC3 plus, the IHC2 plus, or all patients. In the IHC3 plus, they found that the ORR was actually 56.3%. In the IHC2 plus, it was 35%. So this data of the Destiny Pan tumor obviously gave them the accelerated FDA approval for patients of unresected or metastatic HER2 positive solid tumors that we are aware. So as my God, so everywhere, and somehow trastuzumab deruxtecan has also entered every guideline of all parts of the solid tumors, be it NCCN or ESMO guidelines. Now coming to the emerging options that the HER2 targeting ADCs. Now, as I told you previously as well, that 15% of the bladder tumors have high expression of HER2, and even though it is high, there are some low tumors as low HER2 low tumors as well. So 20 to 25% of them do have low tumors. So there are some new HER2 targeting agents which are coming into the development. That is the disitamab vedotin, the DV, that is the anti-HER2 and antibody with the MMA payload. And there is a lot of promising data which has come from China, and we are actually waiting for the phase 2 and the phase 3 trials, which are going to be I think they're already accruing data patients for that. There is one more interesting area of discussion for metastatic bladder cancer is the phase 3 trial of the disitamab vedotin plus toripalimab, and whether this data also really stands up. So we have a very nice study design where patients were taken with HER2 IHC of 1 plus, 2 plus, and 3 plus as well. And these were the patients also who were cisplatin and carboplatin eligible. So the study arm was DV plus toripalimab, and the standard arm of obviously the gem cisplatin or the carboplatin for a maximum of 6 cycles. And the dual primary endpoints were obviously PFS and OS. And it was seen that there was in the recent ESMO 2025, they showed that there is a nice signal which is coming, and there is some obvious data on ORR. Now, one more thing that we have to understand is that, as I was talking to you, is all biomarkers are not the same, and we have to have a rationale of how we are going to sequence our ADCs, because more and more ADCs are going to come into the market, and we have to choose. And for us, we are basically one just sitting across the table with the patient. We have to discuss with them about frankly about what would be the best benefit provided the financial situation of the patient, because as I was discussing in India and also in the other countries, actually the insurance doesn't take care of a lot of things. So it is mainly self-financed, so we have to give them the most financially feasible, the most logistically feasible approach. So for that, what is the rationale for ADCs? To understand that FGFR3 and HER2 alterations co-occur very uncommonly, and that is less than 5%. So as FGFR3s are enriched in the lume P, and the HER2s are in the lume U. So now the thing is that FGFR3 alterations and TROP2 expressions do not co-occur commonly, only in 20%, as TROP2 is enriched again in basal or squamous and luminal use. Now the Nectin-4 and the HER2 alterations can also co-occur in one third of the patients, and Nectin-4 and TROP2 can actually expression is common but not completely overlapping. So the resistance mechanisms do not overlap across ADCs, and these intricate details we should understand, like what is the correlation of FGFR3 with HER2 or FGFR with TROP2, netting with HER2, and all those things. So there are excellent drugs which are coming in the pipeline. We have the sacutumumab tirumatican, and then we have sacutumumab govitecan with pembrolizumab, and there are sacutumumab govitecan with bladder plus RT. All these things have been coming in muscle invasive bladder cancer. But when we are talking about the metastatic setting, which is there is data coming up on sacutumumab govitecan with atezolizumab, and also various combinations which are targeting effectively the TROP2. There was there was a phase 3 data on Tropics 04, where sacutumumab govitecan was compared with chemo in pretreated advanced urothelial carcinomas. And then when the data came out, we found out that the median OS was 10.3 months versus 9 months. And the primary endpoint was not met. The hazard ratio was 0.86. And as we all know that sacutumumab govitecan SG is not a very easy drug to handle. And thus, on October 18, 2024, the FDA accelerated approval was actually voluntarily withdrawn. Then once we had the sacutumumab govitecan been withdrawn, we have other anti-TROP2 ADCs, which are the datopotamab deruxtecan, which is used in the pretreated metastatic urothelial carcinoma. And in the first line setting, the ORR was very nice, which was 68.2%, and in the second line it was 33.3%. And now talking about this drug, I'm sure that we have heard a lot about it in the breast setting, and it has been doing getting some good response. So I'm expecting the same in the bladder setting. And then, as I was talking about, is the sacutumumab tirumatican in the advanced urothelial segment, and I'm sure that this is also a drug which is going to give us good data, because already the signals are of the ORR being 45.5% in the first line setting. Now, as I told you that there has been excellent work going on, and now we have some small ADCs, and then we have the DADs of them, that is the double ADCs, and there are some phase 1 trial going on in this setting, and the ORR has been again 70%, which is astonishingly great in this segment of patients, especially in the second line. So I think what we have to understand is that the combination, the overall idea of how we should take it, especially in the LMIC setting, is that if there is a combination therapy, if the patient is eligible, I think if the PS is 0 to 2, if the GFR is okay, if adequate organ functions are okay, and the patient is eligible, for cisplatin. At my setting, I think we would be still very much interested in giving gemcitabine cisplatin or gemcitabine carboplatin, and we have generic nivolumab available, and I'm sure that we can add that in the metastatic setting as well, even though we have good signals about durvalumab. But on the other hand, if the combination therapy is not in if the patient is not eligible, then I think EV plus pembro would be a great option for these patients. In the second line, if the patient is already exposed to EV plus pembro, then I think EGFR positive, we should check the biomarkers for EGFR tumors, and then edafitinib should be offered. And always we have the thumb rule where any biomarker should be preferred over IO. So if we have any of the biomarkers in the second line setting, for example, if GFR positive tumors, or we have the HER2 positive tumors, then the preference should be for edafitinib and trastuzumab deruxtecan simultaneously. And if that's not the case, then after that we can choose for the other options. But in case, if in the real world setting, what I was talking about, if we have given gemcitabine cisplatin in the first line, then I think EV should be offered as soon as possible to these patients, that is as soon as second line, to get the maximum benefit out of it. With this, I would like to end my talk telling thank you to the organizers. It was a great learning experience for me to attend the sessions, and the speaker lineup is excellent, and I'm sure that I would be learning all throughout the day today. Thank you so much.
C'est bon, t'arrives dans le peut-être c'est comme ça. Okay, thank you very much, Dr. Goswami, for this very insightful and great presentation. We have a question from the audience we would like to right now mention. So one of the audience is asking that every patient with bladder cancer should undergo genomic and HER2 testing. In your view, which biomarker is currently the most practice changing in metastatic urothelial carcinoma?
I truly feel that the most practice changing in urothelial carcinoma would be the FGFR and the HER2, because we have edafitinib and we have good data in the THOR trial, as well as if we are talking about, as I mentioned, that 10 to 15% patients are HER2 positive. So TDXD in this segment has a great job. So I feel that HER2 and important biomarkers here.
Okay, thank you very much, Dr. Goswami, once again for the great presentation. And we would also like to thank all of our speakers for today's very excellent and insightful presentations. And we truly appreciate the time, expertise, and valuable knowledge they all shared. For now, I would like to mention that we'll have a break before continuing to our next speakers. So once again, thank you all very much. Okay, welcome back everyone to our Oncology Virtual Summit on bladder cancer. Thank you everyone for your patience during the break, and now we're going to continue with our session. It's my great pleasure to introduce our next speaker, Dr. Bradley McGregor, Senior Physician in Medical Oncology at Dana-Farber Cancer Institute, also at Brigham and Women's Hospital, and Assistant Professor at Harvard Medical School. His work focuses on genitourinary cancers, immunotherapy, and new approaches to rare and complex tumor types. Dr. McGregor? Yes.
Thank you so much. Okay. Can I get started? Do I just share my screen? Is that the best way to do this?
Yes.
Okay. I think I did already. Do you see it or no?
No, I think your presentation isn't shared right now.
Oh, 1 second. 1 second.
Yes, okay, we can see your screen.
Okay.
Yes, it's great. It's great, so you can start.
Okay, you can see it now, correct?
It's perfect, yes.
Okay, all right, so yes, thank you so much. So I was looking to decide what to talk about, and I saw the final agenda. I saw there's a lot of discussion about the role of MRD, and so I decided to switch up my topic a little bit and, think about the role of antibody-drug conjugates in bladder cancer. I think we all know that ED is the new king in bladder cancer, and when we start thinking about bladder cancer, where there's access to ED, it's really a situation of has a patient with bladder cancer or urothelial cancer had ED or not, and then we go from there. But I think as we look at the future, there's a lot more to the ADC story than EV. I'm going to sort of highlight that in the next 15 to 20 minutes. So obviously, we all know about EV302. This was a trial that really changed everything and was the first trial to spell the end of cisplatin eligibility in a frontline setting. And now we know that it's really not the standard care in the perioperative setting either, but this was a large trial that really was looked to beat cisplatin, which had never been really done before in 30 years. And so patients were randomized to either chemotherapy via cisplatin or carboplatin with gemcitabine for up to 6 cycles, or the combination of EV and pembrolizumab. So for vedotin, dose day 1 and 8 every 21 days, with pembro every 3 weeks. The EV was given indefinitely until undiscovered toxicity of progression, while pembro stopped at 2 years. Primary endpoint was PFS. And we all know that there was a dramatic improvement in PFS, doubling 12.5 months with EVP versus 6 months with chemotherapy. And this translated into an improvement in overall survival. I think what's really remarkable is you look at this median overall survival of close to 3 years. And we think back to the early studies that defined, maybe a cisplatin-based chemotherapy as a standard, where you had a median overall survival just around 12 months. So remarkable how much better outcomes are with the addition of EVP, with a response rate close to 70%, a CR rate around 30%. So really, really set the new gold standard. But as we look to the future, it really doesn't end with N4 vedotin. And if we start thinking about ADCs across solid tumors, this idea is really taken off. HER2 has been around for a long time in breast cancer, and then we had in gastric cancer, and now we're really understanding the role and importance in bladder cancer. TROP2 universally expressed, and there's options. We have Claudin 18, Claudin 6, B7H3 in prostate cancer. So there's a lot of different ADCs that are coming. And as we look at the future, I don't think it's going to be a situation of one ADC and done. And all these ADCs likely will play a role as we look to improve outcomes in urothelial carcinoma. So one, there's other Nectin-4 targets. We have different combinations. We have the bicycle compound, which unfortunately recently is not going to be moving forward. But there's also targets from Lilly with next generation antibody drug conjugates, similar payloads but different linkers, with the hope that with the different linker and antibody will get different penetration of the tumor, different toxicity profile. Because ultimately, as we think about the resistance to ADCs, we don't really quite know, is this a problem with chemotherapy issues where the chemotherapy is no longer effective, the resistance to chemotherapy, or is it a situation where there is a downregulation of the target and therefore you're not delivering the therapy to the cancer like you were initially. And I think, we don't know. We know in like something like HER2 positive breast cancer, it seems to be that HER2 is sort of dependent, it's always upregulated, but the story in Nectin-4 is still evolving as we think about the mechanisms of resistance to ADCs. So I think these are going to be important, looking at next generation Nectin-4 MMAE, next generation Nectin-4 with other payloads as well as we look to improve outcomes. What about ADCs that have sort of already made it to the big stage? So sacituzumab govitecan, this was a drug that was approved in the U.S. Several years ago based on non-randomized cohort of metastatic urothelial patients who were treated with platinum immunotherapy with SG. We saw a response rate close to 30%, a mean PFS of 5 months, a mean overall survival of 11 months. And this led to the FDA accelerated approval in April of 2021. But as everyone's well aware, we've since had a phase 3 trial, which was negative, and the FDA, they withdrew their indication. So let's take a little bit further look at that trial. This is a TROPiCS-4 trial. Large trial, 700 patients, metastatic, locally advanced, unresectable urothelial, progressed on platinum and PD-L1, good performance status. They're randomized 1-to-1 to SG at a dose of 10 mg per kg IV every day, 1 a.m. 21 days, or physician's choice. I will say that GCSF with cycle 1 was really not encouraged in this protocol as initially designed. And so here are the curves here. You can see there's a very early crossover on the curves, in the first couple months. And as you look at the mean overall survival, there is not a statistically significant difference in improvement, hazard ratio of 0.86, although there is, numerically improved 12-month OS with SG versus platinum. So it's certainly an active drug. We see, 23% versus 14% objective response rate. We see numerically higher CRs, PRs, and the PD rates are quite similar. Duration response is quite similar, but this is with toxicities. So we start looking at this overall. I think what's most concerning is you look at the treatment-related adverse events leading to death, 15 with SG versus 5 with the platinum agent. So we dive further into that, and as you look at that, it really comes down to myelosuppression, notably neutropenia, leukopenia, and febrile neutropenia, where over 10% rate of febrile neutropenia. And as we dive further into the data, we see the majority of the patients in the trial never received GCSF. It's interesting, you say, well, why do we see this here? Maybe it's the patient population, they're older, smokers, but they have similar data and similar trials in lung cancer with a very similar patient population, same dose, and it was did not have the same issues. So the question would be, could it be a situation where patients have bladder cancer and have urostomy? Potentially with the diarrhea associated with SG, is there more gut translocation? Unclear, but there were certainly toxicities which led to treatment-related deaths. I think that certainly affected the primary outcome, and it was gone. So the question would be, is SG no longer have a path forward in urothelial cancer? I think that as single agent 10 mg per kg, it doesn't. But when this trial when the SG had accelerated approval, as we think about ADCs, we had EV, the standard of care, post-platinum immunotherapy, and SG was evolving, and we said, well, why do we have to use these sequentially? Patients with bladder cancer, urothelial cancer, metastatic are often sick. They're not able to get to that next line of therapy. Is there potential to combine these two together? SG, EV, very different toxicity profiles, very different targets, and different payloads. There's potentially some synergy between irinotecan metabolites and taxanes or MMAE. So the thought was, can we combine them? And so that was the idea behind the double antibody drug conjugate, or DAD trial. We combined SG and EV. So this is a phase 1 boring design where we started at low dose, 8 mg per kg of SG, 1 mg per kg of EV, and then based on toxicities, we would escalate the dose. Primary endpoint was look at the maximum tolerated dose with safety. When we first started this, we were really worried that patients would start one combo and never get 2 drugs again. So we said, listen, when you start each cycle, you have to get both drugs on day 1, but day 8 can be held independently. And so what we saw surprisingly is that maximum tolerated dose of EV and SG was actually the full dose. Now, I would argue that at the full dose, there were significant toxicities, febrile neutropenia, mucositis, delay in treatment. That was the maximum tolerated dose only because at dose level 2, dose level 1, it was incredibly well tolerated with the caveat that patients received G-CSF support. So as we started this trial, the first 6 patients, we didn't allow prophylactic G-CSF at cycle 1. We had 2 episodes of febrile neutropenia with no other issues. And so we said, listen, if I was giving this patient, one patient was over 80, another patient was over 75, if they were getting SG monotherapy, I would probably give them G-CSF with cycle 1. So why are we not allowing it in the protocol? So we allowed it. And subsequently, as we look of the next 17 patients who enrolled, 16 of 17 did receive prophylactic G-CSF with cycle 1. And so the caveat is that the max tolerated dose would be the full dose with G-CSF support. And as you look at the DLTs, and, I think DL1, both of the neutropenic fevers had not happened with prophylactic G-CSF. The dose level 2 delay, that was actually delayed treatment, which actually wasn't due to the toxicity. It was actually from an immune-related colitis from the prior pembrolizumab, so it actually wasn't related to therapy at all. Dose level 3, though, there were significant issues. Febrile neutropenia, severe mucositis, delaying treatment from disease. So as we looked at this overall, while dose level 3 would be max tolerated dose, we think that dose level 2 would be the recommended phase 2 dose, because as we'll see, the efficacy was important, independent of everything. And as we get look at it again further, what was most notable is dose level 3, patients may have tolerated the first cycle, but they quickly dose reduced. Whereas we start looking at dose level 2, patients were able to maintain that dose intensity for quite some time. So what about efficacy? So surprising, and this is post-platinum, post-IO, all but 1 patient have received platinum, 1 patient received IO alone. We saw objective response rate of 70%, so 16 to 23 patients. You can see majority of patients had significant tumor shrinkage. We had 4 CRs, and what I will tell you is that 5 of those patients actually remain now without evidence of disease progression. Longest is over 4.5 years, without therapy for over 4 years. So really remarkable. 2 of these patients had liver mets with impressive responses. So there seems to be some significant activity. But as we know, EV is no longer stare post-platinum, post-IO, is now combined with IO. And so the question is, what's the path forward? And that's where we come with the DAD-IO trial, or DAD-IO. So this is looking to build upon EV pembro. So taking treatment-naive metastatic urothelial carcinoma of 40 patients, and we're looking to combine EV with SG in the frontline setting with pembrolizumab. So SG 7.5, EV 1.25, day 1, 8 with pembrolizumab every 21 days. G-CSF is mandated if patient meets criteria for ASCO guidelines, which pretty much every patient with metastatic urothelial carcinoma will meet. And so this trial is open and multi-center in IST, and we have over 23 patients enrolled, I believe, at this time. So over halfway to our goal, and we're really excited to see the results. And can we build upon that 70% response rate with an 85% response rate? Can we cure more patients? I do think I've cured 5 of the 23 patients on the DAD cohort, and really excited to see how this data plays out. At the same time, what about other TROP2 ADCs? So dapotamab deruxtecan, so Dato-DXd. So this is another TROP2 ADC by AZ and Daiichi. So they have had studies post-platinum, post-IO in urothelial carcinoma, and you can see a majority of these patients had received prior EV. And here we see response rate, 25%, disease control rate 31%, mean duration of response not evaluable, with a 76% 6-month DOR rate. And so I think, you look at this, and I think the fact that majority of patients have received prior EV, I think this is certainly very encouraging. And there is a trial that is currently ongoing, looking what is the role post-EV pembro, what do we do? And I think it's an important trial that looking at platinum gem versus Dato-DXd with platinum. So can platinum Dato-DXd improve outcomes versus platinum gem post-progression on EV pembro? Currently in a phase 2, looking at dose optimization of the Dato-DXd with platinum, soon to go into that phase 3. So will be an important trial. Will give us what is the activity of platinum gem post-EVP, and can we build upon that with novel ADCs? the other sacituzumab ADCs, using the same antibody, different payload. So SAC-TMT, this is a compound that is being developed by Merck. And so this was just, again, early trial. We saw, pretty impressive response rates, 45% objective response, only 11 patients. In the third line, 26%, 30% overall. As we see very few CRs, but I think really, really encouraging results. And so there's a phase 3 trial with this compound versus dealer's choice versus dealer's choice of taxane, vinflunine, which is currently open right now. So again, I think the TROP2 story, while SG, the TROPiCS-4 did not meet primary endpoint, this is still going to be an important target. But, TROP2, Nectin-4, these are universally expressed targets in bladder cancer. There's no testing we need to do them. But what about HER2? So HER2 is certainly a target. And, I think as we look at the novel ADCs and we start thinking about the linker, the new linkers are really allowing us to expand the role of HER2 as a target, because we don't need to have 3+ HER2. If we just have, some expression, as we've seen with, trastuzumab deruxtecan in breast cancer, just some expression will allow us to deliver the payload and get activity. So while 50% are high expressors, is 35 to 40% are low expressors. And so overall, 50 to 60% have some degree of HER2 expression. And so as we think about this, there's really 2 ADCs that are far along in the treatment of urothelial cancer in the US, trastuzumab deruxtecan, and then disitamab vedotin. So trastuzumab deruxtecan, again, the topoisomerase payload, and then we have disitamab vedotin with the MMAE payload. So trastuzumab deruxtecan is actually approved in the US based on a pan-destiny trial. In the bladder, there's only 16 patients with HER2 3+, but we saw is a pretty impressive response rate, 56% objective response rate, and that response rate was still prevalent in IHC 2+, although lower at 35%. So the FDA label is actually for those who are IHC 3+, but if you look at NCCN guidelines, it includes those patients who are 2+ as well. But the question really would be, do we need, is that even too high a goal? Do we need to go, could we go even lower? But, again, just highlighting the toxicities, there was nothing unusual with TDXD. I think as we look at the toxicities, EB, neuropathy is certainly the big one as you think about it, rash. When we start looking at the deruxtecan payloads, we start worrying about pneumonitis, and we start adding trastuzumab deruxtecan, we look for cardiac issues as well. What about disitamab vedotin? So we had data in China where DV was a very, very exciting result, 60% response rate in those patients who are HER2 3+ or 2+. These patients were MMAE naive, but we saw pretty exciting response rates, even those patients who were HER2 low. And so that led to a trial in China. But before we get there, I just want to say we have now data in outside of China, looking at what is activity of DV in another population. Again, very similar to what we saw in China, looking at the HER2 positive, HER2 at 3+ or 2+, as well as those who were lower, presented to you ASCO by Tom Powell's. We saw an objective response rate of 55%, CR rate of 17% in the HER2 high, but we saw very comparable response rates in the HER2 low. Now, with a caveat that none of these patients have received prior MMAE payload, right? And so the question would be, as EV becomes a standard, what is going to be the role of HER2? Are we going to preferentially give HER2 ADCs to patients who are HER2 positive instead of Nectin-4 ADCs? I think this is unclear. This is just looking at the waterfall plot. Pretty impressive, the degree of tumor shrinkage. And what we see is that it didn't really matter. We saw a shrinkage in HER2 IHC 1+, 2+, 3+. And then we had data from Galsky a year and a half ago that can we combine with EV, with pembrolizumab, and just like we saw with EV, the MMAE payloads seem to work really well when combined with checkpoint inhibitors, where we saw this response rate of 75%. And we have data now from China looking at DV with toripalimab, which is another checkpoint inhibitor, versus cisplatin gem. And this, again, took patients with any IHC positive down to 1+. We saw a 76% response rate versus 50% response rate, although quite low CR rates when we think about what we saw with EV Pembro, close to 30%. This translated into improvement in overall survival, hazard ratio of 0.54. And again, now given that data, there is a trial that's ongoing outside of China looking at DV with pembrolizumab versus platinum, again, doing that. The question really will be, again, my question is, are HER2 overexpressors more likely to have less Nectin-4, may benefit more from a HER2 ADC versus an EV Nectin-4 ADC, given that payloads are exactly the same with DV and EV, but more to come. And then finally, we have the DAD trial, but what about doing just a dual targeting ADC? So this is a compound that's being developed now by BMS in a phase 3 trial. This looks at HER3 and EGFR. Really exciting response rate, 41% response rate in the refractory setting. And so again, this doesn't require any screening or target identification. So this could be an option for all. So more to come. The phase 2 trial here is in development. So as we think about urothelial cancer, EV Pembro has certainly transformed treatment, but that's not going to be the end of the story for ADCs. ADCs will continue to develop in the treatment of urothelial carcinoma, potentially as alternative frontline treatment-resistant settings, or even as an additive option as we think about how to best improve outcomes for our patients. And with that, I want to thank you for your attention. I can open to any questions.
Okay, thank you very much, Dr. McGregor, for your very insightful presentation. And we have a question from our audience. I will read it out loud now.
Sure.
Do you think ADC combinations will eventually replace conventional platinum chemotherapy entirely in first-line metastatic urothelial carcinoma?
I do, actually. I think in the United States, where we have access to these drugs, it certainly already has replaced. EV Pembro has certainly outperformed platinum-based therapy in the metastatic setting, as well as the perioperative setting. And so as we think about where there's access, I think EV Pembro will become the standard of care. And I think as we look to the future, it's going to be building upon EV Pembro. How can we do even better with EV Pembro? Is it going to be, again, biomarker selection? Is it going to be an added approach like the DAD-IO? I think that remains to be seen. I think as we look to the future, though, I think one of the main things is going to be access, right? So we're very fortunate in the US. We have access to these drugs, and I think these are incredibly important drugs that have really transformed the landscape. And we need to ensure that we're able to get access to these drugs across the globe. In China, where they don't have access to EV, they've had access to DV for quite some time, and have sort of looked at these options where they have the HER2 1+ using this, right? So that really expands the market for HER2 ADCs, had great responses. So I think that this is a story that continues to evolve, and it's going to be important to ensure that all patients with metastatic urothelial carcinoma get access to these drugs, because I think they're incredibly important.
Okay. Yes, thank you very much for the question. And once again, Dr. McGregor, thank you for your engaging and informative presentation and sharing your valuable expertise with us today. And I would like to move on to our next speaker. And it is a great pleasure to welcome our next speaker, Dr. Timur Mitin, Professor and Director of Quality and Safety in the Department of Radiation Medicine at Oregon Health and Science University. Dr. Mitin is a recognized expert in radiation oncology and genitourinary malignancies with more than 100 scientific publications in the field. Today, he will be speaking on the role of neoadjuvant systemic therapy prior to bladder preservation, treatment in muscle-invasive bladder cancer. Dr. Mitin, are you here with us? Yes, I think Dr. Mitten has joined us, but we do not hear him yet. So once again, for today, I would like to mention that we're having a OncoDaily OncoDaily virtual summit on bladder cancer, and we will have speakers the whole day. And for now on, I think we will have a short break, and after that, we will continue with our speakers. Thank you very much. Okay, welcome back everyone on our Bladder Cancer OncoDaily Summit. And moving to our next speaker, I want to welcome Dr. Timur Metin, Professor and Director of Quality and Safety in the Department of Radiation Medicine at Oregon Health and Science University. Dr. Metin is a recognized expert in radiation oncology and genitourinary malignancies, with more than 100 scientific publications in the field. Today, he will be speaking on the role of neoadjuvant systematic therapy prior to bladder preservation treatment in muscle-invasive bladder cancer. Dr. Metin, you can join us.
Great. Thank you so much. And can you confirm that you see my slides and everything's working?
I confirm we can hear you, we can see you, and yes, we can see your presentation.
The slides.
So you can.
Wonderful. All right. Great. Well, for me to be invited to the global virtual summit dedicated to treatment of bladder cancer. I have no disclosure except for the fact that I am a radiation oncologist and therefore am biased at organ-sparing treatment approaches. Today, I will not go into the details regarding the radiation therapy itself, but rather instead we'll focus on the role of neoadjuvant systemic therapy prior to bladder preservation therapy. So management of non-metastatic muscle-invasive bladder cancer has two goals. Obviously, to cure the cancer, but doing so while minimizing the impact of treatment on patients' quality of life. And until we know how to 3D print or grow in Petri dish new fully functional bladders that human body will not reject, and with full innervation by parasympathetic, sympathetic, and somatic nerves, preserving the bladder will always be an attractive alternative to radical cystectomy that many patients choose if dissimilar cancer clinics. Because as my dear mentor and friend Anthony Zay, the best bladder you will ever have is the one you were born. Another brilliant man, a well-known patient advocate and survivor of muscle-invasive bladder cancer, was not afraid to teach that men need to be better counseled regarding impact of radical systemic erectile function, and that bladder preservation treatment should be presented to male patients not only as an organ-sparing treatment modality, but also as an erectile function-sparing treatment choice. The debate over the bladder-sparing treatment modality versus radical cystectomy started before I was born. The one and only randomized phase 3 trial in UK, the SPARE trial, closed early in 2007 due to poor accrual and high level of non-adherence to the treatment arm assignment. However, among the 45 subjects who were treated on the study, there was no difference in overall survival. Comparison of large cystectomy and bladder preservation published experiences from different institutions showed a remarkably similar 5 and 10-year overall survival rates, highlighting the fact that the local therapy choice, cystectomy or bladder radiation therapy, does not drive the ultimate outcomes, whereas tumor biology and propensity to metastasize do. This debate over surgery and bladder sparing options raged over several decades among urological oncologists. NCCN guidelines in 2013 listed bladder preservation option as a Category 2B alternative to radical cystectomy. In 2018, the Category 2B designation has been removed, and in 2020, concurrent chemoradiation therapy received Category 1 designation, same as neoadjuvant chemotherapy followed by radical cystectomy. So in our clinic, we follow the NCCN guidelines as well as the joint guideline issued back in 2017 by AUA, ASCO, ASTRO, and SUO, that all patients are seen in multidisciplinary clinics to discuss curative treatment options, which include both radical cystectomy and bladder preservation options. But today I will focus differently from NCCN guidelines and why I disagree with these guidelines. Notice that in 2026, whereas radical Category 1 treatment option includes systemic therapy options, the bladder current chemoradiation therapy Category 1 treatment option does not include any systemically active neoadjuvant or adjuvant systemic therapy recommendations. The UK National Institute guidelines disagree with NCCN guidelines. UK neoadjuvant chemotherapy using a cisplatin combination regimen before radical cystectomy or radical radiotherapy is recommended. And durvalumab is included as an option with and cisplatin based on Niagara data with neoadjuvant treatment regardless of those. So why are NICE and NCCN guidelines disagree on the question of neoadjuvant therapy prior to bladder preservation? The reason lies in the historical context of two large prospective trials, the MRC BA06 trial in UK and the RTOG 8903 trial. Let's look at these two trials in details. In the BA06 trial, patients were randomized to either neoadjuvant cisplatin methotrexate chemotherapy or no neoadjuvant treatment therapy of patient's choice, radical cystectomy or definitive radiation given without concurrent chemotherapy. An addition of neoadjuvant chemotherapy improved overall survival in patients who underwent either radical cystectomy or definitive radiation therapy. RTOG has several consecutive prospective trials, and in 1989, the trial of neoadjuvant chemotherapy MCV for 2 cycles prior to bladder chemoradiation therapy. The trial, however, was poorly designed. Initial eligibility allowed patients with serum creatinine up to 2 milligrams per deciliter and a 24-hour creatinine clearance of 50 ml per minute to be enrolled on the study and receive 2 cycles of neoadjuvant cisplatin chemotherapy and then cycles of cisplatin with concurrent therapy. After seeing significant toxicity with neutropenia and sepsis, the protocol was ultimately updated to serum creatinine 7 milligram per deciliter, still a pretty high value for a contemporary. But the damage was patients in neoadjuvant arm had significant toxicity, which impacted overall survival, but was interpreted as unnecessary and inappropriate prior to bladder chemoradiation therapy. Design study in North America, subsequent RTOG protocols reject any neoadjuvant treatments and in mandating adjuvant chemotherapy after chemoradiotherapy. That was a standard subsequent RTOG protocols. Adjuvant chemotherapy was clinical appreciation for a high risk of systemic disease progression. After all, the vast majority of patients with muscle-invasive bladder cancer from systemic disease, not from the local disease. The SWOG 8710 study showed that neoadjuvant chemotherapy improves survival in invasive bladder cancer patients who undergo cystectomy and is given concurrently with bladder radiation is largely not considered effective. The addition of IVFU to bladder radiation, a randomized trial BC 2001 in UK, significantly improved the local regional control rates, but overall survival. When I was involved in analysis of all 3 study data, we noticed that patients who completed all adjuvant chemo had numerically better bladder intact and overall survival rates. However, since the chemotherapy was not administered in a randomized way, and there was a lot of patient selection bias, our team felt that this was not appropriate for these results. So there was appreciation for the need of systemic therapy in patients with muscle-invasive bladder cancer undergoing bladder preservation chemoradiation therapy, but there was no agreement on when to administer systemic therapy. And even among famous UK oncologists, there was argument for adjuvant chemotherapy and against neoadjuvant chemotherapy, despite the UK national guidelines. One raised concern, again, mostly created by the poorly designed RTOG 8903 trial, was over the issue of inability to deliver chemoradiation therapy due to toxicity caused by neoadjuvant chemotherapy. But we have data to refute that concern. Among the subjects enrolled on UK C2000 received neoadjuvant chemotherapy. Over 90% of these patients completed differentiation therapy or chemoradiation therapy, randomized arm, and neoadjuvant chemotherapy did not compromise the delivery of radical curative treatment, and general control from chemotherapy addition was similarly found in the subgroup of BC2000 subjects who received neoadjuvant chemotherapy with no increase in late toxicity. However, of neoadjuvant chemotherapy are worth exploring. First, staging of the primary tumor, thus often reducing the need for maximum safe TURBT prior to bladder chemoradiation therapy, and making many patients with large primary tumors better candidates. And second, may guide patients and patients when they discuss local therapy choices. For neoadjuvant chemotherapy to my patients, but it was challenging, fresh out of residency training, to go against the NCCN guidelines and against the established R2G standard practice. Retrospective study from Princess Margaret Hospital in Canada validated my approach and provided additional. At Princess Margaret Hospital, all patients with muscle-invasive bladder cancer were offered neoadjuvant chemotherapy, and then was offered to patients with either stable disease or response, and radical cystectomy was offered to patients with regression in the absence of development of distant metastases. 57 analyzed patients, 2 and 0 disease. 1/4 had hydronephrosis, and about 20% of variant histology. Initial maximum TURBT was performed in 70% of patients, completed planned adjuvant chemotherapy with half requiring, and 100% completed definitive therapy. Bladder intact, disease-free survival, and overall survival rates were very similar to other publications in the UK. But what was interesting is the association of residual disease at cystoscopy after neoadjuvant chemotherapy with bladder intact disease-free survival. On univariate analysis, profound factor associated with bladder tumor recurrence. So patients with residual after neoadjuvant chemotherapy had 5 times higher of failing bladder preservation than patients with clinical complete response or neoadjuvant chemotherapy. Study empowered me to reject NCCN guidelines and to routinely recommend neoadjuvant systemic chemotherapy, and then reevaluation, cystoscopy, and discussion and ID of local therapy options, with as well as the patient's preference driving the final decision regarding or bladder preservation with chemoradiation therapy. Based on the result of my trials, most patients with localized muscle nowadays start with either Niagara protocol, neoadjuvant chemotherapy with durvalumab, or combination of EVP therapy. And this is a great development radiation oncologists because we anticipate a much higher rate of clinical response. The PathCR in the Niagara trial was almost 40%. Response with staging with EVP regimen was seen in 66% of and achieved PathCR. With this approach, patients with localized cancer after contemporary neoadjuvant immunotherapy become great candidates for organ preservation with chemoradiation therapy and do not need to undergo radical cystectomy. The most interesting question is whether radiation therapy will even be needed for patients with muscle-invasive bladder cancer desiring bladder preservation treatment. Based on success EVP, Pfizer is now launching the trial comparing versus chemoradiation therapy for localized muscle-invasive bladder. Very excited to support this study at our institution. Time will tell, of course, but I suspect that the future of localized muscle invasive bladder cancer treatment will be systemic therapy alone, with radiation therapy reserved only as a salvage option for patients with localized disease persistence, and radical cystectomy reserved only as a subsequent and therefore an salvage options for patients with further local disease or progression despite salvage therapy. Thank you for your attention.
Thank you very much, Dr. Mitin, for your very insightful presentation and sharing your knowledge with us. We have a question from our audience we would like to read out loud. So, new adjuvant therapy may introduce a selection bias in bladder preservation studies, since only good responses typically proceed to preservation approaches. Was the question?
Yeah. So I think what I hear as a question is, will the response to neoadjuvant systemic therapy determine selection of patients for bladder preservation versus radical cystectomy? Is that correct? Is that how I understand that question? So historically, historically patients has always been selected for bladder preservation. There were, mandated patient selection criteria, such as a small tumor maximally resected with TURBT, no presence of hydronephrosis, no presence of CIS. All these criteria were used to select patients for bladder preservations. The point is that the best selection of patients is response to neoadjuvant treatment, because with neoadjuvant treatment, often we see hydronephrosis resolving, often we see large tumors disappearing without the need for maximum safe TURBT. So I believe that the use of neoadjuvant therapy will improve and increase the utilization of bladder preservation and will minimize the need for radical cystectomy for patients with localized muscle invasive bladder cancer.
Yes, I see. Thank you very much for the answer. And for now, once again, thank you, Dr. Mitin, for your presentation. We'll have to have a short break and continue with our session.
Thank you.
Thank you. Okay, welcome everyone back, and we continue with our virtual OncoDaily Summit on bladder cancer. And I am very happy to welcome our next speaker, Dr. Vicky Thapa, faculty member at Dana-Farber Cancer Institute and instructor in medicine with expertise in genitourinary oncology. His work focuses on precision medicine approaches for advanced GU malignancies, including prostate, bladder, kidney, and rare genitourinary cancers. Today, he will be presenting on contemporary management of upper tract urothelial and urethral tumors. Dr. Vicky Thapa, can you hear us?
Yes, I can hear you. Thank you so much. Can you see my screen?
Yes, your presentation is on. I think you can start.
Okay. Hi, everyone. I'm Vicky. I'm one of the genitourinary oncologists at Dana-Farber Cancer Institute. And I would like to thank you, OncoDaily, for this opportunity. And this is one of my favorite tumor that I generally treat my clinic. So as alluded earlier, I'll be talking on contemporary management of upper tract urothelial and the urethral tumors. So I have none to disclose. So the first question come up is why this topic is important. This is important just because of the rarity of the tumor, aggressiveness, and diagnostic challenges. And also there's a complexity in the management. As we know, UTUC represents around 5 to 10% of the urothelial carcinomas, and primary urethral carcinoma is even rare, less than 1% of all genitourinary cancers. And additionally, we have limited prospective data, and guidelines just relies on some of the small retrospective series and risk stratification and multidisciplinary management. So this requires a highly specialized team to manage these rare tumors. I would like to go through some of the epidemiological data. It's UTUC is commonly found in like men in 70s and 90s, and men tend to be more have this condition as compared to women 2 to 3 times more. And also, 17% of the UTUC tumor has concomitant bladder cancer. Pilocalyceal tumors are twice as common as urethral tumors, and 10 to 20% of the cases tend to have multifocal disease. Common etiology risk factors include smoking, which is one of the common risk factors, aristolochic acid, environmental toxins such as arsenic, alcohol, and also studies have found that phenacetin-containing analgesic is also predisposed to the risk for the UTUC. More importantly, Lynch syndrome is one of the conditions that predisposes to UTUC. I want to highlight this difference in bladder cancer and UTUC because it tend to have different biology, different management. So particularly UTUC tend to have more muscle invasiveness at presentation as compared to bladder cancer, and also tend to have more metastatic disease. Also, prevalence of the Lynch syndrome is quite high in upper tract urothelial carcinoma, around 9% compared to 1% in bladder cancer. And also there's a difference in genomics. UTUC tend to have high FGFR3 mutation and more immune cold microtumor microenvironment as compared to the bladder cancer that tend to have more TP53R with genomically unstable and frequently immune inflamed. So this table highlight basically differences in the complexity of the disease of bladder and upper tract urothelial carcinoma. Also, just want to highlight few biology which is quite distinct for UTUC. As I alluded earlier, it is T cell depleted and immune cold microenvironment. I would also like to highlight that in a patient with Lynch syndrome, FGFR mutation, particularly R248C hotspot, is commonly associated with this tumor. And also high MSI high, TERT mutation, and variant histology is present around 8 to 14% of the cases. I have a case later during this presentation where I'm going to show in that patient there is a R248C hotspot mutation. Uh, so Lynch syndrome is commonly associated with UTUC. Guess colon cancer is one of the most common tumor, followed by endometrial, and UTUC is third most common type of tumor associated with UTUC. It is important to note that MSS2 and MSS6 mutation is commonly associated and generally in the elderly patients. MSS6 mutation tend to be more older patient with the median onset around like late 60s, and MSS2 mutation generally found patient which are a little younger who are in late 50s. It has clinical implication. That's why it is mandatory to test MMR status in patient diagnosed with UTUC for the therapeutic purposes as well as for the cascade testing for the family members. Now, going to the diagnosis and risk stratification, this also remains challenge in UTUC space. Imaging that is commonly done is CT urogram, but in some patients who have CKD and contrast allergies, MRI urography is preferred. Endoscopy such as ureteroscopy provide the biopsy and also direct visualization of the tumor. Cytology is commonly used but has poor sensitivity for low-grade disease. And also after those diagnostic workup, it is important to risk stratify patient, and we have AUA and EAU guidelines to stratify patient into high risk versus low risk. High risk patients tend to have tumor size larger than 2 centimeter, high grade multifocal tumor associated with hydronephrosis, invasion, and commonly associated with CIS. One of the important things that I want to highlight is there's a diagnostic challenge, as I alluded earlier. Endoscopy biopsy confirm the diagnosis, which is quite good, but at the same time, because of the thin tube and also thin muscle mass, urologists are quite conservative about the biopsy and not to complicate with the perforation. So there's a meta-analysis of 23 studies which showed that there is a 46% understaging rate as well as 32% of undergrading rate. So that highlights that even if we have a diagnosis of UTUC, that might not reflect the true risk for that disease condition. So moving to management, we'll start with the low risk and favorable. Generally, kidney sparing strategy is favored, in which laser ablation is done for low-grade tumors. Depending on the location of the tumor, especially for the distal tumors, segmental uretrectomy is done. And recently, chemoablation with mitomycin reverse gel has been utilizing in the upper tract urethral tumors. And in the Olympus trial, it shows a response rate of 59% and duration around 48 months. But this treatment is highly associated with a complication, such as ureteric stenosis in 44% of the patient requiring stenting, recurrent UTIs, and flank pain. Although it is kidney sparing strategy, however, it requires frequent surveillance with ureteroscopy, which is also not very convenient for patients. Moving to high-risk UTUC, which is a challenging situation in our day-to-day clinical scenario, which is basically divided into neoadjuvant surgery and post-operative management. This is where it becomes quite challenging to make a right decision for the patient. First of all, for the neoadjuvant therapy, we have to have a right patient selection. Patients who are eligible can be given cisplatin-based chemotherapy to downstage the tumor, and the trial have shown improvement in the clinical outcome. But also, giving neoadjuvant cisplatin-based chemotherapy will not further because that will preserve the kidney function. As we know, after radical nephrourectomy, there is worsening of the kidney function. So after neoadjuvant chemotherapy, who are eligible undergo radical nephrourectomy, and post-operatively, patient gets single dose post-op intravesical chemo, generally mitomycin, that risks the incidence of the bladder recurrence. If the patient did not receive any neoadjuvant chemo, then for high risk, pathological finding T2 to T4 and lymph node positive, adjuvant platinum-based chemotherapy is given. If patient is cis ineligible and for the residual disease, and adjuvant immunotherapy can be given as well. This is a table that highlights all the trial that we have, and based on the studies, POUT and the split dose gemcitabine phase 2 trial is good evidence that we use, and it's recommended by the guidelines. So POUT is level 1 standard of treatment after radical nephrorectomy with platinum-based chemotherapy, and that showed improvement in clinical outcome with 5-year disease-free survival and overall survival. Phase 2 split dose gemcitabine and cisplatin showed improvement in clinical outcome as a neoadjuvant chemotherapy, and it is one of the strongest prospective neoadjuvant evidence. The study showed 63% pathological response with around 19 to 20% of the complete response after the treatment. We have other trial of the immunotherapy. PURE2 tried pembrolizumab in a neoadjuvant setting, but this is not supported based on the data, but one patient had major path responder and one treatment-related death. And other trial basically was tried in the muscle invasive or bladder cancer setting, so we kind of extrapolate from that. Although PURE didn't show any like major breakthrough, but I have a case that I'll discuss later during the presentation where I utilized the pembrolizumab and improved the patient outcome. I would also briefly want to talk about the ctDNA because this is one of the emerging biomarker, and we know in the bladder cancer space, it is one of the biomarker that we utilize for prognostic biomarker, also in some cases likely predictive based on the future trial. So some of the studies, a small study shows that ctDNA positivity is associated with the worse clinical outcome. So I'll not go into detail about this, but I just want to highlight the importance of the emerging biomarker. So in metastatic UTUC, EV plus Pembro is standard first-line treatment based on the data from EV302 phase 3 trial data. And patients who are not EVP eligible, then they can be given cisplatin or carboplatin. So, and also like maintenance immunotherapy is an option. Patient who progressed on first-line therapy, there are different options, and it depends on what patient received as a first line. If patient progressed on EV Pembro, they are eligible for platinum-based chemotherapy. If post-platinum-based chemotherapy, then we can do enfortumab vedotin. And if patient exhausted all the treatment, if patient harbors FGFR2 or 3 mutation, then erdafitinib is a good drug, targeted drug. Additionally, IHC of HER2 is important because it is one of the expression which is common in urothelial carcinoma. And trastuzumab deruxtecan is pan-cancer approved. I use this medication in my clinic and seems to have good clinical outcome. So based on to keep the interest on the time, so I just want to go through some of the cases. So case 1, this is high-risk localized UTUC, a male in early 70s who presented with gross hematuria, good ECOG performance status. CT urogram showed a 1.8 centimeter left renal pelvis or lower pole calyceal tumor, cystoscopy with normal urethra and bladder trabeculations. MRI showed similar 2 centimeter left renal pelvis mass. Underwent laser ablation, but and pathology showed high-grade papillary carcinoma. IHC for MMR was negative, and comprehensive genomic panel from the tissue showed typical of UTUC genomic features, which include FGFR3 mutation, PIK3C mutation, and ARID2. TMB was quite high, which I highlighted 27.9. Due to multiple comorbidities and pulmonary embolism, nephrourectomy was postponed, and personalized therapy was started based on the high TMB. So this one, I want to highlight that in the trial PURE-02, we didn't utilize pembrolizumab, but in certain cases, we definitely. On the left side of the slide is the pre-treatment MRI, which showed around 2 centimeters of tumor in the right kidney. After multidisciplinary evaluation, we given patient 4 cycles of pembrolizumab. On the right side of the slide, you can see the post-treatment MRI, which show the shrinkage of the tumor. Patient underwent left radical nephrourectomy, and pathology showed negative tumor and no evidence of residual tumor. I also had ultrasensitive ctDNA done, which I didn't put in here, which showed like low-level ctDNA was positive and it was negative after treatment. The other case that I saw in my clinic and which I managed was a female in mid 70s with left UTUC. She was not in good, didn't have any good performance status with ECOG of 3. Initial staging showed 8.4 centimeter left kidney mass. Additional workup negative for metastatic disease. Biopsy showed high-grade papillary urethra. She received 4 cycles of GEM-CIS in different hospital, and she came to me for the second opinion and for the management with our team. And restaging CAT scan showed large heterogeneous bulky left upper tract mass with hydronephrosis, as you can see on the bottom left side of the slide. I did since I didn't have a tissue for NGS, so I patient had a blood-based to NGS, which showed FGFR3 R248C mutation, which I showed early in the slide that is a common FGFR3 mutation associated with Lynch syndrome. You can see MSI is high, TMB is very high, and tumor fraction, which is this tumor seems to be shredding DNA quite a lot, so 30%. We had a multidisciplinary discussion for this patient, and she was not deemed a good candidate for surgery because of her poor functional status, COPD on oxygen, and multiple comorbidities. As we can see on the left-hand side of the slide, the FTG intense severity of the tumor, and we gave her 3 cycles of pembrolizumab, and post-treatment PET showed decrease in FTG uptake. And tumor agnostic ctDNA showed 30% tumor fractions, and after treatment, tumor fraction dropped to 0.6%. Patient underwent left radical nephrourectomy that showed non-invasive urothelial carcinoma, and further evaluation by pathology showed that there is extensive necrosis and tumor effect with 90% of the presumed tumor mass, and only 1 centimeter of viable tumor was present in the pathology. So these 2 cases highlight the importance of the multidisciplinary evaluation and personalized treatment, and potentially organ sparing in the future for some of these patients. So my key takeaways for UTUC is germline testing is important and mandatory for all UTUC. And if you don't have tissue, then we can certainly do like blood-based testing as well. The major debate is between the perioperative systemic therapy and selecting the patient and multidisciplinary evaluation. Option of EV plus pembro is there based on selected patient, and it could be off-level that I tend to do in my clinic. Tumor agnostic approach is highly feasible based on the 2 cases I discussed, and EV plus pembro is the standard frontline treatment for the metastatic disease. Now, moving on to primary urethral carcinoma, which is one of the rare genitourinary malignancy, and it is more common in male as compared to female, and tend to affect the older patient greater than 75 years. Etiology include chronic inflammation, infection, strictures, and diverticula in female. HPV is commonly associated with this tumor, and mainly squamous cell variant, and it could be associated with multifocal disease with maybe associated with the upper tract or bladder tumor. In urethral cancer, and it varies in the location and the management, or depends on the location of the tumor. On the left-hand side of the diagram is the male urethral anatomy, which show that 21 centimeter urethral length, and the proximal urethra tend to have more urothelial carcinoma, as compared to distal urethra tend to have more squamous variant. In female, 4 centimeter urethra and proximal similar to the male urothelial carcinoma, and distal more squamous cell carcinoma. But there is also adenocarcinoma variant mainly associated with the submucosal gland. Clinical presentation include hematuria, urethral discharge, and in male, perineal pain, penile swelling, or strictures. In female, dyspareunia, pelvic pain, recurrent UTIs. In advanced disease, urinary retention is common symptoms, and there could be periurethral fistula or abscess formation. Workup include physical examination, which is key, and to look for the inguinal or lymph nodes, and if there's any evidence of the pathological lymph node mets on the physical examination. Urine cytology could detect high-grade disease. Cystourethropy is important with transurethral biopsy. Pelvic MRI is highly recommended because of the better soft tissue resolution, and CAT scan of the chest and abdomen to evaluate for the distant metastasis. This is a TNM staging. I'm not going to go through this. And management depends on the location, also size of the tumor. So this is basically mainly from EAU guidelines. So, and also depends on the male or female and location of the tumor. Our surgical colleagues does the most of the management in those cases. And for more locally advanced or metastatic disease, it's multimodal and multidisciplinary approach. If it is tumor is T3, T4, there is opportunity for neoadjuvant chemotherapy, which we basically extrapolate from the bladder cancer and followed by consolidative surgery. If not fit for the chemo radiation is an option, or radiation only is also an option. In clinically node-positive patients, systemic therapy is an option, and also chemo-RT and squamous chemo-RT is favored. In metastatic disease, treatment is similar to the bladder cancer. Now, moving on to the case one, because this is rare tumors, so we are extrapolating data from the bladder and also like some of the small studies. I want to highlight two cases, how we manage that in our center with a multidisciplinary approach and improve the outcome in the patient. Case one, a female in her 80s, good performance status, history of Crohn's disease, and colectomy many years ago with no active IBD. Initial MRI showed 6 centimeter urethral mass, and cystoscopy showed high-grade T1 tumor in the urethra. Biopsy with high-grade urothelial carcinoma invasive into the lamina propria. Comprehensive NGS showed BRCA2 mutation, EGFR amplification, and EGFR mutations, ERBB2 mutation, and TMB of 14 mutation per MB. IHC for PDL1 was 20%. I did HER2, it was 2+. And pre-treatment MRI showed 7.1 centimeter urethral mass that was protruding into the bladder neck and invading into the vagina. And there was also concern for the pelvic mets. Pre-treatment MRI, as you can see on the left upper side of the slide, showed 7.1 urethral mass. This is a sagittal view of the MRI. After multidisciplinary evaluation, we did 3 cycles of EBP, and post-treatment MRI shows 2.1 centimeter mass, which is significantly decreased compared to the pre-treatment one. I also had tumor-informed ctDNA for this patient, which is 16 variant-based ctDNA, and pre-treatment 14.85 mtm per ml, and post-treatment it was undetectable. So imaging as well as like molecular monitoring showed that there is this excellent response. So based on the excellent response, this patient is currently on pembrolizumab monotherapy. She got total of 8 cycles so far, and most recent MRI abdomen pelvis showed further decrease in urethral mass, and also now it is around 1 centimeter, no evidence of metastatic disease, and she didn't undergo any surgery, so we are able to avoid any major surgery in her case. So systemic therapy was able to downstage the tumor significantly. Going on to like next case, a male in mid-70s, poor performance status, presented with penile mass, progressive increase in size. Unfortunately, the patient had concurrent diagnosis of high-risk prostate cancer with Gleason score of 9, and he is on androgen deprivation therapy. Cytology of the urine showed high-grade urothelial carcinoma with squamous differentiation. The cystoscopy showed abnormal urethra and thick indurated urethra of the mid-urethra, and proximal is normal. Penile biopsy showed invasive, moderately differentiated keratinizing squamous cell carcinoma. IHC for PDL1 was around 50% positive in 50% of the tumor cells. I also had Nectin-4 IHC for this patient, which was high, and pre-treatment MRI shows 10 centimeter enhancing mass involving corpus spongiosum. Going to the tissue NGS with the 698 gene panel that showed FGFR3 mutations and KMT2D mutations. Since this patient presented with the penile mass and enlarging penile mass, so there could be suspicion of the penile cancer as well. So FGFR3 mutations suggest that this is likely urothelial in origin. TMB was 22.6 mutant per MB, and and also NGS showed that greater than 100 HPV sequence read, suggesting that HPV positive. On the left upper side of the slide is the PET societal view of the PET scan. I don't have the MRI because this patient received all initial workup in the outside different hospitals. And the patient referred to our Center for Multidisciplinary Management. So on the left-hand side shows a PET scan that showed a 10 centimeter everted lesion. And after multidisciplinary evaluation discussion, patient was deemed not a good candidate for surgery. So plan was to do systemic treatment. Based on the genomics and ISCs and patient performance status, so he was good candidate for EVP, enfortumab vedotin plus pembrolizumab. He received 4 cycles of treatment. During the treatment, he experienced shrinkage of the tumor. And on the right upper side of the slide shows post-treatment MRI with a significant decrease in the lesion size, 1.2 centimeter distant penile urethral area and 0.5 centimeter in the mid penile urethral area. I also had a tumor-informed ctDNA. For this patient, pre-treatment ctDNA was 184 part per million. I would like to emphasize that this ultrasensitive ctDNA is different from the one that I illustrated in earlier cases. So it was able to detect tumor DNA in the blood for the localized tumor, and post-ctDNA was undetectable. So here we can see that patient has excellent and good response to the systemic treatment, and we forego surgery at this point of time, and patient is currently on active surveillance with cystourethroskopy, imaging, and ctDNA MRD. And also, this patient is not in good shape to undergo surgery. Therefore, we thought that surgery is not a good option for him. Additionally, most recent CT scan of the chest showed some initial evidence of pneumonitis. So I stopped the treatment and just monitoring and let our urology colleague manage locally. So key takeaways for penile urethral extremely rare. Anatomical location histology dictates the management. And this type of tumor requires multimodal therapy, and multidisciplinary approach in the specialized center is the key for better outcome of the patient. And I'm highly proponent favored.
Dr. Thapa, can you hear us?
Yes.
Yes, I think it got disconnected for a moment. I can see your presentation on the last slide.
Mm-hmm.
Have you finished?
Yeah, I finished. So I was like, oh my God, I got stuck.
Oh, okay, yes.
Yeah.
So it automatically got us into the break. So, okay then. In that case, we have a question from the audience, actually. Yes, we have 2 questions here. So one of the questions is, do you foresee ctDNA becoming a routine tool for perioperative decision-making in UTUC in the near future?
Yes, this is a very good question. I do see, that is one of the biomarkers that it will be utilized in the clinic. To be honest, I use that in my clinic for all my patients, and I tend to favor more ultrasensitive ctDNA because there are different types of ctDNAs. There are 16 variant, there are 1800 variant types, so I tend to favor more ultrasensitive one. Yes, that is gonna be one of the biomarker that we're gonna utilize in our clinic. But in my clinic, I use that commonly for these rare type of tumors.
Okay, yes, thank you very much for the answer. And moving to the next question, could EV plus pembrolizumab eventually move into earlier stage high-risk UTUC management beyond the metastatic setting?
That's a very good question. I like this combination of drug very well, and I'm a person that I would love to use this in the high risk group, and I see that future coming up because we are seeing more and more in bladder cancer, and I do see that coming up in the UTUC as well. And I think even before we have the trial, in a patient who have limited treatment option, we should try off label. So I have been doing that in some of my patients, and I'm seeing good result. But certainly for the guidelines, we need a good prospective trial to have those. But I would suggest personalized therapy as well and off-label treatment for some of the patients.
Okay, Dr. Thapa, thank you very much for your fascinating and very engageful presentation. Now, we really appreciate you sharing your expertise with us. And I would like now to move on to our next speaker in our program, Dr. Alexander Zlota from Howard Sokolowski Chair in Uro-Oncological Research and Professor of Urology at the University of Toronto. He is also Director of Uro-Oncology at Mount Sinai Hospital and a staff surgeon at Princess Margaret Cancer Center. Dr. Zlota is widely recognized for his work in bladder and prostate cancer, translational research, and large international collaborative studies in uro-oncology. And today, he will be speaking on bladder preservation versus radical cystoectomy. Who truly benefits? Dr. Can you hear us? Dr. Zlota, can you hear us? I can see your screen. You have shared it and wanted to make sure. Can you hear us?
Yeah, I do. Do you hear me here?
Yes, now everything is perfect.
Can you? Yes, but can you hear?
Yes, yes, okay.
Do you hear
you can
me?
share your presentation. We can hear you, and you can put your presentation on.
Okay. Good morning or good afternoon, and thanks for the invite. So I'm going to talk about bladder preservation versus radical cystectomy and who are the real candidates for each of the procedures or both. A small hello from Toronto, sunny today, which is kind of unusual in the last weeks. And here are my disclosures. The first disclosure is that actually I'm not a radiation oncologist. I'm a surgeon, a maximally invasive surgeon, but using minuscule incisions. And so that I'm going to talk about radiation, of course, but I'm a surgeon. The first thing is that we all agree that the MIBC field is rapidly and definitely changing. And I'm going to start with a case of a 71-year-old gentleman with type 2 diabetes, EGFR 46, had cholecystitis in the past, has obstructive sleep apnea on CPAP, hyperlipidemia, has BPH, and was treated for iron deficiency. You can see on the screen the large bladder tumor, and he got EV pembro to start. This is actually the result after EV pembro, where you basically see nothing inside the bladder, a scar. A little bit of thickening, as you might see on the CAT scan, and then the entire discussion is how do you consolidate? Do you have to remove the bladder? Can you just simply monitor? Can you give TMT? And so when we think about potential of consolidation by either doing nothing, surveillance, or TMT, we have to look first at what some of the treatments neoadjuvantly provided will end up in terms of complete response. And a very nice summary was published recently in European Urology Oncology, where you can see that except maybe the blast that was approaching with Gemcis and Nivo, 50%, or the Nabucco trial that was Nivo and IPI, most of the data showed complete response short of 40%, in the ballpark usually of 20 to 40%, which still is leaving ample room for additional new treatment paradigm. We've learned that when you add an immune checkpoint inhibitor here, durvalumab, to chemotherapy, in patients who will undergo cystectomy, you clearly can see that this will provide an overall survival advantage. And that is the combination of Gemcis Durva prior to cystectomy, and then followed by adjuvant Durva compared to simply Gemcis and radical cystectomy. And please have a note of the pathological complete response, again, in the ballpark of 30 to 35%. Now, things have changed and rapidly changed recently with the introduction of perioperative EV Pembro. The study was published in the New England Journal a couple months ago. That was a Keynote 905. And this was for cisplatin ineligible or who declined cisplatin-based chemotherapy. And it's interesting because if you really look at the patient population, you can see that basically 40% of those patients had a clearance above 60 millimeter per second. Cutting to the chase of the data, you can really see now that in terms of pathological complete response, 57% of patients, compared to 8% only in the control when you only resect the tumor, 57% of those patients achieved a PT 0 and 0 on the final specimen of the radical cystectomy and lymph node dissection. And this did translate into a clear survival advantage in between EV Pembro and control, with 79% at 2 years versus 63%, and a hazard ratio of 0.50, which was fairly dramatic. Now, two comments here. First, this was achieved by the combination of EV and cystectomy. And so, yes, 57% were PT0, but that means that 43% were not PT0. And that also came with a little bit of a price in terms of side effects. As you can see that about 45% had grade 3 or more side effects, and some even leading to 19% of serious and even 2 deaths. So, as I mentioned, no free lunch here. Is not a treatment that will be completely a walk in the park for absolutely all patients, but definitely a dramatic improvement, especially for patients who had no other options in the past as they were cisplatin ineligible. Now, moving to the cisplatin eligible, another randomized study, the Keynote B15, was recently presented. Here, a larger amount of patients, about 800, were randomized 1-to-1 to in between cisplatin Gemcis, the standard of care, followed by cystectomy and observation, versus EV Pembro, cystectomy continued with EV Pembro for a total of 13 cycles after. And the primary endpoint was event-free survival and also overall and pathological complete response. Here, again, in a patient population who received EV Pembro and cystectomy and then EV Pembro or Gemcis, cystectomy and Gemcis, you see a difference, a little bit less dramatic compared to simply observation without any neoadjuvant, with an hazard ratio of 0.65 and an overall survival of 86% at 2 years and 81% in the Gemcis. Definitely an improvement, but much more narrow in terms of outcomes compared to the EV Pembro versus no treatment. So the big question is, okay, but who will benefit from surveillance, who will benefit for cystectomy, who will benefit from TMT irradiation. We know that when you actively surveil patients who have a complete response, that doesn't translate necessarily in terms of absence of requirement to remove the bladder and also absence of risk of metastatic disease. In Retain 1 and Retain 2, you can see in the series of Retain 2 that out of 22 patients with active surveillance, the orange dots are the NMIBC recurrence. The pink dots are the MIBC recurrence, so you have 3 of them. And the blue one is the pelvic node recurrence, so that 4 out of those 22 patients ultimately had still either metastatic disease to the node or muscle invasive and bladder cancer, and an additional 8 had actually non-muscle invasive, including high grade, which means that we are still struggling to truly define what a complete response pathologically is based on the clinical response. And if you go back to the Matgalski paper, where that was Gen-Cis and Nivo plus Nivo maintenance, followed by surveillance when patients achieve a complete response, or cystectomy where patients prefer to do it, or because they had no complete response. What you see in the cystectomy-free, which is the dark blue, that only a minority of patients ultimately were cystectomy-free without metastatic disease and are alive. And a way to basically differentiate between those at risk and not at risk is by using either ctDNA or more locally urinary tumor DNA. And you really can see on the right-hand side, and that was recently published in PNAS by Matt, you can see that in the future, it's likely that urinary tumor DNA will pick up the local recurrence, whereas the ctDNA will pick up persistent of micrometastatic disease. But this is still in investigation and is not ready for prime time. So I'm going to conclude the first part by saying that bladder preservation nowadays is feasible but challenging. It is challenging because despite very spectacular complete response rates after the new immune checkpoint and EV combination, patients can achieve about 57%. But the current methods, unfortunately, cannot reliably predict who can safely avoid cystectomy or consolidation, because our prediction of PT0 is clearly imperfect, and that the best available tests, whether ctDNA, that was just recently discussed a couple of minutes ago, MRI, genomic markers, have low sensitivity, which means that one patient up to 4, up to 5 with an apparent complete response may still harbor residual muscle invasive disease. And that's why I think I made a plea recently, and I continue to make the plea, that patients should be enrolled in trials as much as possible, rather than assuming that with 57% of complete response, we can actually safely monitor all those patients. The excellent outcomes were achieved by the combination of neoadjuvant systemic therapy plus cystectomy, not alone. And I have to say, coming back from the AUA, that I've heard many colleagues stating that given the PT0 rates after EV Pembro or complete response rates after neoadjuvant chemotherapy, consolidation by TMT is the way to go. We should, when you have a complete response, let's consolidate by TMT. But I would like to bring a word of caution as well, because you see this blank slide. This is a blank because there are actually no data to fully support that. And so I spend the first half of my talk to basically demonstrate how good now some of these systemic neoadjuvant treatments are, but we're still not there yet where we can safely, absolutely say we can either not consolidate or move away from cystectomy for those large tumors that require some neoadjuvant chemotherapy or systemic therapy. This being said, there are absolute good candidates now for TMT and bladder preservation. And I think we and others have made many people rethink radical cystectomy as the only choice for patients with muscle invasive bladder cancer. But that doesn't mean pushing for TMT for all patients in the absence of data. And so, as we know, radical cystectomy has been the traditional gold standard for muscle invasive bladder cancer. That was a combination of the bladder removal and lymph node dissection. But we have also seen a paradigm shift in the treatment of many cancer types towards organ preservation, which usually combine limited resection and chemoradiation, known as trimodality therapy. In muscle-invasive bladder cancer, TMT includes a complete TURBT. You completely resect the tumor. This is followed by radiation and the radiosensitizing chemotherapy. And the most robust data, and I'll allude to that in a couple of minutes, for bladder sparing, and if the question that I had today is who are the best patients, these are select MRBC patients with unifocal clinical T2 tumors, less than 7 centimeter, without extensive carcinoma in situ, no or minimal unilateral hydronephrosis, and a good bladder function. And by definition, the chemotherapy will radiosensitize. The chemotherapy will be provided to as a radiosensitizing agent. In the past, several studies have shown, but these were non-randomized, non-comparative studies, that for these patients, the TMT for muscle-invasive bladder cancer does provide very encouraging results in terms of bladder preservation. There are some popular myths that are believed to be contraindications to TMT. Some of those myths is that patients should not have hydronephrosis. Hydronephrosis is usually a surrogate for more locally advanced tumor, but unilateral, not major hydronephrosis is actually permissible, although bilateral not. Results will be clearly suboptimal. That patients should not have carcinoma in situ, but not carcinoma, all carcinoma in situ were created equal. So extensive multifocal CIS is a contraindication because it's a surrogate for bladder instability. But if you have a little bit of carcinoma in situ at the vicinity of the tumor, this is completely permissible and actually comparable outcomes will be achieved. There's also the myth that every single bladder radiotherapy will lead to a small shrunken bladder. Not to say that bladder radiotherapy is without complication, but to think that all of them will lead to that is absolutely not accurate. And last but not least, is that if patients fail and require a cystectomy as salvage, this will end up with poor outcomes. Our series, the Manchester series with Noah Clark, the MGH series really show outcomes really comparable to primary radical cystectomy in centers which are actually used to perform post-CMT surgery. Another myth is that histological variants cannot be treated. You have to be very careful with pure variants, but very often you're going to have the combination of urothelial with a variant, and you can see here that the outcomes are relatively similar. What about quality of life? Well, quality of life is most of the time kept, and both TMT and RC result in acceptable and comparative quality of life. There's also this kind of an intuition that cystectomy leads to very, very poor quality of life. All the data don't show that. They show actually that quality of life after cystectomy as well is actually very, very acceptable. But both results ultimately, like in the SPARE trial, to something very, very equivalent. And a recent meta-analysis actually supported that comparable oncological outcomes for select patients, and definitely good quality of life can be achieved with TMT. So the summary is that the ideal candidates are patients who are fit for chemoradiation with small amount of variance, single primary tumor completely resected, no residual mass, good bladder function, because ultimately to keep the bladder, you have to have a good bladder function to start with, and also no or localized carcinoma inside you. Now, if you have a large primary with a residual mass, this is not a great candidate. If you have bilateral hydronephrosis or severe unilateral, that's a poor candidate. If you have pure squamous or adenocarcinoma, that's not a great candidate. If patient starts with very severe lower urinary tract symptoms and you're going to irradiate that bladder, this can only make things worse. If you have widespread carcinoma inside you, this is clearly a risk of popping out another tumor during follow-up. And of course, if someone has a contraindication to radiation, like a prior radiation to the prostate, for instance, it's also a contraindication. Since many years, actually 2 decades, we have a multidisciplinary bladder cancer clinic in Toronto. I'm going to go and head to the clinic in 2 hours this afternoon, where uro-oncologists, radiation oncologists, and with support of the medical oncologist, provide second opinion for bladder cancer cases where we discuss bladder preservation, cystectomy, TMT, or both. And that provides a simultaneous assessment by expert urologists. It's patient and family friendly, so that patients have a one-stop shop where they can actually be seen by all the specialties at the same time, which will end up with a decision the same day. We are helped by our bladder informatics system, where we can literally follow the course of those patients. Green is absence of recurrence, red is something showing up on CT, and yellow is usually dubious or suspicious. We have been treating patients with TMT, and what we've also have done to improve the outcomes after the full resection is at the vicinity of the tumor to inject lipidol. Lipidol can be seen on the CT, and so that whether the bladder is completely distended or the bladder is completely collapsed, this enables our colleagues from radiation to literally target without having to boost much radiation around the tissue, because the bladder is actually moving. And we also treat the nodes, and we use usually hyperfractionation and 20 fraction at 55 grade now. TMT works, but TMT works provided that patients are willing to have a very stringent follow-up, because you need to pick up the recurrences local, but also at distance in a timely fashion. And that means cystoscopy every 3 months for the first 2 years, every 6 months for the 3 following years, and every year lifelong. So what are the data? The data were recently, or 2-3 years ago, shown by our group. We did a study that was not randomized, because absolutely all the randomized studies closed early due to lack of accrual. And many of us are very, very skeptical that there's going to ever be a randomized study between radiation, TMT, and radical cystectomy. And so in the absence of data of the randomized, we compared the TMT to RC in matched cohorts from multiple institutions. We published this 3 years ago in Lancet Oncology, and that was a combined effort by surgeons, radiation oncologists, medical oncologists from Toronto, from USC in California with Ziad Danishmand and Jason F. Satu, co-leading radiation oncologist at Harvard Medical School, Mass General. What we did was to accrue 722 patients with clinical stage T2 to T4, 440 radical cystectomy, 282 TMT. And absolutely all those patients were eligible both for TMT or RC. Those patients all had very specific criteria. solitary tumors less than 7 centimeter, no or unilateral hydronephrosis, no multifocal carcinoma in situ, and all those tumors were completely resected. We use propensity score for matching patients, and we also looked at differences in survival using two types of analysis: propensity score matching, match 3-1, and IPT2W, which we had really two different ways to match the cohorts. And we use multiple endpoints: overall survival, cancer specific, distant free, pelvic node failure, disease free survival, and met free survival, with our primary endpoint being met free survival. And this was performed as intent to treat. The covariates for matching were age, sex, CIS, clinical stage, BMI, hydronephrosis, neoadjuvant chemotherapy, smoking history, and ECOG. The first question that everyone will ask is how many patients who underwent radical cystectomy were eligible and did fulfill those criteria? Roughly 30%. You see that the cohorts were different before matching, but overlap after matching. 75% were men. The mean age was 71. 10% had hydronephrosis, and 51% had neoadjuvant or adjuvant chemotherapy, with 90% CT2. And these are the results. For those, again, select patients, the met-free survival, whether using IPTW or PSM, was exactly the same. The curves are exactly the same. Cancer-specific survival, exactly the same. A little bit of improved overall survival, but that was driven by one single center and probably due a little bit to chance rather than true biology. If you compare patients who had radical cystectomy and neoadjuvant chemotherapy versus TMT, because all patients in TMT received chemotherapy, again, absolutely no difference in DFS, MFS, or CCS. But that was an intent to treat, which means that the superposable curve were also taking into account that about 15% of patients underwent a salvage cystectomy. But when they underwent a salvage cystectomy, the outcomes were exactly the same. And this was achieved, the results were achieved irrespective of the cystectomy, whether patients were treated in LA, Toronto, or Boston. You can see the curves were exactly the same. So as I mentioned, 30% of the patient require cystectomy. So the equivalence in outcome is actually pending that everyone understand that about 10 to 15% ultimately will end up having a cystectomy. That another 20% will have NMIBC recurrences. But that doesn't mean that cystectomy is a bad option. In those 440 patients with clinical T2 disease, you see that about 44% had PT3 and even 26% had N-positive disease. And 2.5% of perioperative mortality, 39 nodes removed, 1% of positive surgical margin, ended up with a cancer-specific survival in the cystectomy group at 83%. So that shows one thing, is that it shows that those select patients are equally served by TMT and radical cystectomy, but that by no means cystectomy is a bad option in those patients. And so this large multi-institutional contemporary study provided the best evidence to date in the absence of RCT supporting TMT for select patients with MIBC, but didn't support that RC is not a good option. It simply supported it's not the only option for these select MIBC patients, and that patients should be offered the possibility to discuss bladder preservation and cystectomy. And cystectomy shouldn't be offered to good candidates, whereas radiation should be offered to patients who are not candidates for surgery. However, the study does not show that large tumors responding to NAC or EV treated by TMT will end up with similar results. Again, stressing that those patients were completely resected and then were given TMT afterwards. Our study and others have led to changes in the guidelines, AUA, ASCO, SUO, where clearly now it's a strong recommendation to discuss TMT in the presence of select patients. Can we try to improve? Yes, we can try to improve. Several studies like the NRG 1806 is comparing chemoradiation to chemoradiation and immune checkpoint adhesion for 27 weeks. The Keynote 992 is giving Pembro with TMT or TMT and placebo. The BL13 is randomizing patients to TMT and adjuvant durva or surveillance. And at the time of complete response after EV, some studies are actually ongoing. This one is from Houston. Patients with T1 and 4 and 2 or T4 and 0, no distant mets, EV Pembro given pre-treatment. If patients have a complete response or partial response, they are eligible for radiation with hypervaccination in EV, and then there's follow-up with or without cystoscopy and systemic therapy up to the discretion. But again, this stresses that we don't have a lot of good data about TMT after complete response, including in the patient that I showed you initially in the introduction of the talk. Shout out to my colleagues and friends from Vancouver, Marie-Pierre Saint-Laurent and Peter Black. They are leading the NeoBlast study. The NeoBlast study is standard of care of neoadjuvant therapy in CT2 for disease. Then there's going to be a restaging, and they will use ctDNA, bladder MRI, TRBT and cytology to ensure there's no residual disease, and CT chest abdo-pelvis, with the use in the exploratory setting of urinary tumor DNA. When patients will have a complete response, then they will be randomized to either definitive treatment or active surveillance. And you can see here the follow-up with cysto, ctDNA, and CT. If they have a persistence of PT1 or more disease, they will have either radical cystectomy or TMT followed by surveillance. So the future, but probably not the present, of MIBC is that patients will receive neoadjuvant systemic. They will be restaged. Cysto, biopsy, TRBT, urine cytology, MRI, urinary ctDNA, ctDNA. When absolutely all the parameters and the lights are green, possibly some will be offered no local therapy, pending that the trials are positive and reassuring. If you still have a urinary tumor DNA, which means that there's still something locally happening, possibly they will receive radiation. When you have no clinical response, it's going to be radiation versus radical cystectomy. For the time being, probably radical cystectomy is the way to go given these ongoing studies, but we'll have to wait whether radiation maybe will end up with something equivalent. And the ctDNA, when it's positive, that means that you still have circulating tumor cells, and so the local control is not at the forefront of the problems. The systemic therapy should be switched to possibly second line. So I'm going to end up with, is this the end of TMT and radical cystectomy? No, it's not the end. We still will continue to do radical cystectomy and TMT. What I try to show you is that for the time being, the excellent results that are achieved with neoadjuvant EV Pembro, with spectacular, somehow game-changing complete response rates approaching 60%, were achieved in patients who underwent cystectomy. And so I don't think we would basically jump to the conclusion that we can safely do without in the absence of studies. And the reason is that the prediction of complete response pathologically remains really suboptimal. And it's a plea here to, rather than treat patients outside of studies, we need data. We need to enroll those patients in studies. There is no doubt that TMT and radiation is an option, especially for patients with MIBC, single tumors less than 7 centimeter, completely resected without major hydromitofocal CIS. But the results of surveillance of TMT after complete response should be provided by studies before jumping to the conclusion that all patients currently are good candidates for blood preservation or TMT. It is completely possible that this will be the case, but let's wait until we get results before jumping the gun and basically treating outside of studies. It was a pleasure to be with you.
Okay, thank you very much, Dr. Zlota, for your excellent presentation and very thought-provoking theme. And now we have a question from our audience. I would like to read out loud. So, which patients with muscle-invasive bladder cancer truly benefit most from bladder preservation compared with radical cystectomy in terms of long-term oncologic outcomes and quality of life? Was the question?
So I think a couple of comments. So a couple of comments, if I may. So the CISO trial by John Gore that was comparing bladder preservation with cystectomy. Sorry. Kind of shook the tree here in the sense that the quality of life with cystectomy remains very, very good. And I think there's this kind of misconception that people who undergo cystectomy will have a poor quality of life. That's just not true. This being said, if you ask patients, it's obvious that everyone will prefer to keep their bladder rather than having the bladder removed. In terms of long-term oncological outcomes, to the best of my knowledge, the only strong data long-term are the comparison by matching of cystectomy and TMT, but this again was for specific patients. I'm aware that some groups, like for instance in England with Ania Shiburi and Nick James, have been extending some of the indications for TMT and then also show good outcomes, but I don't know to what extent these were compared. Do you hear me?
Yes, your voice is very hearable. It's all right.
Is it okay?
Yes, everything is fine.
I don't. Sorry. I'm not sure that the comparison with the cystectomy arm are provided in a very robust scientific manner. And this is why I still think that for large, bulky tumors with cystectomy has the longer and more robust. For select patients, TMT definitely provide the same outcome. And I think several trials are now ongoing to see whether we can expand the indications, both in terms of quality of life and in terms of survival, and pushing the envelope, so to speak, in patients with multiple tumors, larger tumors, not fully resected.
I see, Dr. Zlota. Thank you very much for your answer. And once again,
and I'm fine to
Yes.
and I'm fine to join the panel if you want.
Yes, Dr. Zlota, can you hear us?
Yeah.
Well, okay, then in that case, I would like to thank again for your presentation. And for now on, continuing with our program, we'll have a short break. And after that, we'll move on with our next speakers. Thanks again.
I was saying,
Okay, welcome back everyone. And as we continue with our OncoDaily virtual summit on bladder cancer, I would like to welcome our next speaker, Dr. Gert de Merlier, Head of Clinics in the Department of Radiation Oncology at Leuven University Hospitals, where he leads the multidisciplinary management of genitourinary cancers. His work focuses on advanced and oligometastatic disease, precision radiotherapy, and metastasis-directed therapy in GU oncology. Today, he will be speaking on the place of modern radiotherapy in the treatment of muscle-invasive bladder cancer. Dr. Merlier, can you hear us?
Can you hear me?
Yes.
I don't know how to share my screen in this program. But I've sent my presentation to you this morning.
Okay, now I think we can try to share it from our side.
Yeah.
Dr. Merlier, could you please try from your side? I think you should just share your presentation.
Yes, but how do I do this? This is my question.
I think you can press H.
That's what I'm doing all the time, but maybe I can do it this way.
Yes, okay. Yes, it's great. We can see your screen now.
Is it? Great. So, bon. You see it?
Yes, we can see your screen.
Do you see my presentation?
I think we can wait for a minute because it is
because
loading.
Because it says it's processing, it's saying.
Yes, yes.
Okay, first of all, I will skip a lot of slides because Professor Zlota, hi Alexandre, has already covered a lot of TMT, which was the main subject of my presentation. So it's good news because then we spare some time. I know I'm waiting to have my presentation ready.
Yes, Dr. de Merlier, I think from that perspective, you still have your full time and you can share your with your.
Yeah, but I will not. I think that Professor Zlotta has done a great job. It's not necessary to repeat what he said. Huh? So I've now. Do you see my screen?
Yes, we can see your screen is just a.
You don't see my presentation because I just got a message. It's okay. Present. So it says now present. So should I do present?
Yes, I think you should just press it and present.
I've done that, but nothing happens.
Dr. Merlier, maybe you can try one more time, turn it off and then turn on again.
Because
let's try one more time.
So presentations, but it's uploads. I will upload it again.
Okay,
And
in that case, I think we can manage it just in a few seconds. We can go now for a short break and understand the technical issue and continue with our summit. All right?
Yeah, but is there nobody who can help me out? I mean, I've sent
sure.
everything to you
We're in
hours ago,
contact with
so
you.
I
We're
have
in
sent.
contact with you, and we will manage it together right now.
Now I get a message, the presentation source has been added and is waiting for the host to enable it.
Okay.
Voila, it's there.
It's working now, okay.
Okay. So, hi everybody, I will go a little bit faster because I don't think it's a good idea to have too much redundancy. And as I said, Professor Zlotta has covered already some important items on TMT. So I will skip the slides who are coming back too much. But I think the first one is the slide stating when you have a patient of 17 years old, which has in fact no comorbidities, diagnosed with a PT2, poorly differentiated bladder cancer, the typical histology, and you get a question, would you consider TMT as a virtual curative treatment? It's clear to see that in urologists, nearly 80%, and in medical oncologists, nearly 70% vote no. So meaning that we have still a lot of work to do as radiation oncology community. And once again, I hereby thank Professor Zlotta for defending our colors a bit. Now, very important to you, I'm from Europe, and as you might know, there are two different schedules when you go for TMT and bladder cancer. And if I'm not mistaken, the split course is often considered as the treatment of choice in United States, where people start getting treated with chemoradiotherapy to 40 gray, then get a cystoscopic biopsy, and then if there is no complete response, get a salvage cystectomy. If there's a complete response, they get consolidative radiotherapy further on. In Europe and also in Belgium, we start with a full dose chemoradiotherapy, and then we perform at the end of treatment, we biopsy, and if there's no complete response, then we go for salvage cystectomy. So the slides that are here now, I will skip because Professor Zlotta has already shared them with you. And they're identically the same, so I will skip this for reasons of time. Very recently, we have this multi-institutional analysis who was checking on several publications, and they did meta-analysis whether there was a difference between TMT and cystectomy concerning the upper limit, the upper part overall survival, cause-specific survival, or metastasis-free survival. And as you can see, the dotted line here, which is the statistical line of equality, put at 1, you see that the summary of all the studies showed that there is totally no difference near overall survival, near for cause-specific survival, near for metastasis-free survival between TMT and radical cystectomy. Don't get me wrong, this is not a plea to go for the TMT in everybody, but it is pretty considered in patients who are, for instance, very scared to lose their bladder. Of course, these studies were not randomized, but to be honest, I don't think we will have any randomized controlled trials in the coming decades. A good friend of mine, Professor Huddard, has tried to perform a randomized trial in UK comparing radical cystectomy with TMT for these kind of patients. Problem was that only very few patients wanted to get randomized because they were scared to end up in the radical cystectomy group. So I think that waiting for a randomized controlled trial is a little bit waiting for Godot. And I think the coming years, decade even, we will have to stick to these data, for instance, coming from a meta-analysis. Now, what is the standard of care? Very important is that we start with a good transurethral resection, as you can see over here. We call maximal transurethral resection of the bladder. Then you can go for neoadjuvant chemotherapy. It's not routinely used in our daily clinic routine. We go for a combination of radiotherapy and for cisplatin as radiosensitizer. The question is now, radiotherapy is a word, but its effect, is it covering a lot of different types of treatments, not only in technology, but also in prescription. And this very important paper by the group of Robert Huddard and Peter Hoskin from UK did a very nice job analyzing the data of the Beacon trial. Beacon is a trial that used nicotinamide and carboxyoxygen as radiosensitizer, and the BC2001 used chemotherapy as radiosensitizer. And in both trials, patients were treated with conventionally fractionated radiotherapy, meaning 2 gray per fraction, or what we call moderately hypofractionated radiotherapy, meaning that you give a higher dose per fraction. And here you see the results. You see that in patients that were treated in a conventional way, they received 64 gray and 32 fractions. Patients who were treated in a moderately hypofractionated radiotherapy fashion, they received 55 gray and 20 fractions, meaning that the dose per fraction was higher, resulting in what we call a higher biological dose. And the results were quite impressive. If we look at the red lines, the Beacon trial, you see that this line is the conventionally fractionated group, and the dotted line is the moderately hypofractionated group. When it comes to invasive local regional control in the bladder, you see that the hypofractionated group significantly outperforms the conventionally fractionated group. And this is also the case in the BC 2001 trial. And then they did this analysis, and they show that if we add up the results of both trials, you see that when it comes to invasive local regional control, that when you look at both trials together, that hypofractionated radiotherapy, in this case 20 fractions to 55 gray, which is more or less 2.7 gray a fraction, clearly outperforms conventionally fractionated radiotherapy. There's no difference in overall survival, but this is probably due to the fact that most patients develop metastatic disease. So this has become the standard of care in our country, and according to my modest opinion, should be the standard of care everywhere. Now, the other question is it really needed to add chemotherapy to radiotherapy, or can't radiotherapy be a standalone procedure after having performed a maximal transurethral resection of the bladder? And in this trial, with the follow-up of nearly 10 years, and using 5-FU and mitomycin C as radiosensitizer, something we don't do, but that's another discussion. The authors clearly showed that concerning the local regional disease-free survival, the blue line, which is chemoradiotherapy, clearly outperformed the radiotherapy alone group. Also, in the case for the progression-free survival concerning invasive local regional control, difference concerning overall survival and bladder cancer-specific survival were not significant. But once again, when it comes to local regional control, so preserving the bladder, the combining chemotherapy with radiotherapy is worth the effort. Which chemotherapy you have to use, this is a matter of debate and discussion, and is very country dependent. For instance, in Belgium, where I live, we mostly use cisplatin weekly, or sometimes we use gemcitabine I'm not a real big fan of gemcitabine because I've seen heavy toxicities of this regimen. But this is a personal opinion. If you look at a combination of radiochemotherapy, chemoradiation, you see that there's no dead people, so no grade 5, and that 5% could develop grade 4 toxicity, but a very important grade 3 toxicity, which means that you have a toxicity that necessitates invasive procedures, for instance, coagulation of a bleeding rectitis or coagulation of a bleeding cystitis can mount to over 30%, and this is substantial. So yes, chemoradiotherapy is quite well tolerated when you say that tolerated is no grade 4 or 5 toxicity, but grade 3 toxicity can be severe, and believe me, this can be quality of life diminishing. So we have to make our radiotherapy technology better, and I will come to that later on. This is a very recent publication of a French group who said, look, we give gemcitabine and other ones give cisplatin as radiosensitizer. Why don't we add both schedules together with radiotherapy? It was a randomized phase 2 trial, which was stopped due to very poor accrual, but also because there was no difference at all. On the contrary, the group that received the combination, which is here depicted in red, was concerning overall survival a little bit, well, not significantly, but certainly not better than the platinum-only group. And concerning disease-free survival, there was no difference at all. So it's not needed to combine gemcitabine and cisplatin together. One of the two is a perfect choice. Very important to me is that also very recently published is that T2 disease, which we see the most as a radiation oncologist, is also quite a heterogeneous group. This is published very recently, like I said, in seminars and original investigations in urologic oncology. And what these colleagues did, they made several cutoffs of the tumor size of the bladder cancer. And the best cutoff they could find was 6 centimeters. So lesions in blue depicted that are more than 6 centimeters clearly have a worse clinical cancer-specific survival or also an overall survival. You see that cancer-specific mortality and overall mortality is higher when tumor is bigger than 6 centimeters than when tumor is less or equal to 6 centimeters, which is very close to the 7 centimeter that Professor Zlotta has taught us. Very importantly, they did some very, complicated calculations with very smart statisticians and mathematics, and they ended with the conclusion that per centimeter increase in tumor size you have 1.6 times higher risk of cancer-specific mortality. So meaning that also concerning T2 disease, it's quite a heterogeneous population, and maybe we should consider tumors bigger than 6 centimeters are not, as we already know, the ideal candidates for TMT and try another kind of treatment. Now, what are then the ideal candidates? Like we already heard, completely TURB with a complete resection of the tumor, unifocal T2. Well, no hydronephrosis is of course ideal, no carcinoma in situ, and negative nodes. Very important is a good bladder function and capacity. Now, you have less than ideal, but still a very possible candidate. Is very important unilateral hydronephrosis. And like Professor Zlotta already said, carcinoma in situ in the immediate vicinity of the invasive tumor and node positivity. I come back to node positivity later. Rather, relative contraindications is what we know already, and complete contraindications is diffuse carcinoma in situ, of course, prior pelvic radiotherapy, and poor bladder function and a bad patient. But a bad patient is probably a bad candidate for every treatment of muscle-invasive bladder cancer. And I found this in a recent publication. I think this is very useful to use in your daily clinical routine. If you go from down to upwards, you see which patients are the ideal candidates for radical cystectomy. You can find them over here. If you go from the left to the right side, you see the ideal candidates for TMT. But you see that here in the upper right corner and also in the lower left corner, you see that both treatments are possible. So I think this is a very useful slide to even use in your daily clinical routine to talk to the patient why he or she should benefit more of a radical cystectomy. Other ones should benefit or could benefit more of a three-modality treatment. Now, something that we fear as radiation oncologists a lot is what we call the small bladder syndrome, or the reduced capacity bladder syndrome, or the shrinkage of the bladder, which can, believe me, which can be caused by radiotherapy to the whole bladder, and which has a very, very bad impact on quality of life, and often needs to be treated by what we call cystectomy de propriété. Of course, now with hyperbaric oxygen, we have a response rate of hematuria of around 70–75%, which is great, but a real shrinkage of the bladder will not be successfully treated with hyperbaric oxygen, and like I said, often leads to this kind of surgical procedures. And therefore, I think the future is still there. This is a very important study by, again, a group of Robert Huddard, who started to use what we call adaptive radiotherapy. What is adaptive radiotherapy? That is that you make per patient 4 plans, always with a different bladder filling. And every day you see which plan covers the best the daily situation of the bladder filling. Secondly, with this, you go for a lower dose to the whole bladder, and you go to a higher dose to the place where the tumor is. You can do it with lipiodol, like Professor Zlotta already said. There are all other possibilities like cone beam CT, like Marcus, and so on. And then he also added the dose-escalated adaptive radiotherapy, which went to 60 Gray in 20 fractions or 70 Gray in 32 fractions to the intravesical tumor. And what they saw is that when, and it's a very prudent conclusion by our colleagues from UK, when you consider a clinical absolute benefit of 10% in favor of dose-escalated adaptive radiotherapy, the pink line, as clinical relevant, you should do it. The difference was not significant from a statistical point of view, probably because the quite low number of patients, but they consider 10% difference at 2 years and also at 3 years clinically relevant. So if you would go for adaptive radiotherapy, there is no use not to go for dose escalation because there was no increase in toxicity. Here you see the 20 fraction, so the what we call hyperfractionated schedule with DART compared with the standard adaptive and with the whole bladder radiotherapy, which is treating the whole bladder. There was no difference at all of radiotherapy toxicity grade 3 or more. Also for grade 2 and more, you didn't see any difference. So dose escalated adaptive radiotherapy is certainly not more toxic than whole bladder radiotherapy, and is probably a little bit more toxic compared to standard dose adaptive radiotherapy, with the benefit that you have a higher probability of saving the bladder after 3 years. Something which I think is important, that is what to do with patients having clinically node positive but non-metastatic disease, so lymph nodes in the pelvis. Of course, this can be treated with surgery and pelvic lymph node dissection, and without any doubt, there will be systemic therapy available for a lot of those patients. But what with radical dose radiotherapy in those patients? And this is a study that was published 3 years ago in GCO, which is not, to be honest, a bad magazine. And it's a very important study, very nicely done. So all patients with clinical node positive disease defined on conventional imaging, so no biological imaging, as being a lymph node with a smaller diameter of 1 centimeter or more. And they were treated with palliative radiotherapy, or palliative treatment, sorry, including palliative radiotherapy, or radical treatment, including radical radiotherapy or radical cystectomy. you see that in the radiotherapy group, more or less 2/3 were treated to the bladder alone, and 1 out of 3 was treated to the bladder and the lymph nodes. And good news, the vast majority received the hypofractionated schedule, which is considered the state of the art. The chemotherapy was gemcitabine cisplatin, which I wouldn't do anymore, MMC, mitomycin C, and 5-FU, or Beacon, so the nicotinamide trial. And these are the results. If you see, this is the overall survival for the whole cohort and the progression-free survival. It's not good. I mean, you have more or less 25% at 2 years progression-free survival and more or less 32% overall survival at 2 years, which will certainly be better with the new systemic treatments nowadays. But if you go for radical treatment to the bladder or to the bladder and the nodes, both overall survival as progression-free survival significantly increases, with here respectively over 50% and over 40% results. In absolute differences, this amounts to 25%, which is clinically very relevant. So I think when you consider a local treatment for a bladder cancer patient with nodal disease, you have to go for what we call a radical schedule and not a palliative schedule. Here you also see that if you consider radiotherapy with radical cystectomy, there's no difference at all, although the radiotherapy arm is a little bit better than the cystectomy, but I will be very prudent and say there's no difference. And also for other endpoints comparing radical cystectomy and radiotherapy, there are no differences. Then very important, and has been a discussion point for a long time in the radiation oncology community, should we treat the nodes or not? It's a little bit counterintuitive, but till now we don't have any evidence to treat the nodes with radiotherapy, and treating the bladder alone should be sufficient. Probably because, it's my opinion, that not every node you see on conventional imaging that is enlarged contains cancer. That's one. And two, probably when patients really have clinical nodes and they are really positive with cancer, they are always or probably already gone to other parts of the body. Something for the future, also radiation oncologists perform lab research. And here you see, this is very recently published, the value of circulating tumor DNA in patients who were treated with chemoradiotherapy for their bladder with the endpoint metastasis-free survival. You see that patients who have, before they get treated with chemoradiotherapy, after they have the maximal TURB, and they don't have circulating DNA, they have a much better metastatic-free survival than when they have circulating DNA. If they have circulating DNA after they have stopped their trimodality treatment, then that's really a bad thing, and those patients certainly need further systemic treatment. Also important is that if you have a recurrence and your circulating DNA is negative, then it's mostly a local recurrence, being invasive or non-invasive, while when you have in red circulating DNA that's positive, your recurrence is mostly metastatic. So my conclusions is there is indeed an ideal candidate for TMT, and if you go for radiotherapy, please go for hypofractionated radiotherapy. One small thing I have to add, when you have an old patient who is not fit enough for radiotherapy, for chemoradiotherapy, there's a schedule from UK, which I use from time to time, 6 times 6 gray once a week, offering a very good local control and certainly symptom control. It's very good to treat hematuria, or even it's very good to treat pain, which can be caused by the bladder tumor. If you go for radiotherapy in a curative intent, you have to combine it with chemotherapy. The choice of chemotherapy is yours. I think that we can say that TMT equals radical cystectomy if we stop hoping for randomized trials and data coming from randomized control trials. Don't get me wrong, I'm a radiation oncologist working in a multidisciplinary environment. I still consider cystectomy the golden standard. But patients who are not willing to undergo radical cystectomy or for technical reasons, it's difficult, should not be excluded from information for TMT. And unfortunately, this is still happening too much in our country. Importantly to know is that most salvage cystectomies which are performed are not for toxicity, but for local recurrence, which of course is the golden standard. And I think indeed, like Professor Zlotta already focused on, the future is on dose lowering to the complete or the full bladder, and to go for dose escalation on the tumor bed using intravesical devices like Lipiodol or even clips, or using modern imaging, for instance, MRI. So this is Led Zeppelin together with me saying thank you very much. And if there are questions, I'd be happy to answer them.
Thank you very much, Dr. Merlin, for your excellent presentation, for your insights. And yeah, of course, we have some questions for you. And so we have a question from our audience. Could you comment on the role of metastasis-directed radiotherapy in oligometastatic urothelial cancer?
It's a very good question. It's my favorite item of research. Comparing to renal cell carcinoma and certainly prostate cancer, the experience in metastasis-directed treatment in urothelial cell carcinoma is very limited. It's very difficult to create a prospective trial because when patients are metastatic, they are often seen in my country by the medical oncologists, and it's difficult to convince them to go for the metastasis-directed treatment. However, I'm a believer of it, and I would always advise it to do, of course, saying to the patient, look, we don't have very high level of evidence, but if it doesn't work, we will know soon enough. I mean, you don't lose time by giving 3 times 10 or 12 gray in 1 week and then check 1 month later whether the patient is already progressing or not. So I think it's the future, but believe me, we will need European support from EAU, for instance, to start up such trials. Yeah.
So there are no ongoing trials on that topic?
Well, prospective trials, I don't think so, and certainly randomized, no.
Okay. Thank you very much. Thank you for your presentation.
But it's a good idea.
Yeah, yeah. Thank you. And now we are moving to our next presenter, who is Dr. Steven Sayedin, radiation oncologist and medical director of Genitourinary Radiation Oncology at UCSF. And today he will discuss a patient-tailored approach to radiotherapy in muscle-invasive bladder cancer. Dr. Sayedin, welcome. The floor is yours.
Hi, good morning. Can you guys hear me okay?
Hello, yeah.
All right, I'm just trying to share my PowerPoint.
See you.
Here we go. Let's do that. And then I thought I had my camera on, but hopefully you guys can at least see my screen now.
We see it, yeah.
Okay, perfect. Let me see. I thought I had my camera on, but for some reason it's not coming through. But it's a pleasure to speak with you all today. I think this is a great segue. It's interesting to see how our colleagues in the UK practice. You know, I different practice style. I mean, I'll kind of go through how I modify sort of my radiation based on the patients that I see, for sure. And I just found this really cute little figure. Actually, ChatGPT made it for me. So it's amazing what ChatGPT can do in a matter of 30 seconds or so. These are my disclosures. You know, I think it was already touched upon pretty nicely who is an ideal candidate for bladder preserving chemoradiotherapy. And I apologize, I didn't realize this would be discussed beforehand. I think a lot of this is overlapping. So those, for example, who have a good baseline urinary and bowel function, you know, for example, are patients who come in and their bladder cancer has invaded some of their urinary sphincters or made their bladder essentially non-functional, then I really do tend to push patients towards a salvage cystectomy, of course, or a cystectomy. And then bowel function is also really important. I do make sure patients don't have any major contraindications such as disease, which can be reactivated with pelvic radiotherapy, or any history of like diverticulitis and so forth, at least to counsel them about their risk of GI toxicity.
I think it was touched upon really nicely. Tumors between 5 to 7 centimeters are really ideally what we try to treat. Those without hydronephrosis, minimal or no CIS. I still think patients with focal CIS could be eligible for bladder conserving radiotherapy. And then most patients will have T2 and node positive or up to node positive prostate cancer. I think some great data was shown from our colleagues in the UK about the importance of local consolidation, either with cystectomy or definitive radiotherapy. Oh, there we go. Where did some of these criteria come from? Some of them came from, a lot of our trials in the late 80s and early 2000s that were kind of conglomerated together as a meta-analysis. So the RTOG, which is a cooperative group here in the US, which is now part of the NRG, had conducted about 6 national trials that looked at chemoradiotherapy in a variety of regimens for muscle invasive bladder cancer and examined the complete response rate. What does that mean? Complete response rate here talks about patients who are about somewhere between 40 to 45 grays into their radiation, doing a cystoscopy, and if there was residual disease or positive urine on cytology, and as well as imaging, they would go to a salvage cystectomy. But if not, they can finish out their radiation. And no surprise, these patients who have a complete response do quite well. In terms of disease-specific survival, their complete response rate overall was 69%. Disease-specific survival, you can see, does change between T-stage. So I think, part of our natural thought process is patients with more advanced T3 or T4 disease might be better candidates for salvage cystectomy. Sorry, I keep saying salvage. For radical cystectomy. You can see here the survival rates were fairly comparable. Overall survival at 10 years being 36%. There was I would think, probably higher rate than I'm used to seeing for local failures, but the majorities were non-muscle invasive and can be treated with a 2-RBT. And disease-specific survival, again, for those who achieve a CR, complete response, is quite good. When we look at some of the models that talk about risks of having a complete response or achieving a complete response, really the one that stands out is having a complete 2-RBT, which makes sense before patients go on to their radiation therapy. So I still always encourage our urology colleagues, if they're able, and I usually ask if they feel like they got all the tumor out on their 2-RBT before proceeding with chemorats. Granted, I know there's some more modern data that might suggest otherwise, but still I think it's, if possible, within good practice. When we look at the regression model for disease-specific survival, here we see again T-stage, having borderline significance on the multivariate model, as well as hydronephrosis. And to me, I will say these reflect more of just bad biology, risk of developing distant metastatic disease. And we're practicing in an era where we didn't have great biomarkers, as discussed with ctDNA in the prior lecture, to risk stratify these patients who might still be benefit from chemoradiotherapy. Looking at a more modern data set, this is a multi-institutional retrospective study that was spearheaded by our colleagues at MGH, and Dr. Zlato, I think, was a presenter earlier, and I apologize if you presented this data. I didn't realize it could be presented, but looking at patients who got chemoradiotherapy versus those who got radical cystectomy, and I think what to pay attention to, and I'm sure it was highlighted, this is what they call a matched cohort, which is what we see here on the right. Patients mostly with T2 disease without hydronephrosis, patients who either had neoadjuvant chemo or adjuvant chemo with their cystectomy. And you can tell that the adjusted metastasis-free survival rates are fairly comparable, right, at 2.5 years and beyond, and as well as adjusted cancer-specific survival. And so I think some of these criteria, and patients included studies had tumors up to 7 centimeters and focusing up, right? And so a small amount of CIS could still be acceptable. Something I sometimes hear or get asked about by my patients as well, if I do fail radiation therapy and need a salvage cystectomy, is that going to impact my survival? And the data here suggests it does not. As you can see here, patients who needed a salvage cystectomy in the red, and compared to the no salvage cystectomy patients who completed trimodality or chemoradiotherapy, their adjusted cancer-specific survival was fairly identical. And probably this is because, as our last lecture mentioned, these are mostly local recurrences, right? And local recurrences tend to not have an immediate overall or metastasis-free survival impact on our patients. So removing the bladder addresses that. I get asked about, what should I, and I would also say there's a lot of options here. I stole this from the SWOG 1806 protocol, which was a trial that looks at chemoradiotherapy with durvalumab, as well as adjuvant durvalumab. The results of those trials still pending. And I will suggest don't look at the doses here, but just really more about how you can treat bladder cancer, right? So for example, some people, and I think I tend to do this top option, where they'll treat the initial bladder to one dose, and they'll boost the tumor bed or the TUR bed to another dose. You can just treat the tumor, right? To, I would say, a boosted volume. Vice versa, on the right side, you could, if you want to treat the pelvic lymph nodes, they call what they call the mini pelvis or the small pelvis. But this also has a variety of combinations. It's similar to what's on the right, of doing a whole bladder, a small bladder approach, or even both, a whole bladder and a boost approach, which is shown here on the top. So I think, long story short, I usually tell a lot of my colleagues that there's almost no wrong way, as long as you target the right area to treat bladder cancer. I also use intensity modulated therapy. I think that's really a lot of the trials that first came out for bladder cancer. I think what was also discussed, the meta-analysis of BCON and B201 were done in normal era, meaning that their margins of error were much higher. So you're talking about treating a bigger area. Instead of expanding your bladder by a margin of error of 7 millimeters, you're going to 1.5 centimeters and beyond. And you have adjacent bowel that's usually sometimes on top of your bladder, or your rectum behind, which can increase the GI toxicity. So sometimes I do advise patients, prior data is really helpful for counseling them. The toxicity rates could be elevated as a result of that. And I'll kind of demonstrate an example of that. I thought, to make this a little more case-based, which is what kind of the moderators of this panel had asked me to do, I give you a few cases of how I approach this. So here's what I call the kind of garden variety bladder cancer that I see. 75-year-old male who has a history of colon cancer, a history of diabetes as well, but his performance status is excellent. He presented with hematuria, a test and a urogram, notes a bladder mass of the posterior wall, but no hydronephrosis present on the CT. A cystoscopy performed with a transurethral resection, notes a 4-centimeter trigone lesion with right ureteral orifice involvement, but without obstruction, meaning it wasn't being blocked. Pathology here did appreciate high-grade urothelial carcinoma involving the muscularis propria. When I met him in my office, his hematuria had resolved. He had no incontinence, he has great function, no bowel risk factors. My recommendation here was to do the kind of what was discussed before, the hypofractionated or 20 sessions of bladder-only radiation with chemotherapy. Why was that? And I think this was touched upon. This is the meta-analysis that we spoke about of 2 trials from the UK. BC2001, which was actually a 2x2 trial of radiation plus or minus 5-FU mitomycin C, but also looking at partial bladder versus whole bladder boosting for radiation therapy, and then BCON, which was radiation with or without oral nicotinamide and carbagin, which are meant to be potential radiosensitizers. Both trials had a 6.5-week regimen, which is a 64 gray and 32 fraction, as well as the 4 weeks, which is 55 gray and 20 regimen. And so they looked at local regional control at 3 years between the 2 radiation regimens. Here, when we look at the graph, you can see the dotted lines represent the 55 gray regimens, or the 4-week regimens in both arms or in both studies. And then the solid lines represent the 6-week arms. And when you kind of aggregate both trials together, they did appreciate here a beneficial hazard ratio, so a lower risk of local or improved local regional control in this 55 gray, being shown here on the graph when you look at them individually. Just to emphasize, there was no differences in toxicity, urinary or bowel toxicity in this arm. And I also will say that this again was done in an era, both studies in a what we call 3D conformal era, where margins were probably much bigger and probably incidentally treating a lot more bladder, nearby bowel and rectum. What is my general approach to designing radiation? So when we do our simulation, meaning our planning CT, I usually like to give oral contrast because, as I mentioned, I have had cases where literally there can be small bowel just right on top of the bladder. So it's good to know where small bowel ends and again, bladder begins. So I do give oral contrast. I do treat on an empty bladder, but there are actually quite a various options. You can actually do a full bladder and an empty bladder. Some people do their boost radiation on the full bladder to try to spare as much normal bladder as possible, which I think is great. I do find the empty bladder is very reproducible. The other thing I actually try to make sure is that if patients have gone for a recent repeat cystoscopy and TURBT, that I usually wait about a couple of weeks before doing their sim. I have noticed that they do struggle to empty their bladder for the first couple of weeks. So then in the middle of radiation, they're emptying their bladder better. And then what happens is more small bowel will kind of sink into your radiation field. So you have to kind of redesign their radiation. So that's just my own personal trick. Of course, we want a detailed cystoscopy report, the tumor size, the location, the involvement of what adjacent structures, if it's applicable. And this is, of course, when designing your kind of what we call the TUR bed or the TURBT bed, helps me kind of understand where to target. I always collaborate with our urologists here at UCSF. It's great. I can send my radiation design to them. And if they think, hey, you should cover this area a little bit more in the boost or whatnot, they'll give me that collaboration. Now, if you don't have a local urologist to collaborate with, or the cystoscopy report isn't overly clear, or you don't have pre-TURBT imaging, then my best advice is just to treat the entire bladder and boost it. It's a very acceptable approach. And like I said in the prior couple of slides, there's a lot of ways you can go about targeting bladder cancer. My quote margin of error, my expansion from a target, is about 7 millimeters in this IMRT or intensity modulated era. I also get, frequent cone beam CTs to make sure bladder is lining up to bladder. So empty bladder to empty bladder alignment. Here's kind of what this plan looked like for this particular patient. So again, the neon green line that I'm kind of outlining with my mouse here is the is the expansion from the whole bladder, which is in yellow. I treat this in 16 sessions initially, and then I kind of do a sequential cone down to the tumor bed, which is again outlined in that kind of pink or magenta red. And then the blue there as well is the expansion of that. The other variation, again, if you don't have great cystoscopy imaging or whatnot, is to just treat the whole bladder to itself in 20 sessions to 55 grays of radiotherapy. I'm seeing something in the private chat, so I just want to make sure people can hear me. Okay. All right. This is case number 2. This is a little bit more aggressive. So this is a 78-year-old male, admitted for left side fake pain, good performance status, but a cystoscopy notes a 5-centimeter tumor at the left bladder wall. There was obstruction of the left ureteral orifice. A TUR was performed. And pathology noted some high-grade urothelial carcinoma with macrocystic pattern. And there was also involvement of the muscularis propria. Some people ask me, well, when you see these kind of variant histologies, macrocystic and nested pattern, are you concerned? My answer is yeah. I do think it increases your risk of developing metastatic disease. However, that doesn't exclude you from chemoradiotherapy. I won't show it here, but there are our colleagues from multiple institutions, for example, in Canada, that have shown that there is just as good control in these patients compared to those who have a pure urothelial variant histology or a pure urothelial histology, pardon me. So I still offer them chemoradiotherapy. My couple exceptions to that, I will say, are small cell bladder cancer, it's pure small cell, as well as sarcomatoid bladder cancer. That's, again, pure sarcomatoid bladder cancer. And so I think those are the patients that maybe perhaps I do suggest either doing chemoradiation, like treating lung cancer in the small cell setting, or going for a cystectomy in the sarcomatoid variant because those are less radiation responsive. Continuing on to this case, MR urogram did also note some kind of, I would say, subclinical involvement of the posterior anterior bladder wall, which made me nervous. There was some enhancement. There was a pelvic lymph node here, and there was hydronephrosis present. So again, now we're seeing someone who maybe isn't as great of a cystectomy or a radiation candidate. CT chest was unremarkable. And then I actually think it makes a good segue to what was discussed in the prior lecture. We actually did get a ctDNA on him, and it was actually quite elevated. We were concerned about his occult risk of metastatic disease. I think here the standard of care at the time would have been to start, at least here in these states, is to start EV Pembro, which is what he did do. And he got 3 cycles. There was a 4th intended, and then maybe planned to go to cystectomy, but he couldn't tolerate it. The good news is his ctDNA went down to 0. And then we got repeat MR imaging, which noted a response to the lymph node, but it was still present, but it was just smaller. But there was no evidence of local clinic. In my local progression. In my clinic, he's refusing a cystectomy. So we talked about treating his whole pelvis and bladder radiation over 6 weeks. This actually I did do with more conventional, even though they were saying, well, hypofractionation, meaning 20 sessions is more standard. I think the data for that is done in a setting where actually a whole pelvic radiation was not done. So neither BC 2001 or BCON allowed for whole pelvic radiation therapy. And again, when you're treating a whole pelvis, there's a lot of GI organs in there. So I do get worried about the toxicity of that. So I still use a conventional format here of 1.8 to 2 gray per fraction, which is still acceptable, for example, for our NCCN or National Comprehensive Cancer Network guidelines here in the US. I started with 22 sessions of whole pelvic radiotherapy, which is being represented here in this kind of like green volume here, or in the blue volume is actually the dose in itself. So I apologize, it's a little messy. Phase 2 for me would be treating just the gross lymph node to 60 grays of radiation and the TUR bed. And that's kind of what this, TUR bed here is for me. And again, this includes what I saw on the MRI, what the urologist saw in clinic as well, with an expansion of 7 millimeters. And then finally, the last couple of sessions going to 64 gray and 32 sessions just to the TUR bed. This patient did really, really well overall, very minimal toxicity. They had a nephro stent at baseline that didn't get resolved, but they are disease-free to this point. My final patient is an 88-year-old male with a history of heart failure, diabetes, prior heart attack. You're kind of going to see where I'm going with this. He had a history of non-muscle invasive bladder cancer that was refractory to BCG, as well as other intravesical therapies. And so with that being said, his performance status was pretty poor. He could probably just walk more than like a flight of stairs before getting short of breath, just to give an example. He had a surveillance cystoscopy that did note a 2-centimeter right lateral wall lesion. They took it out, of course. This noted high-grade urothelial carcinoma, again, with just associated CIS, but was pretty focal. I did verify with the urologist to make sure there was no multifocal CIS on his cysto, and he did not believe so. The imaging workup was negative. Again, in my office, he's not a cystectomy candidate just due to his prior comorbidities. Now, it's funny, interesting to see, how we all approach our more frail patients. 6 grade times 6 is definitely a valid regimen. Actually, I take a regimen, which also is out of our UK colleagues, of doing 20 sessions of radiotherapy with weekly gemcitabine. I would say, from my experience with weekly gem and radiation, it's very well tolerated. Where does this regimen come from? Again, our colleagues in the UK who also looked at, BC 2001 and BCON meta-analysis, all looked at using 52.5 grays in 20 sessions of radiation. So that's the first difference, where if you appreciate, usually we go to 55 grays. So not a big difference there. But the chemo regimen is weekly gemcitabine. They had 46 patients on this protocol. And again, it's not new. It's from 2011, as you can see down there. But 90% of patients completed all patients completed radiation, but 92% of them completed 4 cycles of gemcitabine. 4 patients stopped due to grade 3 GI toxicity. Just to point out the prior lecturer's point, we do see a decent amount of GI toxicity, but to also mention that this was done in much larger volumes, right? So this study, I did look at the volumes. They're expanding from the bladder about 1.5 centimeters, where usually in my practice, again, with intensity modulated radiotherapy, as well as daily good what we call IGRT or image guidance, you could probably shrink those margins quite down. But they did not appreciate differences in bowel, urinary, and sexual function at 2 years compared to baseline. Here you can see 4 patients on this regimen required a salvage cystectomy. Only 1 of the 4 was due to toxicity. The other 3 were due to local recurrence. You can see the rates of complete response, a little different than what I defined as complete response in those initial 6 trial meta-analysis. This is a complete response at 3 months, post-radiation therapy with cystoscopy, imaging, as well as urine cytology. 2 patients, as you can see here, or 1 who had non-muscle invasive failure, and then 1 who did not have a cystoscopy done at 3 months. But I would advocate these are very high rates of complete response. And when you look at comparing this to standard of care, comparable overall survival and disease-specific survival or cost-specific survival. So I do tend to use this regimen for my elderly patients, and this is kind of what it looked like. I took what we call an integrated boost approach here. So whereas before I had different phases, 1, 2, and 3, and kind of sequentially boosting, here I just did him in one plan of 20 sessions, treating his entire bladder to 44 grays and the TURE bed, and that's what represented here in this orange area. And you can see the doses here. I should have pointed that out earlier. I apologize. To 55 grays. And this plan came out really great. The patient tolerated radiation very, very well. He's disease-free. If people were wondering about a ctDNA, it was actually negative from the get-go. So maybe there was some bias selection there. Maybe had he been positive, he might have recurred, distantly sooner, but we don't know that as a fact. But this is my usual to go to my elderly patients, but 6x6 or 7x3 is another regimen that I see is quite well tolerated as well. So lots of options in our kind of elderly or more comorbid patients. Where do I think, this is kind of the fun part, where do I think the future of radiation therapy is going? Has been discussed, obviously, for our patients who have locally advanced disease, really EV Pembro or GEMS Cisgerva has taken over this space. I think radiation is going to finally start to catch up a little bit, where we combine our anti-drug conjugates with immunotherapy and radiation. This could really redefine who we think is an ideal candidate, where a lot of the initial studies that we show, right, whether it's their tumor size or CIS, are really based on chemoradiotherapy, right? We actually don't know whether hydronephrosis or, tumor size will still play an impact in how we define patients in this kind of modern era of ADCs and immunotherapy that are actually have quite a robust response rate, right? Where we see patch CR rates of 50 to 55% or up to 60% in patients getting EVP for locally advanced disease. This is a trial that we are doing here at UCSF that is led by our medical oncologist, Dr. Vadim Koshkin. We are looking at patients who have muscle invasive disease, and this also, we did actually amend it to include node positive patients who have urothelial histology, except again, small cell, pure small cell, who go to get a TURBT, and then we're actually doing EV Pembro and their radiation. Here is brain 32 fraction, so it's not the hypofractionated regimen. This is primarily done just due to concerns of safety, at least in the phase 1B setting. And it's done at 3 dose levels. We've finished accruing to dose level 1 and 2, and we're hopefully going to start level 3 here soon. And then we'll go on to a phase 2 with a couple other sites as well. But so far, my experience, with the 6 patients I've treated on dose levels 1 and 2, thank goodness we haven't seen any, just kind of anecdotally haven't seen any major toxicities. Oh, and I should mention, the primary endpoint for this study is a CR at 6 months on cystoscopy. So I'm excited to see how that turns out. The other area that I think really radiations for bladder cancer is going to be a big impact is adaptable or on-the-fly radiation therapy. And so, what do I mean by that? Well, we're getting better and better machines that can do on the fly. So when patients are on the machine, you can actually modify the radiation volumes, right? And so, for example, the current standard is we make a plan, and then essentially when we make that plan, it gets plugged into a machine, and then we treat the same way every day, regardless, right? Now, granted, there are some exceptions to that. You can actually make a plan where you treat on a full and empty bladder, and there's some kind of adaptable options you can take, but nothing is truly adaptable, meaning that you can actually change it while they're on the actual treatment machine, right? And right now, there are a few machines. One I point out here is an MRI linear accelerator where patients can actually MR their physical anatomy in real time. And this is a great option for patients. Again, I showed this is a patient of mine on the bottom. This is kind of my tough case, right? I've kind of outlined the patient's bladder in this kind of magenta pink line, but you can see right on top against that small bowel, which makes, treating that area, especially if she has a lesion of the dome, right, or area I want to boost, right, because I could potentially put her at risk for significant GI toxicity. And you can see her rectum also has gas right behind it. So to be able to adapt or carve out radiation in that setting could be very valuable. There also are CT-based machines that can also do this as well, that are made by a variety of manufacturers. And then I'll just also make a plug for one of the national consortium trials we have here in the US called Archer. This is a trial that's really looking at 5 sessions versus 20 sessions of chemoradiotherapy for muscle invasive disease, but it has an adaptable option. So we look forward to seeing how this accrues and how this can change our toxicity rates. Just some conclusions. I think thoughtful selection or thoughtful candidate selection is still really needed when we're talking about which patients we should be treating with chemoradiotherapy for MIBC, which have been touched upon on my lecture and as well as the previous lecture. Various treatment options for bladder radiotherapy exist: whole bladders, partial bladder with a boost, right? Treating the whole pelvis or not. I think when I do these, right, I always just like to use my clinical intuition, which patients are likely more aggressive. But 4 weeks of radiotherapy can result in improved local control, was demonstrated in my lecture as well as in the last lecture. And again, for those who are at a higher risk of occult failure, I do add whole pelvic radiotherapy. Usually for those who have, for example, T3, T4 disease. Obviously, node-positive disease goes without saying. And then finally, GEM-X is a well-tolerated option for our frailer MIBC patients. But just to be very clear, there are a lot of great options that are more palliative and gentler in a regimen, 6x6, 7x3, and so forth. But with that being said, please reach out. I'm always looking for patients who have a passion, or looking for collaborators who have a passion in treating bladder cancer. I will be at ASCO. For those who are going, please reach out, and I'll take any questions. And I really appreciate your attention.
Thank you very much, Dr. Sayedin. Thank you for your presentation and your time and your interesting cases. Unfortunately, we're now running out of time and there's no time left for questions, but we will be very happy to have you joined on the panel discussion after the event. You will receive a calendar invite. And now, continuing our program, it is my pleasure to introduce Dr. Fred Ghali from Yale Cancer Center, who is an expert in urologic oncology and bladder cancer research. And Dr. Ghali will speak on the management of BCG unresponsive non-muscle invasive bladder cancer. The floor is yours, Dr. Ghali.
Well, thank you so much for the invitation and for allowing me to join you all. And
thank you for your time joining.
Great. Is my screen visible? Can you see up the slide set here? Hopefully that's clear for everybody. Well, I'm going to be talking about BCG unresponsive non-muscle invasive bladder cancer. And this is for those of us, especially the urologists, this is a very hot topic. We've seen a lot of growth in this space. And so hopefully I can share a little bit of kind of where we are in the current landscape and how to differentiate from multiple agents that are rapidly being added into this area. So this is our agenda. I'm going to dive right into it here. So bladder cancer, you all will know, and I'm sure has been brought up today. It's a real significant clinical challenge. Many patients, this is 84,000 Americans that are diagnosed every year, upwards of 300,000 patients globally diagnosed with bladder cancer. And many of the audience will also know that most of the time patients that are diagnosed with bladder cancer are diagnosed in this non-muscle invasive space. 70 to 75% are diagnosed with superficial TA, T1, or CIS bladder cancer, meaning that it does not include these deeper layers of the bladder. So these patients are often treated with transurethral resection, followed by I would say the standard of care first-line therapy for high-risk disease is BCG. It's sort of our standard therapy. And recurrence rates for BCG vary. I think that we in the urologic community are realizing that perhaps we have been overestimating the frequency of recurrences following adequate BCG. This is a study that I reference for patients frequently. It's a study of real-world data from Florida from Chad Rich and colleagues, where they looked at their recurrence-free survival here for high risk, intermediate risk, and low risk bladder cancer. And you can see here that in high-risk patients, upwards of 40 or 50% of patients sometimes recurred in this real-world series, and progression was significant as well. More recently, we've seen clinical trials in the BCG naive space in upfront patients who are being treated with adequate BCG per protocol on a clinical trial. We've actually seen several. So here's 3 studies that looked at BCG, comparing BCG alone versus BCG plus a checkpoint inhibitor of some variety. And separate from the results of the actual experiment evaluating the benefit of the addition of these checkpoint inhibitors, one thing that we clearly realized from these data are that BCG alone works much better than we historically had thought. This had been noted by several folks, but BCG recurrence rates were actually closer to probably 15% or 20% at 24 months in many of these series. And so it kind of suggests that actually probably with high quality surveillance of these patients and adequate BCG allocation, BCG actually probably works a little bit better than we thought. That being said, recurrences are a frequent problem that we treat and are seeing in non-muscle invasive bladder cancer care. There's another important thing that we learned from this trial, and I just want to highlight this letter to the editor written by Max Cates over at Johns Hopkins, where he really highlighted a couple of important things. One is that, like I say, BCG works better than we thought, but he also pointed out a really important pattern that I think is going to come into play with the treatment of BCG unresponsive patients, the subject of our topic today, which is that you can see this very stark drop-off in recurrence-free survival early on in the 3 to 6 month mark. And he sort of points out, and others have pointed out, the importance of a quality transurethral resection during the initial diagnosis for patients with non-muscle invasive bladder cancer. And so this was highlighted even just in the talk before, but TURBTs are really an underappreciated skill set. I think that it has, people have for a long time talked about the importance of a quality TURBT. And this was really demonstrated in many of these studies where, for many of these, the majority of the drop-off, you could see here 10% drop-off in the first 3 months. And then for the patients to reach another 10% drop-off sometimes took 24 or even longer months moving forward. So this kind of highlights that many of these may have been avoidable had a quality TURBT been done. And TURBT quality has been highlighted for a long time. This is Harry Herr has written this editorial and has written multiple papers on high quality TURBT, things that we as urologists should be doing and thinking about, including a checklist here, which I've just included for reference to highlight the importance of: did we get muscle in the specimen? Were we able to remove all visible disease, or was there some visible disease that we left behind? Was a bimanual exam performed, and so on and so forth? You can see here a long list, and I really appreciated the title of this editorial, "Urologist Audit Thyself." I think that's an important thing to consider for those of us that are surgeons. So TURBTs are really important quality metric. So BCG unresponsive non-muscle invasive disease is really defined by this FDA SUO definition, which has been around now for about a decade. And it's really written out here: the persistent or recurrent CIS and papillary disease within 12 months. You can have papillary disease within 6 months of adequate BCG. And there's this other caveat, this third bullet point: T1 high-grade disease at first evaluation following induction. That'll also meet the definition of BCG unresponsive. Now, what does adequate BCG involve? Adequate is the sort of, in my mind, I think of it as the 5+2 rule. And so you have to have at least 5 of the 6 induction plus 2 more, either 2 of 6 of a second induction or 2 of 3 maintenance BCG. So you have to have 7 doses one way or another. 5 plus 2 is the breakdown, except if you fall into this third category, as I mentioned. If you have 5 of 6 induction and then have T1 high grade at the first evaluation, then you don't need that additional 2 more. You can meet the definition based on these criteria. I want to take a moment before we dive into the plethora of new agents to mention cystectomy. So cystectomy is the de facto gold standard in BCG unresponsive non-muscle invasive disease. And this comes from a set of prior studies that have evaluated the outcomes of patients with this diagnosis that undergo cystectomy. It's reflected in the NCCN guidelines. Here are AUA guideline statements that reflect this, that are just here for reference for the audience. But both of these reflect cystectomies preferred for these patients. And the reason for this is plainly because of the concern of understaging and risk of progression in BCG unresponsive disease. It's a recognition of the high-risk nature of this disease state. And so understaging is common, unfortunately. So approximately 30% of patients will experience a high-risk clinical progression. And multiple rounds of bladder-sparing therapy, which I'll call BST in these slides, is a risk factor for progression. And there's some data to suggest that secondary progression to muscle-invasive disease is a risk factor for worse prognosis even than de novo MIBC, although these are contested, but there are some data that suggest this. One such study from our colleagues in Spain reflects this. This is a study of 93 patients with BCG unresponsive disease. A third of these patients clinically progressed, meaning that even before cystectomy had clinical T2 disease, while the other 70% or so had clinical non-muscle invasive disease. So 30% is a significant number in this BCG unresponsive space with subsequent TURBT. Importantly, of the patients that underwent cystectomy for clinical non-muscle invasive bladder cancer, another 30% were pathologically T2. So we had thought they hadn't progressed, but when the bladder was removed and was evaluated more effectively with pathology, about 30% of them were actually T2 or higher. And you can see the Kaplan-Meier plots. This is outcomes based on clinical staging. So you could see if they were clinical NMIBC, they did better than those who progressed to clinical T2. But when pathology came back and they looked at the subset of subclinical progression, in other words, that 28% who were pathologic T2, even though we thought they were NMIBC, those patients actually did worse than the clinical NMIBC. So all of that is to say there's a very high risk of progression, and it is reflected in the overall outcomes for these patients. I think this makes all of our ears perk up a bit and worry that we might be taking a curable disease and missing a window of cure because we're delaying or foregoing cystectomy. Now, our understanding of this is evolving. These are some real-world series. This is from the MD Anderson group, presented by Ashish Kamat as the senior author, and Wei Shen-Tan, who's one of my colleagues here at Yale now and a really bright clinician, as well as some other long-term data from a multi-institutional cohort. This is a larger cohort. What you can see is that across all BCG unresponsive patients, if you look at overall survival and cancer-specific survival, you could see those Kaplan-Meier plots show that there's not a significant difference for the whole cohort. But there's nuance in all of this. 30% of the bladder-sparing cohort, the bladder-sparing arm of these real-world data actually ultimately underwent cystectomy moving forward. And of those patients, many of them had progressed. The bladder-sparing patients that underwent cystectomy had much higher rates of nodal involvement, 14% compared to 7%. So significantly higher rates of nodal involvement and higher rates of metastasis as well for those who underwent cystectomy. So we recognize these aren't randomized data; these are highly selected and so forth. But it does sort of suggest that overall, there are clearly subsets of patients who are safe to undergo bladder-sparing treatment, but we have to be vigilant to try to avoid progression in these patients. So those are the caveats for these. And this is a paper that just came out recently. This is claims data written by a senior author of Roger Lee down at Moffitt that looked at claims data for BCG unresponsive patients that underwent cystectomy versus bladder-sparing therapy. And again, I think that the key point here is that This is for patients who did not undergo cystectomy prior to progression, which you can see is 14%. So that's a high rate of progression in these patients. 14% ultimately ended up progressing based on these claims data. So we have to be vigilant. Cystectomy is a really important option. Luckily, it's likely safe, but so the takeaway is that in well-selected patients, bladder-sparing therapy is reasonable, as we saw from these real-world data, but there is a risk of progression and occult muscle-invasive disease, so we have to be selective. I throw this in because I mentioned this study to most of my patients that I counsel on this. This is the CYSTO trial. This is a study conducted by John Gore over at the University of Washington and Angie Smith and colleagues. It's an observational pragmatic trial. So these are patients with high-grade NMIBC that had cystectomy versus bladder-sparing therapy. And their primary outcome was quality of life data. But I did just want to highlight, you could see here recurrence-free survival. The bright blue is radical cystectomy in self-selecting patients. The gray is bladder-sparing therapy. And what you could see here is that recurrence-free survival is clearly better in radical cystectomy patients. Progression to muscle invasion, it's interesting that the charts flip here between the bladder sparing and the radical cystectomy. And while this might suggest that progression-free survival is worse in the radical cystectomy arm, I think what's clear here is that there's some selection bias happening. And the other thing is that we are, because radical cystectomy progression is based on the pathologic specimen, whereas the BST is based on TUR, we're likely understaging a significant number of patients undergoing bladder-sparing therapy. So this, to me, this panel B highlights that we're actually likely missing some progression in BST. But these are the quality of life outcomes, and I know the writing is small here, but you'll have to trust me that for the bars that are to the right side of that line in the middle here, it suggests that it actually favors radical cystectomy in terms of quality of life outcomes. And so what this suggests is that this should be reassuring, and I use this to encourage patients to say, we can try bladder-sparing therapy, but if and when you ever need a cystectomy, just know that it's safe in select patients, and your quality of life, you could live long, healthy, happy lives after a cystectomy as demonstrated by these pragmatic observational data. So hopefully that's helpful for counseling. Now, the arsenal for bladder-sparing therapy I've broken up into these two broad categories, and this is really how I think of these data. There are 5 agents that are widely used in this space that are either FDA approved or just de facto used in the community. And they fall into chemotherapeutic mechanisms and immune-mediated mechanisms. And we'll go through these briefly. This is a really nice review paper by Bogdana Schmidt over in Utah, and I thought the schematic was really helpful. So here's a bladder, and you could already see one of the agents is a chemotherapeutic agent, TAR-200 here, which delivers intravesical gemcitabine. Chemotherapies, either gemcitabine and docetaxel mixed, or like I say, gemcitabine delivered through these chemotherapeutics is one broad mechanism that is useful in BCG unresponsive disease. There are immunotherapeutic agents like pembrolizumab is really it's an anti-PD-1 agent, which is FDA approved. Citrilimab was tested for some time. Actually, at the time that this figure was drawn, it was in use in trials, but it's not approved at the moment. But immunotherapies are useful for BCG unresponsive disease. And then there's the immune activation, sort of immune-mediated viral delivery systems. And the key ones are nadofaragene firadenovec and cretostimogene, which is ongoing in clinical trials now. So we're going to go through some of these briefly. This is I think a nice summary table, and those of us who attend these meetings and will look at summary tables like this a lot. These are the key trials across the agents that are in use. GemDoce is retrospective data, but the rest are prospective single-arm trials. And you can see here Sunrise-1 really established TAR-200 in this space, Keynote-057, as well as these clinical trials here, which gave us N803 and nadofaragene. Here's a brief description of the mechanism of action. N803 is importantly given with BCG. So these are BCG unresponsive patients that are rechallenged with BCG with this IL-15 superagonist N803. It's a small molecule superagonist. Nadofaragene is a gene therapy which secretes interferon. through a gene editing mechanism. So it's a non-replicating adenovirus. And then pembrolizumab, we're all very familiar with. TAR-200 is an indwelling device. So these were small studies. So all of these studies had fewer than 100 patients in each of them, and this is CR at any time. And so we'll see some differences here, but you could see at any time. So usually at 3 months or so, 62% to 82%, 41% for the pembrolizumab arm. One might ask, and I think it's fair to ask, well, we don't want to know what's at 3 months. What's the likelihood of durable CR, complete response for patients with CIS, BCG unresponsive CIS? And at 12 months, you could see a significant drop off here. So this number goes down from 62 to about 36%. Again, you see about the halving of almost all of these agents, except the retrospective gemcitabine and docetaxel literature seems to be slightly more favorable, at least numerically. This data, again, this table is available for reference, but you can see duration of response and then CR at 24 months. And again, we see a dwindling even further of CR. And finally, these are grade 3 adverse effects. Most of these agents are well tolerated. We're still sort of evaluating real world data for many of these, but I think the point of this table is to highlight that there are multiple options, but it really leaves the urologist and the patient wanting. I think we all recognize that these CRs are not ideal, and we wish we had higher CRs, and there's a lot of work being done on that. But there are multiple agents available. There's a lot of excitement about having options for patients, but the outcomes are not as ideal as we all would hope for our patients, our family members, our communities. So that's the point. And I do have one more point to say about this, which is patients will often sort of see these numbers, these sort of top of the chart numbers, and will think, well, 82% is better than 41%. And I have to remind myself, and anytime I give a talk or to our residents here in New Haven, we cannot compare across trials that overall CR rate. It's very tempting, especially when it's almost impossible not to see these numbers and say, well, this number is higher than that number, so that this agent must work better. But it's really inappropriate to do this, and we all know this intrinsically. We all know that it's not the right way to compare studies. I think this study by Steve Monda and Todd Morgan from Michigan establishes, really makes the case for why we can't do this. This is a paper available for reference, but this is a table comparing how these trials were performed, the eligibility, the whether reinduction was allowed, when complete response was assessed, whether biopsies were required. And these are Kaplan-Meier plots of all the different agents across these studies. And what you can see is that these were quite heterogeneous studies. They were in different patient groups, and they were really performed differently, and it precludes direct comparison. And so I like to emphasize anytime I give this talk that we really can't say one is better than the other. So, to kind of wrap it up here, how do we choose? So if you have a BCG unresponsive patient, there's absent comparative data between one agent versus the other. So how do we choose the right thing to give a patient? Well, unfortunately, we have to just rely on the particularities of each of these agents. So you have to ask yourself, does the mechanism provide direction? Does chemotherapy versus immunotherapy lead you one way or another? So for example, does a patient have a reason why an immunotherapy might not be appropriate for them? And, maybe their comorbidities, or maybe they didn't tolerate BCG very well or had an immune response. Perhaps they've already seen a chemotherapeutic agent like gemcitabine and docetaxel, and they're resistant to that. So maybe you want to avoid a gemcitabine-based agent like TAR-200. There's not a lot of data to guide this, but these are some of the things that in the real world we're using. Is we try to use mechanism. What about other differentiators? So nadofaragene firadenovec is delivered quarterly. It's a single dose given in the bladder once per quarter, so at once every 3 months. Is that something that makes a big impact for your patient and may have that be more or less useful than other agents? For example, are they coming in from a very far away? Do they really struggle with catheterization? And maybe this is a reason why they'd want to avoid agents that require frequent catheterization. TAR-200 is a device that is implanted and then has to be fished out in a couple of weeks, and then a new one is implanted and fished out. I have had patients who say, this is great. This may reflect more likelihood that I'm going to have higher cystoscopic surveillance of my bladder, and they're really reassured by that. Whereas others really struggle with the frequent urethral catheterizations and cystoscopies. So these are things that you might use to pick one patient for one versus the other. And importantly, N803 is delivered with BCG. So we know that global BCG supply is in flux, and BCG shortages are frequent. So do we have BCG? That's another factor that one has to consider here. Pembrolizumab, we don't have time to go into it today, but pembrolizumab's data really this was the first agent that was used. The data are really I think the poorest of the data. And it does have, because it's a systemic agent that's given IV, I think the real world experience has been that we really try to find an alternative if possible. So that's sort of my one plug is pembrolizumab should not be a first line salvage treatment here. And it's really quite rare that it should be used in the BCG unresponsive space. Finally, cost. These agents are quite expensive, and I know that we have an audience, a global audience, but in the United States, coverage for these agents varies, and your practice's ability to use each of these agents will also depend on sort of the relationship between purchasing and being able to deliver these. So I did want to plug one study that has recently been published. This is a study by Amanda Myers and Ashish Kamat over at MD Anderson. And there's lots of tables in this. I just wanted to highlight one cost effectiveness analysis here. And what you could see is that there's no doubt that from a cost perspective, gemcitabine and docetaxel followed by surgery gives the net monetary benefit here. You could see it's a significant monetary benefit based on their analysis. And this worsens as you go down, and they sort of have this really nice index patient analysis and look over a long time horizon. So from a system perspective, this is a really important part that was probably underappreciated. All right. So the future, we're looking towards expanding options that may improve outcomes for patients. I mentioned cretostimogene. This is a conditional replicating virus that's dependent on RB for replication. So the RB-E2F pathway is altered in many of these tumors, and this is it's conditional replication on this. And we're awaiting the publication of the BOND 003 study cohort C, which looks at cretostimogene in this group. And at least the preliminary data suggests that it will be available as an additional option. This is an ABLE-22, which is an ongoing study by the folks that make nadofaragene firadenovec, one of the options that I mentioned. And this study is looking at the improvement of outcomes of nadofaragene in combination with gemcitabine and docetaxel. So we're sort of starting to combine some of these agents in clinical trials to say, can we improve on the outcomes reported in the initial phase 1 studies? Finally, there's a lot of effort being done to understand the role of ctDNA. Dr. Sfakianos, I know, was here earlier, and others are looking at the role of ctDNA and the role of AI-based pathology assessment to help us both identify patients who are not good candidates for bladder-sparing therapy, but also hopefully lead us down one agent versus the other. Should this patient get immunotherapy? Should this agent get chemotherapy? These are open questions, but there's some papers for reference that are really, I think, starting to shed light on the utility of some of these things. And finally, way down the road, I just wanted to highlight some incredible work by multiple people, but including Mariana Krutoff de Giulio. She's an investigator and just a brilliant researcher at the University of Bern in Bern, Switzerland, who is sort of, I think, spearheading this movement to develop systems where we can take patients' tumors directly. You can challenge them in vitro either by developing bladder and chip models or organoid models, and then be able to assess, here's what this tumor will respond to, here's what this tumor won't respond to. And she's got some fascinating early data and some, like I say, some publications for reference here. And so the future, I think, will rely on biomarkers and some more translational innovations here. And so conclusions, what do you walk away from this talk with? I think quality TURBT is a foundational backbone for the treatment of these patients and really can't be emphasized enough. Cystectomy is still reasonable, and for many, it's well tolerated. I hope this reassures many of your patients. And really, I think missing a window of cure for a curable disease is a tragedy. And so we don't want to sort of get so excited by these agents that we miss opportunities to really cure patients. And there are multiple agents that we've spoken about. We don't have comparative data, but hopefully more of that will come about. And then the future is coming. You know, biomarkers and translational studies will really lead the way here. So thank you so much for your attention, and I'm looking forward to chatting with you all either at the panel or whenever we have time. Thanks so much.
Thank you very much. Thank you for your presentation and also for talking about the future opportunities and about the ongoing studies as well. And we also have a question from our audience about the common mistakes that clinicians should avoid in managing BCG-unresponsive, non-muscle invasive bladder cancer.
Yeah, it's a great question. The mistakes I worry about most is undertreating these patients, not taking their disease seriously enough because we see CIS or we see non-muscle invasive disease and we expect them to do really well. And so things that I'm aware in my own practice, I'm constantly thinking about, am I getting enough imaging for them? We know that imaging will catch some patients who are progressing deeper on imaging or progressing to lymph nodes, even if we're not catching it on TURBT. Are we doing enough TURBT? Is our TURBT quality enough? And like I say, you know, I think that the danger that I'm seeing in practice for patients that are being sent to me from outside, or like I say, even my own instinct is that we may be underutilizing cystectomy in high-risk disease. So if you're seeing any variant pathology, I think you have to be very, very suspicious that these patients are bad actors. Or if you're seeing them recur frequently, progress to T1 disease, have bad features that we all sort of, you know, the urologists in the audience will know. You see some results and you say, this is a bad actor, you know. So we can't underutilize cystectomy in these patients either. So those are the main things I worry about.
Thank you very much. Thank you for your time, and we will be happy to have you on panel discussion as well. And now it is my pleasure to introduce our next speaker, who is Dr. Maria Jiang from Princess Margaret Cancer Center. And Dr. Maria will discuss HER2 targeting therapies in bladder cancer.
Thank you so much. It's an honor to be here. So I'm just going to share my screen here. Okay, so hopefully you can see. So I'm going to talk about HER2 targeting therapies in bladder cancer, which is a quickly evolving field. Here are my disclosures. My main disclosure actually here is that at least in Canada, we don't really have wide access available for these treatments for patients with advanced urothelial cancer. So outside of the clinical trial setting, we've actually treated very few patients in terms of standard of care. So really looking forward to sharing our experience, but also listen to others to get more insights, and hopefully these treatments will become more available to patients globally in the future. So I think it's good to just have an overview of what is HER2, and many of the audience would know that HER2 is a target for many other cancers. It is part of the EGFR family. In bladder cancer, our data show that it is associated with more aggressive biology, higher stage, and treatment resistance. It is also more differentially expressed in certain histologic subtypes, such as micropapillary disease. And interestingly, there's also significant intratumoral heterogeneity, as well as discordant positivity rates when you look at the metastatic tumors versus the primary tumors. So this really highlights limitations of relying on single site biopsies, and potentially there's a role for sequential testing for HER2 in bladder cancer. HER2 is also seemingly a distinct molecular subtype than the FGFR positive tumors. And of course, it is also commonly co-expressed with EGFR, which may have some therapeutic implications for targeted approaches. We'll highlight that later on. So in terms of HER2 testing in bladder cancer, I think the take-home message here is that unfortunately it is not really standardized for bladder cancer. We can look at HER2 status through protein expression on immunohistochemistry or through gene analysis through in situ hybridization, looking for gene amplification, or next generation sequencing, looking for gene mutations. And our HER2 testing algorithm really is borrowing from other cancers, and this has, of course, limitations, as not all epithelial HER2 status is sort of scored the same. In terms of targeting HER2 in bladder cancer, the efforts actually go all the way back to at least 15 years ago. I'm not going to go through this in detail, but this is just a highlight that there have been a number of trials looking at tyrosine kinase inhibitors targeting HER2, and you can see that the overall response rate and the survival outcomes, unfortunately, were underwhelming. You can also see that there are different thresholds and testing methodologies in terms of the HER2 status. And then afterwards, we also saw some studies looking at monoclonal antibodies. And again, as a single agent, we don't really see very high response rate. Some of the studies where you see response rate 65%, 70% is really combining with chemotherapy. And again, HER2 testing methodologies and thresholds really varied across these trials. So I think when you think about the mechanism of action of tyrosine kinase inhibitors, they do require an activated pathway, and monoclonal antibodies do require HER2 overexpression, which is not the case for all bladder cancer tumors. And these limitations can potentially be overcome by antibody drug conjugates, as antibody drug conjugates really uses the HER2 as a docking mechanism to have the payload release intracellularly, but there's also the bystander effects for potentially tumor with even low HER2 expression or negative HER2 expression that can potentially benefit. And ADCs can also potentially generate an immune response. So in bladder cancer, we have two main ADCs that are targeting HER2. One is trastuzumab deruxtecan, or TDXD. This is using a deruxtecan payload or a topo-1 payload. And we have also disitamab vedotin, or DV, which is using an MMAE payload, similar to enfortumab vedotin, which we're all familiar with. So let's sort of start with the data from TDXD. This is really brought on the scene by the phase 2 Destiny Pan-Tumor2 trial. This was a basket study looking at pre-treated solid tumors expressing HER2 that's scored by IHC 2 to 3+, and this is by the gastric cancer scoring criteria. So these patients underwent TDXD, and this cohort included 41 patients with advanced bladder cancer and was able to demonstrate a very promising response rate of 41.5%, and some of these responses did seem to be durable. When you look at the IHC 3+ cohort, there were only 16 patients, but overall response rate was 56%. And this actually led to FDA approval for this indication. And it was a tumor agnostic indication, including bladder cancer, who were 3+ positive. So TDXD has also some early data with combination with immunotherapy. This is an early phase study looking at a small cohort of pre-treated patients, HER2 IHC 1 to 3+, combining TDXD with nivolumab. And here you see the overall response rate is actually a little bit lower, 36.7%. And so to me, this really did not demonstrate much synergy with immunotherapy compared to, of course, the data we know from other ADCs like enfortumab vedotin. So looking at disitamab vedotin, this is, again, a HER2 targeting ADC with an MMAE payload. These are some of the data that initially came from China. And on the left, you'll see this phase 2 trials. There are 2 studies analyzed together, including patients with advanced urothelial cancer, HER2 2+ to 3+, in the second-line setting, mostly treated with platinum chemotherapy previously. So they underwent disitamab vedotin every 2 weeks, and response rate was very respectable, 50%. And you can see that progression-free survival and overall survival data really mirrors the enfortumab vedotin data. And on the right-hand side, you see another small phase 2 study that is actually looking at a similar patient population, but in this case, HER2 IHC 0 or 1+, so really HER2 negative or HER2 low. And this actually demonstrated a response rate of 31.6%, which is pretty good. And you're looking at IHC 1+ patients, again, small numbers here, but an overall response rate of 46.2%. And to my knowledge, this was the first study that actually demonstrated activity of a HER2 agent in a HER2 low or HER2 low setting, which I think is very exciting. So taking all of this together, disitamab vedotin was then evaluated in a global phase 2 study. This was presented by Dr. Tom Powles at GU ASCO 2026. This looked at pre-treated patients with metastatic urothelial cancer post-platinum chemotherapy with HER2 IHC, not only including the 2 and 3+, but also including the 1+. So they had 2 cohorts with HER2 positive or HER2 low. You can see the definition on there. And the 2 cohorts underwent disitamab vedotin and standard dosing every 2 weeks. What was interesting was that overall response rate was similar across the 2 cohorts. So these global results really align the data from China in both HER2 positive and HER2 low tumors. When we look at the combination data from immunotherapy and, keeping in mind what we had with EV-302 in the frontline setting, this phase 3 trial coming from China was trying to look at DV plus toripalimab versus platinum chemotherapy in patients who are untreated HER2 IHC 1 to 3+. And you can see that the data mirrored the data we saw from EV-302, overall response rate of 76%, and you had progression-free survival 13 months, overall survival 31 months, almost doubled of the results in the chemotherapy arm, a little bit lower in complete response rate, but overall very exciting set of data. And of course, the global phase 3 trial is trying to replicate this, and we'll see the confirmatory data soon. And this trial completed enrollment in February 2026. So of course, with the success of HER2 ADCs in advanced urothelial cancer, the next step is to really move forward in earlier disease settings. So this is the data in muscle invasive bladder cancer, again, a study from China, phase 2, looking at perioperative DV plus toripalimab. And there is a neoadjuvant phase followed by radical cystectomy, followed by adjuvant toripalimab. And you can see that the PCR rate of 63.6%, event-free survival at 12 months of 91%, overall survival at 2 years of 91.3%. If you remember the keynote B15 trial that was presented earlier this year, looking at perioperative EV pembro versus platinum, the numbers here are very similar, which I think is very, very exciting. And the difference here is that in the adjuvant phase, they did not actually include adjuvant DV. They only had the adjuvant immunotherapy. So I think confirmatory data would be very interesting and really adds to sort of the data set of using these drugs in the muscle invasive bladder cancer setting. Of course, there's now some early studies looking at non-muscle invasive bladder cancer. I won't go through this in detail, but here are some of the highlights that I think are very promising. Importantly, I think it's also good to address some of the toxicity profiles we see with the HER2 targeting ADCs. So here's some of the data from T-DXd monotherapy from the Destiny Pan-Tumor2 phase 2 study. And I think overall T-DXd, the main toxicity is really GI and hematologic toxicity. So nausea, vomiting, diarrhea, and significant neutropenia in some of these patients. And you can see that there are a significant amount of patients who develop grade 3 or 4 toxicity. I think in the bladder cancer setting, it is important that we keep in mind that this is often a bit of a frailer patient population than other patients like breast cancer. So, upfront dose modification or upfront G-CSF use or a mixture of both is probably important to mitigate some of these side effects. We also see some unique toxicities with T-DXd, including pneumonitis and LV dysfunction. And I think that given our patient population, which is a smoking-related disease, some of these can be a little bit of a concern in the real-world population. When you look at that small trial that I mentioned earlier, combining with immunotherapy, T-DXd plus nivolumab did have a significant amount of grade 3 or 4 toxicity in the range of 70%, and a third of the patients actually discontinued treatment due to AEs. About a quarter of patients actually developed pneumonitis, including one patient with grade 5 toxicity. So I think that in the light of limited efficacy with the combination and toxicity, T-DXd probably will be mainly used as monotherapy. When we look at disitamab vedotin, overall, I think this is a very well-tolerated agent. And of course, this is not as commonly used in our jurisdiction, as this is not approved outside of China. So we typically use EV Pembro upfront. But compared to EV, we do see that DV has maybe a little bit less skin toxicity, a little bit less hyperglycemia. But you still see the peripheral neuropathy, of course, because of the MMAE payload. When we look at the combination with DV plus toripalimab, there's also patients developing more liver enzyme elevation compared to the EV Pembro study. So some of these toxicities we have to sort of keep in mind in terms of close monitoring. So with the rest of the last few minutes, I want to talk a little bit about how does HER2 really impact our clinical practice at the moment. As mentioned earlier, we mainly use EV Pembro frontline for metastatic patients. We don't really need to have biomarker testing, and we don't have access to disitamab vedotin. So does HER2 status matter, and does it differentiate outcomes? So here is some data from the Javelin Bladder 100 study and the Tempest database, which nicely showed that HER2 and Nectin-4 actually have a strong correlation in terms of expression. And when you look at real-world data, and when you look at the real-world data, HER2 status in terms of IHC or gene analysis does not seem to differentiate outcomes with EV Pembro, which is also reassuring. But I still think getting HER2 status is very important early on because it may drive your decision on what to do after EV Pembro. And sometimes these testing results can take a long time. So in terms of what do we do after EV Pembro, we don't really have much data sequencing EV and DV for patients with HER2 positive disease. We do have a little bit of data from going from DV to EV. This was presented by Dr. Tom Powles earlier this year. And you can see that potentially the response rate of EV after DV is a little bit less than we would expect for patients previously treated with platinum, for example. So it's really suggesting maybe that MMAE payload has some cross-resistance between the two drugs. And what about switching the mechanism of action? So maybe going from EV to T-DXd, with an MMAE going to a topo-1 payload. This is very small numbers here, but we do see that potentially there is good response with T-DXd after EV for patients who are eligible, and somewhat comparable to platinum chemotherapy. So again, that HER2 testing upfront, if available, could be very important. And we do need to have bigger data sets and real world outcomes sort of confirming some of these data. So looking ahead, what is coming is, of course, there's other HER2 agents currently in development, and some of the examples are shown here. But what I'm really excited about is sort of the box on the right. They're really in very early development, but you have now ADCs that not only target one target, but you can have bispecific targets. So this agent called ZW49 has a dual targeting ADC. So it basically targets the same domains as like trastuzumab and pertuzumab. And so this can potentially really increase response rate and maybe overcome some of the resistance that can develop with your traditional HER2 target ADC. And then you also are seeing ADCs with dual payloads, again, sort of overcoming potential resistance from a single payload. These, again, are really in early developments, and I'm not aware of trials in bladder cancer, but I think hopefully more to come. I want to give a shout out to the ISABRITE study. This is not exactly targeting HER2, but this is evaluating an agent called Isabrin, which is an ADC with a bispecific target of HER3 and EGFR. So as mentioned previously, EGFR is also commonly co-expressed with HER2, but this is targeting HER3 and EGFR. There is a phase 1 study in patients with pretreated advanced urothelial cancer demonstrating very promising response rates. An overall response rate, I think, was around 40%, but when you look at patients in earlier line setting, overall response rate was much higher. And so this is now trying to sort of fill that space after EV Pembro. What do we do? And this is not really requiring biomarker testing. So the patient will be randomized to 2 different doses of Isabrin versus platinum chemotherapy. This is a global phase 3 study that is open at our center as well, and we're very excited to have the results in the next few years. So to conclude, I think HER2, hopefully, as you've seen, is becoming an important target in bladder cancer across disease stages, with meaningful activity from ADCs more so than the earlier TKIs and monoclonal antibodies. Biomarker testing is a significant limitation here. It needs consensus and standardization. And I gather from our pathology colleagues there may be some consensus guidelines being developed to sort of really get an agreement on what do we do with scoring HER2. But because of the sort of intratumoral and temporal heterogeneity of this disease, retesting and liquid biopsy may be important to really get an accurate picture. T-DXd is approved for IHC 3+ refractory tumors, including bladder cancer. It is unfortunately not reimbursed in Canada, even though it is approved by Health Canada and the FDA. And so we don't really have wide access to this. And I think dose modification may be potentially important as the toxicities can be significant. And we have to watch out for things like pneumonitis and LV dysfunction. Disitamab vedotin has shown activity across expression levels of HER2. It is not approved outside of China, so I think may have a limited role in our region, but other trials are ongoing. Similar payload may contribute to cross-resistance and overlapping toxicity, especially with neuropathy. And other novel ADCs may help to overcome some of these limitations. Thank you very much. Happy to take any questions.
Thank you very much for your insightful presentation, and just a short answer from the audience. What unanswered question in HER2-positive bladder cancer do you most want future research to address? Is there any unanswered question? I think there are many.
Yeah, there are so many. I think it's really hard to pinpoint to one. I think the biggest limitation for these agents, and it's not a trivial thing, is really standardizing the HER2 testing. You know, if we're missing a lot of patients with HER2 positivity, I think that really can be a significant limitation. So while waiting for that, I think that can also impact, the results from, different trials that can have regulatory impacts as well.
Thank you very much. Thank you for your time and for your presentation and for joining us today. And you're also very welcome to join the panel discussions later. Thank you. And now we are moving with our program, and it is my pleasure to introduce Dr. Oscar Rodriguez-Faba from Fundación Cooper St. Paul Hospitals, who is an expert in uro-oncology and bladder cancer research, and he will speak on non-muscle invasive bladder cancer.
Hello, good afternoon. Can you hear me?
Yeah.
Okay, thank you very much. Thank you very much for the invitation. I'm Dr. Rodriguez, as you have said. I'm a member of the uro-oncology unit in Fundació Puigverd in Barcelona. I'm dealing you through how we should treat non-muscle invasive bladder cancer. I'm not sure in 2026, but now we have a different landscape, and we are moving forward in a different way to really see how to deal with bladder cancer. So the first thing that I want to really lead you through is that non-muscle invasive and muscle invasive bladder cancer do not represent phases of the same disease. I think that they are different biological programs and with different clinical implications. In case of non-muscle invasive bladder cancer, we have specific genetic alterations. FGFR3 is the most common. We also have urine biomarkers in order to really follow up, to really diagnose bladder cancer. Mainly also, we have biomarkers like FGFR3, mutations of FGFR3. And for sure, the most important point here is that it's a high risk of disease recurrence. But we should also identify very well those patients that are muscle invasive bladder cancer-like, that are those that have a higher probability to present progression. In case of non-muscle invasive bladder cancer, there is a high risk of metastasis. There are other alterations, mainly in TP53. We are treating with chemo and immunotherapy, and we have some specific biomarkers for follow-up, like the ctDNA monitoring. And as you can see here, the treatment is completely different. In non-muscle invasive bladder cancer, we're focusing on intravesical therapies, and in muscle invasive bladder cancer, targeted therapies. So from the last years, we have seen that bladder cancer is a highly heterogeneous disease. And we have made an important job in order to really publish transcriptomic studies that can converge on reproducible molecular subtypes. And now, in case of muscle invasive bladder cancer, we're in this position to have a specific and consensus molecular classification in luminal, papillary, and also basal, stromal rich, and neuroendocrine-like muscle invasive bladder cancer. So these subtypes reflect different differentiation states, oncogenic drivers, and also tumor microenvironments. So luminal tumors have FGFR3 alterations. Basal tumors have TP53 alterations. And this is very important in order to know the prognosis and in order to drive the treatment in these different tumors. In non-muscle invasive bladder cancer, some high-risk non-muscle invasive bladder cancer have molecular features that can explain early progression because the mutations are close to muscle invasive bladder cancer. So you can see here how the different molecular pathways can really drive us through how to really move in non-muscle invasive and muscle invasive bladder cancer. Globally speaking, bladder cancer have recurrent alterations in a limited number of pathways. TP53 is the landmark of muscle invasive bladder cancer. And in case of non-muscle invasive bladder cancer, we have different genes, and the genomic landscape supports the concept that muscle-invasive bladder cancer is completely and biological distinct compared to non-muscle invasive bladder cancer. That's why there are some non-muscle invasive bladder cancer that behave more aggressively from the start because they are following a totally and different complete biological pathway. And those high-risk non-muscle invasive bladder cancer and carcinoma in situ present mutations and molecular pathway alterations that are close to muscle invasive like TP53. And in case of non-muscle invasive low grade, FGFR3. So in this sense, how can the new biomarkers help us in the clinical management? We need biomarkers in order to go for information about cancer-specific outcomes and also on prognosis. These are the key factors that all the new molecular biomarkers should have. And in non-muscle invasive, we are dealing with PD-L1. We are now starting to deal with ctDNA, but here we have a long way to really drive in order to achieve good biomarkers for having information and good information about prognosis. So in this couple of slides, we have to answer why biology should really influence this management, because TP53 can really drive those tumors that are more aggressive. And if we can identify which non-muscle invasive bladder cancer present these mutations, we can really expect worse outcomes. We can scale the treatment. We can go for early cystectomy. We can enroll the patients in perioperative of biomarker trials and consider these patients for an early systemic treatment. And also, we can learn from muscle-invasive bladder cancer that we have specific genes that can really know those patients that respond better to chemotherapy or to other targeted strategies. So molecular alterations explain why similar-looking tumors require very different clinical strategies. So in this sense, nowadays, we are only dealing with the clinical pathological factors. We are not in this position now to really apply in the clinical practice these new molecular classifications. We have the low, intermediate, and high risk and very high risk non-muscle invasive bladder cancer based only in clinical pathological factors, stage, grade, CIS. And the information that we have in order to treat the patients comes from these classifications that are only based on clinical pathological factors, and we know that low-risk tumors present a very low risk of progression, 1–2%, intermediate-risk tumors, 10%, and high and very high-risk tumors, 25%. And now, all the treatments that we are giving to our patients are based on this. But from the last years, we have achieved a lot of important clinical investigation. And we have moved from the second-line therapy in high-risk non-muscle invasive bladder cancer with a couple of trials that have shown good results in BCG unresponsive to BCG-naive non-muscle invasive bladder cancer. Now we're starting to have evidence on this, and to even intermediate risk non-muscle invasive bladder cancer. All this landscape can now show us how to treat non-muscle invasive bladder cancer in 2026 or even in the next couple of years. In case of intermediate risk non-muscle invasive bladder cancer, I have a word for you, that is de-escalation. Intermediate risk non-muscle invasive bladder cancer is a tumor that have a low risk of progression. So in this sense, there have been developed trials about chemoablation with some specific devices like this liquid polymer that with high temperature has the conversion to semi-solid polymer that drives mitomycin C into the urothelium and really can have good oncological outcomes in terms of recurrence and also in terms of progression. And we have the results of OPTIMA trial with a very good complete response at 3 months of about 65%, and disease-free survival of 95% at 6 months. Now we have recently the results of the ATLAS trial. It's a phase 3 trial where we have seen how we can really even present a chemoablation for tumors. And when we compare the UGN 102 plus TURBT compared to TURBT alone, we can see how the combination of UGN 102 plus TURBT present better oncological outcomes rather than TURBT. And we open the window for having a specific treatment for this intermediate group non-muscle invasive bladder cancer, where we can have a de-escalation and we have a chemoablation that is really effective for our patients. So this is the interim analysis of the ENVISION trial, phase 3, single arm, 240 patients, follow-up of 15 months, 95% of patients completed the 6 cycles with a complete response of 80%. And this device have been approved by the FDA. In this sense, we have new trials that haven't completed the trial until now. That is the pemigatinib. It's a FGFR1, 2, or 3 inhibitor. It's an oral treatment and is estimated to have results in 2027. We have the TOR2 trial. There is the cohort 3 of TOR2 trial. It's an intermediate risk non-muscle invasive bladder cancer with oral erdafitinib, with very good results, with complete response rate of 83%. The problem is the toxicity. It's a hyperphosphatemia in 100% of patients and grade 3 events of 20%. Now we are running the Moonrise trial. Moonrise trial is another specific trial that after checking the FGF3 status gene, we can treat the patients with the specific TAR-200 device, but with erdafitinib. So the device with erdafitinib is every 12 weeks for 1 year, with the primary endpoint of disease-free survival. The completion would be in 2028. The ABLE-32 trial, also in intermediate risk, with nadofaragene firadenovec, with 2 arms in 2030, and also the PIVOT-6 trial, phase 3 trial with cretotismogen heradenovec, with also 2 arms, 1 observation, the primary endpoint recurrence-free survival, and the completion in 2027. You all know the KILT trial with immunoablation, a very nice phase 2 randomized trial with the superagonist combined with BCG. And also, we don't know when we have the study completion, but we can translate the results from BCG and response, and maybe the complete response rate might be really good. Now, if we move to the high risk, now we also are used to deal with the calculators based on clinical pathological risk factors, recurrence and progression rates based on these clinical pathological risk factors. In high risk, about 25%. We have the specific tables from the Cueto group, specific for patients treated with BCG. But now we have evidence that come from new phase 3 trials where they have checked the combination of systemic immunotherapy plus BCG or even a specific intravesical treatments. There are many trials that are running and also a couple of trials that have now results. The POTOMAC, the ALBAN trial, the Keynote 676 CREST trial, Sunrise 3, or even BRIDGE. We have results from the POTOMAC trial, we have results from CREST trial, we have results from ALBAN trial. If we want to analyze the results of these trials, the design of these 2 specific trials, the CREST trial and POTOMAC trial, it's very, very similar with 3 arms. 1 arm, the combination of immunotherapy, sasanlimab or even durvalumab plus BCG, induction plus maintenance, sasanlimab plus BCG only induction, and BCG induction plus maintenance. The endpoint of these 2 trials is different. In case of the CREST trial, is event-free survival. In case of the POTOMAC trial, is disease-free survival. And the third trial is the ALBAN trial. The ALBAN trial is the only of these 3 trials that has been negative, only 2 arms, comparing BCG plus atezolizumab and only BCG, with another primary endpoint of event-free survival. So we have 2 positive trials, that is the CREST trial with a good results. The risk of event-free survival was 32% lower with the combination of sansalimab plus BCG induction plus maintenance compared to BCG induction plus maintenance. Similar results we have had with the POTOMAC trial. In this CREST trial, we have seen how the risk of high-grade recurrence was reduced by 50%. We also have the POTOMAC trial, similar results. The curves are a little bit more open. Maybe we can have better results in the future in terms of overall survival, but the first endpoint is event-free survival, disease-free survival, and was also significant. And the ALBAN trial, the study was negative. Maybe the proportion of patients, maybe the 2 factors that have had influence of the results is the duration of BCG that was lower in case of the ALBAN trial. And in the ALBAN trial, they consider as event-free survival the low-risk recurrences. But globally speaking, the study was negative. So the other endpoints that were the overall survival, and when we compare the other arms with only BCG, induction plus maintenance, sansalimab plus BCG induction, all the 3 studies were completely negative. Overall survival was negative in the 3 trials. So in terms of toxicity, this is the problem, because now we are facing with high-risk patients. We have grade 3 events, about 30%, when we want to select the patients for treating with these new combinations. You can see here that there are a high proportion of patients that present adverse events, and there is a proportion of patients that have grade 3 events. So in the future, it will be very, very important to really select from the whole group of high-risk non-muscle invasive bladder cancer, which patients have more possibility to present benefit from these trials. If we compare, in this case, the toxicity, you can see here how, in case of CREST, POTOMAC, or ALBAN, the possibility of grade 3 or more if adverse events was 30% in the combination, 21%, and 23%. If we are talking about the subgroups, we can see in the 3 trials how the patients with CIS present better outcomes. From these 3 trials, the one that present better possibility to present benefit in case of CIS is the CREST trial. So now we have to really see if we can select those patients with CIS for be treating more active with the combination of sansalimab or even durvalumab plus BCG. And now we have recent data where we can see that those patients that move to the very, very high risk group are those that present more benefit. And when they analyze specifically the group, the very high risk group, we can see how the benefit is even higher. So all the evidence is moving forward in order to really use these combinations in those patients that present a very high risk profile, because here we can balance the toxicity with the clinical benefit. But for sure, we need further evidence in order to confirm these thoughts that we are now dealing with and we are now saying. So the challenges is for sure to manage the adverse events and also to make an arrangement between the different specialists that are implied in the management of bladder cancer in order to adjust the infrastructure, the education for all the members of the teams and the urologists in order to deal with the adverse events, and to really have an integrated patient management to select very well the patient that benefit most from these new combinations. So this is a revision that has been published by Bernadette Sabados, where we can see here how the different doctors that are implied in bladder cancer can really make different jobs during the whole landscape of treating of this non-muscle invasive bladder cancer. If we move from BCG unresponsive non-muscle invasive bladder cancer, we have to say that BCG unresponsive is frequent. And also the patients that present an unresponsiveness present a progression rate of up to 20% of BCG responders, and 66% of non-responders progress to muscle invasive bladder cancer. We know that there is expression of PD-L1 in BCG unresponsive non-muscle invasive bladder cancer. And also we know that there are clinical pathological factors that are more linked with this BCG unresponsive non-muscle invasive bladder cancer, like the multiple CIS, the prostatic urethra involvement, and also the failure to BCG. And as I said before, there is a specific link with the specific pathways like p53. So BCG failure is a common scenario, biological driven and often perceives invasion, but we don't have a single biomarker to really the escalation or to really delay the up to now gold standard treatment that is the radical cystectomy. So now in this table, you can see the approved therapies for BCG unresponsive non-muscle invasive bladder cancer. A lot of them, nadofaragem, faidonobec, pembrolizumab, the combination of interleukin-15, the TAR-200, and valrubicin are therapies that have been approved by the FDA. If we look at the EMA, we have only one approval, but you can see here the landscape. In all the studies, we have a 3-month response that is quite good, but there are a lot of treatments that with the follow-up decrease the response, and up to in 24 months, we have some of the specific treatments that only 20% of patients maintain response, 15%, and only the combination of the superagonist have up to 40% of complete response. So we have new treatments that really have a very good initial responses, but with the follow-up, the response decrease. And we have to link this with the systemic toxicity and also with the cost, Also, we have new investigational therapies that we have that maybe will have better responses and better responses with a long-term follow-up. And if we have the conclusions of all this talk, in case of intermediate risk non-muscle invasive bladder cancer, the therapeutic landscape is moving beyond the conventional intravesical therapy, BCG or mitomycin C. As I said before, there are new strategies of chemoablation, targeted therapies, delivery systems with erdafitinib, or other therapies that really can drive out us how to deal with intermediate risk. And the most important thing in this group is the de-escalation. In case of high risk BCG naive, we have to stay with BCG, but if we add immunotherapy, we expect a 3-year event-free survival benefit of around 7%, but with a grade 3 toxicity, 30%. So now we have to really determine which subgroups might benefit most for this combination in order to balance the oncological outcomes with the toxicity. And maybe we have to really develop new biomarkers that are less complex than CIS in order to select better the patients that will really have more benefit. And in case of BCG unresponsive, we have treatments that really have a very good response. The highest initial complete response is for TAR-200, 82%. CG0070, 75%. And also now we have in this position to say that there are treatments that present a quite good 12 months complete response, like TAR-200 or nadofaragem faidinobec. But intravesical and device-assisted therapies are reshaping the BCG unresponsive disease. And the future selection should be guided by phenotype of the tumor, the patient fitness, the toxicity profile, and also the biomarkers. Thank you very much. If you have questions for me, I don't know if everything has been heard well, because I have no feedback, but I hope so.
Dr. Rodriguez, yes, of course, everything was heard, and we thank you for the very insightful presentation. And we do have a question from our audience.
Okay.
So the question says, what do you consider the biggest unmet need in NMIBC management today?
In high-risk non-muscle invasive bladder cancer maintenance with BCG, you mean?
Yes.
Okay, now I think that the most important unmet need is, if now we know that we can or we need to use BCG with at least 2 years of maintenance, we have to develop all the strategies that we can have in order to improve the adherence to BCG. I think that the key point now is to improve the adherence with BCG with a good patient information and with good management of the local toxicity.
I see. Thank you very much, Dr. Rodriguez, once again for a great presentation. And continuing with our program, I would like to welcome our next speaker, Dr. Kent V. Mao. It's a pleasure to welcome for your presentation. Dr. Kent V. Mao is a radiation oncologist, physician scientist at Dana-Farber Cancer Institute, associate professor of radiation oncology at Harvard Medical School, and associate member of the Broad Institute. Dr. Mao's work focuses on bladder cancer biology, DNA repair, translational research, and radiation oncology for genitourinary malignancies. Today, he will be speaking on advances in radiation for muscle-invasive bladder cancer. Dr. Kent V. Mao, can you hear us?
Yes. Can you hear me and see my slides okay?
Yes, everything is perfect. Your voice is great. So I think you can start.
Great. Well, thanks so much for the introduction and thanks for the invitation to be here. I'm going to talk today about some of the advances that I see in the radiation oncology space for bladder cancer. I hope this will be interesting. I realize it may overlap a little bit with some of the speakers we've heard already, but I hope to provide my own perspective and flavor here. These are my disclosures. None of these are going to be relevant to the work I'll describe today. And so I very briefly wanted to provide an overview of the role of radiation across disease settings in the bladder cancer space. So as folks are familiar, the majority of cases at diagnosis are non-muscle invasive cases, typically managed by urologists and urologic oncologists. Intravesicular therapies remain the backbone of therapy. There were a couple of radiation trials I did want to mention, and due to time, I won't have time to talk about them further, but just thought they were worth noting here. One is the TRAIN trial that's being run in the UK. This is an interesting trial that's comparing in newly diagnosed non-muscle invasive cancer, BCG versus radiation plus concurrent radiosensitizer. Again, that's in the newly diagnosed high-grade non-muscle invasive space, which is interesting. In the recurrent non-muscle invasive space, in the past year or so, there was a publication of a cooperative group trial in the US, RTOG 0912, which compared which was a single-arm trial of chemoradiation, again, in the BCG refractory high-grade non-muscle invasive space. The majority of today's talk is going to focus on muscle-invasive bladder cancer and the use of trimodality therapy in that setting. There's less data available in the node-positive and metastatic setting, although I think hopefully, in the future there may emerge prospective trials testing the role of radiation in these contexts as well. But that being said, I'll focus on muscle-invasive space, as we know, an area that's evolving rapidly. And so I'll briefly review the current data supporting the use of radiation in this context, and then my view of where we're headed. So this is the core paradigm for trimodality therapy, or TMT. It starts with maximal safe transurethral resection, followed then by concurrent radiation with a radiosensitizer. In the US, the radiosensitization radiosensitizers are typically chemotherapy. In the UK, particularly hypoxia modification is sometimes used. Following delivery of concurrent chemoradiation, these patients go on to a close post-treatment surveillance schedule that includes cystoscopy, cross-sectional imaging, blood and urine analysis. And then in patients who develop a muscle-invasive recurrence, we typically recommend those who are eligible and willing to have a prompt salvage radical cystectomy. There are some variations on this theme. Primarily, I wanted to point out the roles of neoadjuvant or adjuvant chemotherapy, depending on context and depending on trial situation. This lower sort of workflow is something that had been used quite a bit in completed RTOG cooperative group trials in the US. This notion of providing about 2/3 of the initial chemoradiation and then pausing for an assessment of response, and then only proceeding to complete chemoradiation if the patients had a good response at that interval assessment. This is a paradigm that's largely fallen by the wayside, and now most of our patients, and certainly all of the trials nowadays, go straight through the prescribed chemoradiation and then surveil patients following completion of therapy. So the Radiation Therapy Oncology Group, which is now part of NRG Oncology, is a cooperative group that over several decades has performed a series of bladder-sparing TMT trials that really have defined and helped shape the current standard of care. The details aren't so important, but I'm listing here the trials that have been completed, again, dating back to the mid-'80s, really. These are largely phase 2 trials, around 100 patients per trial, testing different paradigms of chemoradiotherapy. I'll talk a little bit about the SWOG NRG intergroup cooperative trial, 1806. This is a large randomized trial that was recently completed accrual and hasn't yet been reported. And then the two open ongoing trials in this space, NRG GU15 and SWOG 2427. I'll mention those briefly at the end as well. A couple of just things I really wanted to emphasize regarding trimodality therapy. The first is the important part of radiosensitization as a critical component. This is the BC 2001 trial that I'm sure most folks are aware of. It showed the value of adding concurrent 5-FU mitomycin C to radiation in patients with MIBC. You see the significant improvement in invasive local regional disease-free survival here on the left upper panel, trend towards an improvement in overall survival. And you can see the benefit of addition of radiosensitizer really across different clinical contexts here in the forest plot on the lower left. I'm not going to have time to go into the details of other trials that have investigated other radiosensitizing agents, but to suffice it to say that there are other agents that are supported by good data, including gemcitabine and cisplatin, which are commonly used in the US, and then carbagin and nicotinamide, that hypoxia modifying therapy I mentioned, more commonly used in the UK. One thing I did want to really emphasize is that TMT outcomes have improved over the decades, really, that it's been under investigation in clinical trials. This is a report from a cohort of patients treated at the Mass General Hospital in Boston over several decades. And you can see here the improvement in complete response rates over time eras that manifests as improved disease-specific survival, with the most recent era in red at the top. And then the decreased rates of cystectomy needed for salvage in these patient populations, with about a 15% salvage cystectomy rate in the most recent era that was represented in the manuscript. And I think this really reflects both improvements in patient selection, so understanding who the best candidates for TMT might be, and then also improvements in the delivery techniques that we use for our radiation and chemotherapy. I know Dr. Zalota spoke earlier in the day comparing cystectomy and trimodality therapy. This is a study that he led and published a couple of years ago. As folks are aware, there's no prospective randomized data comparing trimodality therapy to cystectomy, and so we rely on high-quality retrospective analyses. And this study is really one of those best studies that have been used or performed to compare outcomes. This was a large study of over 700 patients accrued at high-volume centers in the US and Canada. The inclusion criteria, relatively liberal here. These are patients with MIBC up to 7 centimeters, could have unilateral hydronephrosis and focal, but not multifocal or extensive CIS. As you can see here in the metastasis-free survival curves, they're really completely overlapping between trimodality therapy and radical cystectomy. The statistical analysis were performed using two different types of analyses. That's what you see in the columns here. Really the take home here is that in carefully selected patients, the metastasis-free survival similar with bladder-sparing trimodality therapy as with radical cystectomy-based treatment. This is a graphic that I created a number of years ago and has evolved over time, sort of thinking about the construct I use to identify patients and in our multidisciplinary setting guide our recommendations. And so it's important to know that there are subsets of patients who are likely to do well with either cystectomy or trimodality-based therapy. Those are what is represented in the upper right in the green circle. These are patients with good performance status and unifocal T2 tumors. They're likely to do well using either approach. There are then subsets of patients, which I show here in the yellow, for whom either trimodality therapy or cystectomy, one or the other might be better. And as an example of patients who might be better suited for trimodality therapy in the lower right here, these are patients who may be higher surgical risk or have a very strong desire to preserve their bladder. Whereas conversely, in the upper left, patients better suited for cystectomy may be those with poor baseline bladder function or general contraindications to pelvic radiation, such as inflammatory bowel disease or previous pelvic radiation. And then importantly, there's this subset of folks in the bottom left. These are patients who have prognostic factors that have been demonstrated to be unfavorable whether cystectomy or trimodality therapy is used. And these are common things that we're familiar with, like CIS, hydronephrosis, more advanced disease, multifocal disease, etc. Oftentimes, these, I think, in practice, often sort of hedge towards cystectomy as a recommended management. But important to note that these have been demonstrated to be poor prognostic factors in both cystectomy and trimodality therapy series. I mentioned this trial earlier. This is the SWOG NRG 1806 trial. This is a large randomized controlled trial that completed accrual, I think about a year and a half ago. This is the largest randomized trimodality therapy trial to ever be performed in the US. It enrolled patients with MIBC stratified by the concurrent chemotherapy regimen, radiation field, whether it be bladder only or bladder plus pelvic lymph nodes, and I'll talk about that in a little bit, performance status and clinical stage, and randomized them really to standard of care contemporary chemoradiation or to chemoradiation plus concurrent and adjuvant atezolizumab, which is an anti-PD-L1 agent. The primary endpoint of the trial is this patient-centric composite endpoint called bladder intact event-free survival. Events that trigger a BIEFS event are things like a muscle-invasive recurrence, development of regional or metastatic disease, cystectomy for any reason, and death from any cause. And so I think the field is anxiously awaiting results of these trials, which are expected in the next year or two. And in addition to the clinical outcomes, there is a rich set of translational and correlative studies that will accompany the trial. I wanted to touch just briefly on a few questions or topics that I would say come up frequently, specifically regarding radiation in this space. I mentioned the idea of elective nodal radiation. And so historically, the RTOG clinical trials that I mentioned have included treatment of what's called a small pelvic nodal field, whereas the UK in their trials like BC 2001 generally have just treated the bladder and have not treated an elective nodal field. There are no randomized studies that have been performed specifically investigating the role of elective nodal radiation. It's worth noting that the rate of isolated pelvic nodal recurrences in large TMT series is relatively low. On the right, I'm trying to show the evolving techniques that we now use to treat bladder cancer patients. And so in the past, when we were treating folks to this small pelvic field, it involved essentially bringing most of the deep pelvis to the radiation dose. Whereas now with the advent of IMRT, we're able to really sculpt the radiation dose, which helps us treat larger fields more safely. And I'm showing here an extended lymph node field that I treated in a patient with node-positive disease. You can see how you can carve the dose around things like the bowel and allow you to treat higher up into the retroperitoneum even. And so my take on elective nodal radiation, it's reasonable to treat or not treat depending on the case specifics. I do treat nodal fields plus the bladder in patients with nodal disease who've had good response to systemic therapy. And it's worth noting that I think our ideas around elective nodal radiation are likely to evolve as the systemic therapy continues to improve. And I'll talk about that in a few slides as well. Another topic of conversation, at least among radiation oncologists who treat bladder cancer, is how we treat the bladder. And one thing after treating many of these patients over many years, one thing that's clear is that the bladder tumor size and location within the bladder changes, as does normal bladder anatomy from patient to patient. And so these are just sort of cartoon examples of the tumor relative to the bladder size. I typically ask my patients to empty their bladder before the radiation, but as you can imagine, the extent to which different patients can empty, it really tends to vary, and therefore these radiation plans actually can look quite different from patient to patient. The RTOG trials have used the successive cone down approach, where the pelvic nodes in the entire bladder go to a total dose of 45 or 50 gray. There's a first cone down to the entire bladder, and then a second cone down really just to the area of the bladder tumor or the bladder tumor bed. Using conventional fractionation of 1.8 to 2 gray per day, that leads to total doses of 64 to 65 gray to the highest dose region in this bladder tumor bed. The SWOG NRG 1806 trial, which I just mentioned, really allowed nodes to be treated or not, and allowed the entire bladder or just the bladder tumor bed to be treated. And so interestingly, we will likely have some data from that trial regarding this question of coverage. The conventional fractionation that I just mentioned, that's been used historically in the RTOG trials, is 1.8 to 2 gray per fraction, 5 days a week. There is, however, a moderate hypofractionation regimen of 55 gray and 20 fractions delivered over 4 weeks to the bladder. This was compared to the conventional fractionation in a meta-analysis performed by the UK groups a number of years ago. And the take home from this really is that this moderately hypofractionated regimen of 55 gray and 20 fractions is no worse, and depending on how you choose to interpret the data, may even be a little bit better than the conventional fractionation. And so that really, I think, has shifted our practice, at least my practice and many practices I know in the US, towards this hypofractionated regimen of 20 fractions over 4 weeks, which is quicker for our patients. One natural question when we're talking about fractionation is more dose better? The 55 gray and 20 that I mentioned has been a standard dose. This is the UK Radar trial published recently. It was a trial that was really intended to compare a couple of different ways of delivering standard or dose escalated radiation using adaptive or standard approaches. It was not powered to compare outcomes across arms. The primary outcomes were toxicity based. I think the take homes from this trial is that these are safe treatments to deliver. There was overall low rates of grade 3 or higher toxicity. This delivery of adaptive radiation, meaning that you choose a radiation plan based on the patient's anatomy on that day, can be feasibly delivered. And the tumor control is quite good across arms, as you'll see on the right here in the BI-EFS curves there. So I mentioned that despite careful patient selection, there are patients who have a muscle invasive recurrence after trimodality therapy. For cystectomy eligible patients, our typical recommendation is for prompt salvage radical cystectomy. Again, that rate is 10 to 15% or so in well-selected patient cohorts using modern techniques. A question that often comes up is, what is the safety of salvage cystectomy following TMT? There have been a couple of comparative types of analyses that have been reported in this space. This is one such study published a number of years ago showing the post-cystectomy toxicity grades in an upfront versus a post-TMT cystectomy setting. And you can see relatively low grade, particularly 4 and 5 toxicities in both, suggesting these are comparable. One thing I do tell folks, patients who are considering trimodality therapy to consider, however, is that the urinary reconstruction options may be different or more limited in the salvage cystectomy space, and that's something I recommend that they have a careful discussion with your urologist. In addition to those rare muscle invasive recurrences, we know that a subset of patients may also experience a non-muscle invasive recurrence after trimodality therapy. In general, it's possible that these can be managed similar to upfront non-muscle invasive diagnoses with relatively more conservative management, including things like TURBT and intravesicular therapy. However, if these are diffuse or multiply recurrent in MIBC cases, we do recommend some of these patients with non-muscle invasive recurrences consider salvage radical cystectomy as well. Another question that commonly comes up is, what about patients with divergent histologies? This is a retrospective study from the MGH published a number of years ago showing outcomes in patients with pure urothelial carcinoma versus those with some component of variant histology. I will acknowledge that the data that we have, especially prospectively collected in this divergent histology setting, is relatively sparse. Therefore, I think it's an area of unmet need as far as clinical trials go. Certainly a presence of variant histology is common. I think a component is not a contraindication to TMT. These percentages obviously are imperfect and have to be taken with a grain of salt, but particularly in cases where the variant histology only comprises a minority of the total tumor, I do offer TMT to many of those patients who would otherwise be eligible. I would say that the optimal management for those patients with 100% variant histology, so 100% squamous, 100% adeno, is unclear, and ultimately we often recommend those patients to undergo upfront radical cystectomy. The one common difference from that is those patients with small cell or neuroendocrine cancer. In our practice, we're typically managing those similar to how we'd manage small cell lung cancer patients with platinum etoposide chemotherapy first, followed by local therapy consolidation in eligible patients. And so up till now, I haven't mentioned the huge shift that's we're experiencing in the systemic therapy space for muscle invasive bladder cancer with the advent of EV Pembro containing regimens. And so I'm showing data published just recently from the New England Journal of Medicine on EV303, which was in the cisplatin ineligible MIBC space, and then data on the right published at GU ASCO this year in the cisplatin eligible MIBC space, comparing EV Pembro to cis-based neoadjuvant chemotherapy. In both of these trials, you see improvement in both EFS and OS. And in our practice, this has led to essentially quick and a complete shift in practices towards EV Pembro for eligible patients. And so a natural question in this EV Pembro, in this new EV Pembro era, is how do we deliver local therapy to patients? Do patients require local therapy if they've had a good response to EV Pembro? And if so, is it with surgery, as the trials that I just showed were conducted with surgery, or is radiation an option in those patients? And so there are a couple of radiation-based trials that are open in this space, and I encourage those folks to consider enrolling to them because I think they're important trials. The one on the left is the NRG GU15 trial, or so-called Archer trial that I mentioned. This is patients who, these are MIBC patients who could have had neoadjuvant chemotherapy, including with EV Pembro. They're stratified by clinical stage, type of radiosensitizing chemo planned, and then whether or not they received neoadjuvant chemo, and then randomized to the 55 gray and 20 fractions that I mentioned earlier, so the moderately hypofractionated regimen, versus an adaptive 5-fraction ultra hypofractionated radiation regimen of 32.5 gray and 5 fraction. And so really asking the question is, can we further decrease the number of treatments that these patients have to have for their bladder cancer? The trial on the right is a SWOG trial, or BRIGHT trial as it's called. This is a trial designed specifically for patients who've had good responses to neoadjuvant systemic therapy. And again, today in our practice, that's mostly patients who are with EV Pembro, although other standard neoadjuvant therapy combinations, including cis-based chemo or chemoimmunotherapy, are also allowed. Patients following neoadjuvant chemotherapy undergo restaging with TURBT and systemic biopsies. For those patients who've had good clinical response, which in this context is defined as no disease on biopsy or up to T1 disease, those patients are registered and undergo 55 gray and 20 fraction to the whole bladder plus pembrolizumab for up to a year. The idea being we can provide safe consolidative local therapy for folks who've had good response to neoadjuvant systemic therapy. One additional technology that I think is likely to continue to be integrated into our practice is the role of plasma-based circulating tumor DNA or ctDNA. This is a study that we recently published from our centers in Boston. This included 84 patients with MIBC treated with trimodality therapy across our institutions. I'm going to summarize a little bit of the data here. Here you can see at diagnosis prior to chemoradiotherapy, about 1/3 of our patients had detectable ctDNA using a commercially available Signatera assay versus 2/3 negative or undetectable ctDNA prior to chemoradiation. And then you can see the shifts over time where many of those patients with detectable ctDNA actually became undetectable after chemoradiotherapy, whereas a smaller percentage of patients either remained persistently positive or converted from negative to positive. The ctDNA status at that first post-chemoradiotherapy time assessment point was highly prognostic. So patients with undetectable ctDNA largely did well, where those with detectable ctDNA following chemoradiotherapy unfortunately did quite poorly, with all patients developing metastatic disease, most within 6 months. What was interesting is that there were also a subset of patients who developed local recurrence only, whether that be MIBC in 5 patients or non-muscle invasive in 7 patients. What was interesting here is that unlike the patients who developed a component of metastatic disease, all of whom nearly had detectable ctDNA, none of the patients who developed a local only recurrence had detectable ctDNA prior to diagnosis of that recurrent local disease, suggesting that plasma-based ctDNA testing may not be the sensitive way to monitor for local recurrence in the bladder. And so I think this is my last slide. This is my take on the potential future of MIBC treatment. So we have patients who are diagnosed with muscle-invasive bladder cancer. We will hopefully have a suite of validated and reliable clinically deployable biomarker strategies to help guide our patient recommendations. This could be things like the classic clinical and pathologic features, tumor genomics, plasma ctDNA, which I mentioned, urine tumor DNA, which may be better at assessing for early local relapse, and then radiomics or AI, which I didn't have time to talk about. I think we're going to use this to stratify patients. And I do want to just make a plug, or my opinion, I think, is that despite the activity of EV Pembro, I do think that there are probably a subset of good risk muscle invasive bladder cancer patients who can be cured with local therapy alone, whether that be cystectomy or trimodality based therapy. However, and how it, I think, is shaking out in our practice these days is that most patients, or nearly all patients, are getting EV Pembro up front. And then their response is assessed following a neoadjuvant component of EV Pembro. Hopefully in the future, and due to readouts from some of the trials that I mentioned, we will have data to support management after response assessment, and whether that be surveillance in folks with good response, consolidative radiation, perhaps with chemo or immunotherapy, cystectomy in patients who have residual local disease, or change in systemic therapy for those patients who don't respond as we hope they would to the EV Pembro. All right, so I think that's what I have. So the conclusions: bladder-sparing trimodality therapy is a curative approach for selected patients with MIBC. It's supported by long-term safety and efficacy data. There are advances in radiation techniques that have improved our ability to target disease both within and beyond the bladder. This has led to improved safety and tolerability, shorter treatment courses, which benefit our patients, and then the possibility to treat disease beyond the bladder, whether that be in lymph node or oligometastatic sites. As I mentioned earlier, I do think the role for local therapy is likely to evolve as our systemic therapies continue to improve, and the future state, in my opinion, likely involves biomarker-driven treatment personalization. So thanks for your attention.
Okay, thank you once again, Dr. Mao, for sharing such valuable insights on advances in radiation for muscle-invasive bladder cancer. And we truly appreciate your contribution to today's session. Thank you once again. And I think we're going to move on to our next speaker. And now I would like to welcome Dr. Shrikala Sridhar, Professor of Medicine at the University of Toronto and genitourinary medical oncologist and site lead at Princess Margaret's Cancer Centre. Her clinical and research work focuses on advanced urothelial cancers, new drug development, and phase 2 clinical trials in genitourinary oncology. Dr. Sridhar, are you here with us?
I'm here. Can you hear me?
Yes, everything is excellent.
Great.
You can share your slides
Okay.
from your side.
See if I can. I've also sent. Oh, here we go.
Yeah.
Oh, are you able to see the slides right now?
Yes.
Okay, perfect. So maybe what? Okay, amazing. I can see them too. And then, yeah, and then to advance, I'll just click to the right if that works. Excellent. So thank you so much for inviting me to present today. Are you seeing it on presentation mode as well?
Yes, Dr. Sridhar, it's great. It's just, could you please share it like in a full screen mode?
Let me see if I can do that.
I think you can enable editing and then make it full screen.
Okay.
Yes.
Editing. And then let's see if this will work like that. Does that work?
I think yes, and you can share it once again.
Oh, okay. Let's see.
Yes, I guess you can share it and then make it full screen.
Okay, let me see if it it unshared itself. 1 second. Sorry about that. Okay, that's the window.
It's okay.
Let's see if I can do this. It's trying. Is that sharing now?
Yes.
Okay.
Yes, it's great.
Great. Okay. So I will get started. So thank you so much for inviting me to be part of this session on how I treat bladder cancer in 2026. I'm going to focus on metastatic disease and give us just a sense of how we got to where we are. So bladder cancer is the 6th most common cancer in the US, about 84,500 new cases and 17,000 deaths. So 4th most common in men and the 8th most common in women. And we don't fully understand that. At one point, we thought it was maybe related to smoking, but those rates have not really been the main reason. So we're trying to understand that a bit better. The average age of diagnosis is 73, which means these patients can be quite unwell. They can have comorbidities, which can not only affect their ability to handle the illness, but also the treatments we want to give them. The ratio men to women, 3 to 1. Key risk factor is smoking by far. And it's surprising me always how little people are aware about that. We know the other risks of smoking, but certainly not bladder cancer. And I think we need to do a better job in that area. Histologically, these can be urothelial, pure or mixed, and sometimes you can get pure variants. The challenge with pure variants is the fact that these are often excluded from clinical trials, so we don't really know what we should be doing. Sometimes we extrapolate from the mixed situation, but I think this is an area that we really need to focus on. One of the most important components of bladder cancer is depth of invasion into the bladder wall. Is it just on the inside, or is it moving in through the wall and beyond? And that's always a critical consideration. Urothelial cancer, of course, can arise anywhere along the urothelial tract from the renal pelvis to the ureter and down to the bladder. Non-muscle invasive, in terms of invasion into the bladder wall, non-muscle invasive disease is the most common at 70%. Muscle invasive occurs in about 1/4, and metastatic disease at presentation is about 5%. And it's important to note those patients who have muscle invasive bladder cancer are at very high risk for subsequent development of metastatic disease. From a staging standpoint, we typically use cystoscopy and a transurethral resection of the bladder tumor. a CT scan of the chest, abdomen, and pelvis. And that's important because some of these patients, as I mentioned, may be smokers, and they may be at risk for other primaries, such as primary lung cancers. And we certainly have found that from time to time. Understaging, however, is a major issue and can lead to suboptimal treatment. So what I say is often what you see is not what you get. Novel imaging approaches may improve detection of disease outside of the bladder. Things like PET, MRI, and other imaging studies are currently underway. So when we think about metastatic disease, the most common sites are lymph nodes, lung, and bone. First-line treatment forever has been cisplatin-based chemotherapy, but that has changed. The challenge with that is really that response rates were high, around 45 to 50%, but cure rates were low. Most patients inevitably had disease progression, and other candidates were just not considered candidates, and they were labeled as being cisplatin ineligible. So when we look at the criteria, the Galsky criteria were initially developed many years ago, and it was it aimed at bringing some homogeneity to this group of patients who were considered cisplatin ineligible. It looked at criteria such as performance status, creatinine clearance, pre-existing toxicity, and cardiac status. But these criteria do exclude a large number of patients from receiving cisplatin-based chemotherapy, and we've really gotten a lot better at giving platinum-based chemotherapy. On the right, we developed some criteria really to broaden the eligibility for cisplatin-based chemotherapy. And probably the most important aspect of this criteria is we allowed patients who went down to a creatinine clearance of 50 to receive cisplatin-based chemotherapy, often delivering that in a split dose fashion. So Gemcis day 1, Gemcis day 8, instead of Gemcis on day 1 with a big dose of cisplatin on day 1, followed by Gem on day 8. So these have been some modifications to help in the delivery of cisplatin. But we've certainly seen a very rapidly changing landscape in metastatic urothelial cancer after about 2016. You can see initially we had cisplatin, MVAC, a number of other compounds. And then in 2016, we saw the introduction of the immune checkpoint inhibitors, 5 in total. And so a whole bunch of them, slightly different PD-1, PD-L1 inhibitors, that group of drugs. 2019, we saw erdafitinib, which is an FGFR inhibitor, and then enfortumab vedotin, which is an antibody drug conjugate targeting Nectin. 2021, we saw the use of avelumab maintenance and another antibody drug conjugate being evaluated called sacituzumab govitecan. And then in 2023 was probably one of the biggest years for the field, where we saw gemcitabine, cisplatin, and nivolumab do better than standard platinum-based chemotherapy. And similarly, enfortumab vedotin and pembrolizumab also did better. So I think we saw this huge explosion of new therapies starting from 2016 or so. So let's stop for a second and think about immunotherapy. Really not a new concept in this disease. We've had BCG for a very long time. The goal of immunotherapy is really to train the immune system to attack the cancer. And why is the immune system potentially important? Well, it offers specificity. So it has the ability to recognize infinite antigens, maybe on the surface of the tumor cells, adaptability based on tumor genetic and epigenetic changes, and it's got memory. The hope is that you'll have durability of response even after you stop giving the drug, which means that you may not be incurring the side effects, but you may still be having the benefits. And bladder cancer may be particularly susceptible to immunotherapy-based approaches because there's a high rate of mutations within the cells, and that may change what's happening on the surface of the cells and allow them to be better recognized by the immune system. We've also learned a lot about the cancer immunity cycle over the years, and we can really see that there's different aspects of the immunity cycle, either alone or in combination, that can be targeted. And this has been really utilized across the spectrum of oncology, where different drugs seem to maybe have different benefits. What's interesting, we're very focused on having biomarkers. In this case, PD-L1, though, has not been a great biomarker, so it's really not used in the metastatic setting to determine treatment. And, early studies suggested that maybe, it was heterogeneity of expression of PD-L1 or there were archival specimens. We're not really sure, but we don't depend heavily on PD-L1 for this reason. So as I mentioned, first-line platinum-based chemotherapy had been the game for many, many years. And in many places, it remains the standard of care just because we're waiting for approvals and funding of novel treatments. Remember, the overall survival is only about 14 months. PFS is 7.7 months. Response rates 40 to 60%, but durable responses are rare. And not all patients are cisplatin eligible. In the cisplatin refractory setting, we saw the introduction of pembrolizumab. This is based on the KEYNOTE-045 study that showed about a 3-month improvement in survival. You can see the yellow line doing better than the purple line there. So pembro became the standard of care in the platinum refractory setting. 5 other immune checkpoint inhibitors, as I mentioned, have already shown efficacy. But it's important to remember that only about 20% of patients will have disease response. So this really drove the ongoing development of novel treatments in the field. These drugs were also tested in the cisplatin ineligible setting. So these are patients who couldn't receive cisplatin-based chemotherapy. And you can see the response rates of about 29% for pembrolizumab upfront and about 23% for atezolizumab. But those numbers are a little bit lower than platinum-based chemotherapy. So the thinking is if you can do platinum-based chemotherapy, that should be the goal. It's also important with immunotherapy to be aware of the immunotherapy-related toxicities. They can affect multiple organs. Skin, gastrointestinal, and endocrine are by far the most common. You can get more rare toxicities as well, inflammation of the heart, liver, and neurological side effects as well. So it's really important that when we treat patients with immunotherapy that they are encouraged to report symptoms. And steroids have been used quite frequently to manage these symptoms and quite effectively as well. What about combining chemotherapy and immunotherapy or dual immunotherapies? Well, the initial combination strategies, as you can see here, were disappointing. We saw a number of studies, Danube, which is dual immunotherapy, Checkmate 901, the first version of Checkmate 901 looked at ipi-nivo, and then a couple of the other studies, IMvigor, Keynote, we're waiting for Nile to report, but the combinations didn't give us what we were hoping for. Now, what about sequencing chemotherapy and immunotherapy? We saw the introduction of the Javelin study here, where patients who had locally advanced disease got upfront platinum-based chemotherapy and had a good response, complete response, partial response, or stable disease were randomized to receive avelumab or best supportive care. And I'll note here, avelumab is given indefinitely. And you can see the survival showed about a 6-month, give or take, maybe a little bit more, 6 to 7 month improvement in overall survival. So this really became the standard of care for a long time. Some of the questions that came up were really how many cycles of chemotherapy are needed. And so this is where we were for a long time. And then what about chemotherapy and immunotherapy? The antibody drug conjugates, I think, have really taken the field of oncology by storm. And one of the first places where that happened was really in urothelial cancer. And so this was an antibody drug conjugate, 3 components. One is the antibody to something expressed in the cancer. You have the linker molecule, and then you have the cytotoxic agent. That's the chemotherapy. A number of them here listed to the right, enfortumab vedotin, sacituzumab govitecan, and disitamab vedotin. They have different antibodies, and they also have different chemotherapy backbones. Enfortumab vedotin, of course, one of the first ones to be evaluated. It binds to nectin, which is expressed on the surface of bladder cancer cells. In fact, expressed so widely that we stopped testing for that in the early studies looking at this drug. The drug is then internalized, and then it targets, the chemotherapy component targets microtubules. And we know targeting microtubules are somewhat effective because the taxanes have been used in late-line bladder cancer for a long time. The EV301 study, this was a 3rd-line study. Patients who've had a prior platinum, prior immunotherapy were randomized to receive enfortumab vedotin, or EV for short, compared to chemotherapy. The objective response was significantly better with EV, 41% versus 18%. And this is the first time we got really, really excited about this drug. Progression-free survival favored EV, and the hazard ratio was encouraging as well. So the FDA approved this drug in the post-chemo and post-immunotherapy settings. There were no new safety signals, but the ones of interest include skin reactions, sometimes severe, including Stevens-Johnson syndrome. You could get peripheral neuropathy, was something that we had to watch closely and consider dose reductions, and this hyperglycemia that came in patients who may not have had a prior history of diabetes. And when you look at the skin toxicity, it's shown here. The key things to keep in mind is if patients are complaining of skin pain, systemic symptoms, there's a risk that this could be Stevens-Johnson syndrome, and this needs to be treated as a medical emergency. Some of these patients need to be treated in the burn unit, and there's a high risk of mortality. So it's really, really critical to be aware of this and not to just dismiss toxicity involving the skin with this drug. It's also important to note that dose reductions are extremely common with EV. In fact, when we did the phase 1 study, we did see responses at lower dose levels. So that maybe gives me a little bit of comfort in dose reductions. And I think some of the side effects, including the neuropathy, can be really problematic in the long term. So managing that early and aggressively is going to be important. Certainly dose reductions are one way of doing that. And as you can see here, many patients do have a dose reduction at some point. What about the other antibody drug conjugate, sacituzumab govitecan? Well, this targets TROP2, and it's a topo 1 is the chemotherapy. This is the phase 3 TROPiCS-04 study, and interestingly here, you see that it failed to improve overall survival compared to the comparator arm. And there were several reasons suggested for that. One could have been toxicity. Many of these patients had neutropenia. And it really highlights that our bladder cancer patients are at risk for infection. And so perhaps we need a lower threshold to use GCSF or those type of medications. The control arm here, the taxane maybe performed better than we expected, although we have seen the taxanes show reasonably good results in that second-line setting. And then the other thought was that the post-progression access to agents was different, and that could have impacted here as well. So this drug does have some activity, but the phase 3 study was negative. What about chemotherapy and immunotherapy, looking at FGFR targeted therapy? So one of the exciting things about urothelial cancer is we've had immunotherapy with antibody drug conjugates, and we've also had targeted therapy enter the field. So about 15% of patients overexpress or have alterations in FGFR2 or 3. When the FGFR3 or fibroblast growth factor binds to its receptor, it signals the cells to divide. So erdafitinib is a drug that blocks this receptor. It's given orally, and it's often used in the third or fourth line to try to reduce the growth of these cancer cells. There was a Thor cohort 1 study. This had a median follow-up of 15.9 months, and you looked at a comparison of erdafitinib versus chemotherapy of choice. Median overall survival 12.1 versus 7.8 months, hazard ratio 0.64. This study was stopped early and unblinded. So studies are either stopped early because they're very good results or very poor results. So in this case, the objective response rate of ERDA was above 45% as compared to only about 11% for chemotherapy. So very, very encouraging in this setting. Then you had cohort 2, which actually moved erdafitinib into the earlier setting and compared with pembrolizumab. And although erdafitinib did have better objective response and PFS, the primary endpoint was not met, and median overall survival was not better. So it really tells us it's super important to do clinical trials to really understand where in the therapy these treatments should be offered. Erdafitinib also has a number of toxicities, including nail changes, which can be chronic, and over long periods of time, this can be really problematic, eye disorders, and diarrhea. The toxicities, again, need to be managed carefully with dose delays or dose reductions. There's a number of newer agents that are trying to minimize some of the toxicities, including things like hyperphosphatemia. And then what about combinations that maybe did work well? It seems that the partner may be important when we're combining chemotherapy and immunotherapy. So this was a study looking at nivolumab plus gemcis, and it's important to comment here that it was gemcis and not carbo. The previous combination studies that were negative allowed either cis or carbo, and since cis and carbo are actually different chemical compounds, their ability to combine with immunotherapy may also be different. So here's the study design for Checkmate 901. This is a sub-study. Gemcis Nivo in the one arm compared to Gemcis in the other arm, the primary endpoint overall survival. And you can see here that the Nivo Gemcis arm did do better, 21.7 versus 18.9 months. And objective response, you can see as well, patients who had a complete response, the duration of that was 37 months. And I should highlight that treatment in these patients, which involved the combination, ended at 24 months. So there was probably about a 12 to 13 months when patients were off treatment and enjoying a benefit, which I think is something we need to really think about, this whole concept of treatment-free interval, because treatment-free also likely means side effect-free. Now, what about the other key study, EV plus Pembro? You know, there's probably several rationales for why we want to combine EV and Pembro. They're both slightly different drugs and have shown to work together synergistically. So they were initially tested in the EV-103 study that really took patients in the frontline setting who were cis ineligible. And they were treated with EV Pembro. And this was probably some of the most exciting data where we saw the confirmed objective response rate sitting at around 71% or so, which is the highest we'd seen ever before. This led to the approval of EV Pembro in the setting first-line cisplatin unfit, and then set the stage for the EV-302 study, which really took patients frontline setting. They got EV Pembro in the one arm or chemotherapy, either Gem-Cis or Gem-Carbo in the other arm. Dual primary endpoints, PFS or and OS, sorry. You can see here a very clear difference between those curves, 12.5 versus 6.3 months for the PFS. Hazard ratio 0.45. We've never seen hazard ratios like this before. Again, overall survival 0.47 hazard ratio in favor of EV plus Pembro, and the objective response rate 67%, with a very, very relevant 29% having complete responses. So this was clearly superior to platinum-based chemotherapy in the frontline setting. Treatment-related adverse events, we can see here, those leading to death included asthenia, diarrhea, immune-mediated lung disease, whereas with chemotherapy, you had more of the standard toxicities such as febrile neutropenia. Median number of cycles was 12 for EVP versus 6 for chemotherapy. And it's probably an important point to note when I'm treating my patients with EV Pembro in the frontline setting, I'm finding by around 6 to 8 cycles that they are developing neuropathy and are having some challenges. And sometimes I end up having to drop the EV after dose reductions. And that helps me to continue on with the treatment. Treatment-related adverse events of special interest, neuropathy, as I mentioned, skin disorders are important to keep in mind, and hyperglycemia as well. So this was the first time that platinum-based chemotherapy had been surpassed in such a significant way, we would say. It showed a statistically significant, clinically meaningful improvement in efficacy over chemotherapy. And the safety results were manageable. So this is sort of how I see the current management. Frontline metastatic disease really would be EV Pembro, and anyone that can potentially receive it, I think the response rates are really, really very good. And then at the time of disease progression, we're now sitting with platinum-based chemotherapy, but we do have a number of trials ongoing in this setting to see if something can beat platinum-based chemotherapy in that context. In some jurisdictions, EVP may not be available, so Gem-Cis-Nivo is a reasonable approach, especially in node-positive disease. It seems to do a pretty good job. And then in patients who get upfront sort of platinum-based chemotherapy, at the time of disease progression, we look at pembrolizumab. In patients who have response to frontline chemotherapy, it would be avelumab, but these are all in jurisdictions where EV Pembro is not available. That should be the frontline standard based on the totality of the data that we have so far. So to conclude, it's been a very exciting time in the field of metastatic urothelial cancer. New agents are now entering the first-line setting, but the question then is, what do we do beyond? Very encouraging data, and maybe we'll even cure a few patients with metastatic disease, and I think that's a reality. Toxicity management will be of critical importance. Sequencing will also play an important role. There's a number of studies exploring de-escalation approaches, targeting oligometastatic disease, and when, if, and as we've seen, this regimen moves into the MIBC setting, what implications does that have for the first-line metastatic setting? And I think major collaborations on all levels, industry, academic institutions, and patient groups has largely led to the incredible progress we've seen in this disease. And that's it. I thank you for your.
Okay, Dr. Shithar, thank you very much for your presentation and the valuable perspectives. And we have a question from the audience. So the question follows: with new first-line standards changing rapidly in metastatic urothelial cancer, how do you approach sequencing when the best first treatment may limit or reshape all later options?
Yeah, I think that's a great question. So I mean, I think it's always assessing the patient in their entirety to begin with and see how they're doing and how they're tolerating things. My first line, if it's going to be EVP in the frontline setting, usually I will think towards something like platinum-based chemotherapy in the second line setting. But there's some scenarios where, for example, they have an isolated lung metastases or limited progression of nodal disease, when what I might try to do is to radiate or target that oligometastatic disease so I can delay the time to starting second line treatment. I think the other thing is I really try to look for clinical trials because we've gotten to where we are through clinical trials. So I think that if we can do a trial in the second line setting, we may be able to establish a new line of treatment in the second line setting. So it's kind of moving everything down a little bit, but it's thinking through and maybe getting other services like radiation oncology or surgery involved. So we're not just thinking about systemic treatment, but we're thinking a little bit outside of that box.
I see. Thank you very much for the great answer. And once again, Dr. Sridhar, thank you for your time and for your presentation. And moving on with our program, I would like to inform that after a short break, we will move to our panel discussion and we will conclude our scientific program with our final panel discussion, the future of bladder cancer care, innovations, challenges, and global perspectives. And the discussion will include interactive conversation on the evolving landscape of bladder cancer management. And we warmly invite all participants to stay with us for this exciting and thought-provoking session. And also I would like to mention that the panel discussion will be opened by Dr. Petros Grivas, a professor at Fred Hutchinson Cancer Center and the University of Washington. So stay with us, and now we'll go to a short break.